அது டூ வந்து அவங்களுக்கு ரெண்டு கார்டு இருக்கும். சரி ஓகே கேக்குதா? ஹலோ செக் செக் 1 2 3 ஹலோ செக் செக் கேக்குதா? பேசுங்க.
வீடியோவே ப்ளே ஆகும்.
பேசுறது ஸ்பீக்கர்ல கேட்குது. கேக்குது bro. இப்ப இதுல பேசுறது கேக்குது. விட்டு விட்டு கேக்குது. இதுதான் இல்ல இல்ல. இப்ப கனெக்டே பண்ணலையே. ரெண்டுமே பேசும். கனெக்டே பண்ணல. சரி கனெக்ட் பண்ணல. மெயின்டெனன்ஸ் தான் கேட்கும். ஒரு இது இருக்கு. மெயின்டெனன்ஸ் கால் பண்ணலாம். மெயின்டெனன்ஸ் கால் பண்ணலாம். ஓகே. அதுக்கு இது இருக்குல்ல. இல்ல வாய்ஸ் ஐஃபை. யா யா. Applied using a point. Apply USB. The USB on the download. வர வரைக்கும்
exchange. I want to welcome all delegates and faculty who gathered for the inauguration of lung cancer clinic, followed by lung cancer clinic update masterclass.
Volume is
The session commence with the invocation song. We all can stand up for it. Dr. Jayaraman, you welcome again.
Very good morning. Warm greetings from Indian Healthcare. Welcome to this lung cancer clinic inauguration and the masterclass on lung cancer. Respected Director of Medical Services, Dr. Paisa, and respected Director of Medical Service, Indian Cancer Institute, Sivasar, and Director of Medical Oncology Services, Dr. Radiotherapy, and all the senior consultants and MGM family. So, very good morning to everyone. Now we are going to inaugurate the lung cancer clinic. You all know very well, lung cancer incidence prevalence rate is very, very high. You take the world scenario, the lung cancer is the #1 cancer in the world, both men and women. In Indian scenario, this is the second and fourth leading cause of morbidity and mortality in men and women. So, in our NGM Cancer Institute and NGM group of hospitals, we are going to start first kind of preventive prostate oncology program, that is lung cancer clinic. Mainly, we focus on the screening and early detection, diagnosis, and treatment of all prostate malignancies, including metastatic tumor, lung tumor, and the pleural tumors. We have expertise and all the facilities available in the center, starting from the basic PFT, pulmonary function test, to the advanced bronchoscopy like endoscopy, ultrasound, and we have a variety of medical oncology, surgical oncology, and thoracic oncology services. So in this center, this is a full-fledged state-of-the-art operation theaters for thoracic oncology and all the other departments supporting team. Everybody is there. So this is a golden opportunity. In India, as far as the lung cancer is concerned, there is no awareness problem. So Western world, they have a high awareness, lot of tobacco smoking. Here, not only apart from tobacco smoking, the air pollution plays a major role in causing the COPD and lung cancer. So we're going to form the periodical program for the general public as well as the doctors along with the IME. So NGM family is doing a lot of human service to the IME doctors and the general public. We do awareness walkathon, lot of programs for the public to create awareness. So awareness is the important thing. Then only we know that we can come to the hospital and screen early and detect early and cure early. As far as the lung cancer is concerned, lung cancer is the completely preventable, treatable, curable disease if you detect early. For that, awareness is a very, very important thing. Anyway, it's a challenging one. So we are starting the program, Lung Cancer Clinic. I need all your supports and the online viewers. We need your support from pioneer level. So with that, thank you very much. So God bless everyone. Thank you.
Thank you, sir. Now we call upon Dr. M.A. Rajan, sir. Dr. Jayaraman, sir. Dr. A.R. Gayatri, ma'am. Dr. Meenakshi, ma'am. Dr. Nalin Jayanti, ma'am, for the ceremonial lighting of Dr. Shweta, ma'am, please. Dr. Shiva, sir, as well. Please join us. Anil Pai, sir, has
কেউ বেশি লাগবে কোথায় লাগবে बटन बताओ बताओ अच्छा पेश करो
Jayaraman sir, for the unveiling of the lung cancer clinic board. This marks a significant step in our commitment to advancing lung cancer treatment. There are no feelings of lung cancer of the past with us, Dr. Jayaraman.
A very good morning, everyone. So we'll start the scientific session of this day. We have 8 sessions, few housekeeping rules, everyone. There is official break for lunch 1 to 2. In between, coffee, tea, snacks available all the time in the atrium. Can go and come back. I request everyone keep your mobile phone on the silent mode. So any queries you are going to ask, kindly use the mic. This is a hybrid meeting. So use the mic. Is always ask the question to the chairperson or the speakers. So with this view, we'll start the scientific session, masterclass on lung cancer. So first session, may I invite the chairpersons of the session, request the housekeeping people, put the chairs in the side. There are 3 chairs, you have to put inside. Ibrahim, kindly coordinate. May I request the first chairpersons of this session, Dr. A.R. Gayatri, coordinator and senior consultant, Department of Respiratory Medicine, Apollo Hospital. Welcome, ma'am. May I request Dr. N. Nalini Jayanti, ma'am, professor and head of the Department of Respiratory Medicine, SRM Institute of Science and Technology, Chennai. Welcome, ma'am. May I request other co-chairperson, Dr. M. Swamikannu, sir, senior consultant and director, Department of Internal Medicine and Allied Sciences, MGM Healthcare. Welcome, sir. So please chair the session. In this first session, we have a first speaker, Dr. Jovita Martin Daniel, senior consultant medical oncologist, MGM Cancer Institute, Chennai. Welcome, ma'am. Today's topic first session is the lung cancer epidemiology and problem statement. Over to Dr. Jovita Martin. Thank you.
Morning, one and all. At the outset, I would like to thank MGM and the administration for this opportunity. And I wouldn't do justice if I don't thank our beloved director, Dr. M.A. Raja, who's been always a very encouraging person. And he actually, never lets down anybody, and he always supports. I'm very grateful to him. And I'm very thankful for Jayaraman sir for such a meticulous arrangement and organization of this meeting. I hope that you'll be able to do much more than this in the future. So I'm going to talk on lung cancer epidemiology and the problem statement. This is my disclaimer. These are my contents. I'm going to speak a few words on the statement that was given by the Union of International Cancer Control and the American Association of Cancer Research also. So lung cancer is represented by this white ribbon. Okay, now this is in honor of one Hidi Onda, who's actually a fitness trainer, health educator, and a lung cancer survivor, and an advocate who founded the White Ribbon Project. So he himself is a survivor of lung cancer. Looking at the Globocon data, in 2020, we found that breast is a leading cause of cancer, 11.7%, which is about 2.26 million cases. Right after that is lung, which is 11.4%, 2.2 million. And number of death also, amongst the 10 million people who died of cancer that particular year, we found that lung cancer attributes to about 18%, which is actually a very staggering value. And we also see that in 2018, the diagnosed number of lung cancer was 1.6 million. In 2022, it rose to 2.21 million. If we look at the trend of increase, it's very constant, steady increase in the last probably a decade, 2004 until 2020. If you see the age group, it starts with 20 years up until about 75 to 80 years. So very clearly, there is a rising burden of cancer from 13.92 lakh cases in 2020. The estimated extrapolated data gives us a value of 15.7 lakh cases in 2025. And in India, 2020, 5.5% of the cases, were the new cases contributory in cancer in terms of lung tumors. The ratio between the males and the females, always there was a skewed picture, males with the predominant numbers. The maximum was always seen with Turkey, Croatia, Black Americans, Lithuania, and France. And if you would look at this 2020 data extrapolating to 2050, in 2020, the estimated was 1.21 million new cases. The death rate was 1.09 because of lung cancer. But in 2050, the expected number of lung cancer cases was 2.64, and the death rate is 2.38 million deaths. So this is actually a very scary number that we are actually looking at. So it must awaken us to the reality of the situation. The first 10 countries, top 10 countries with the highest rate of age standardized death rate were Hungary, the maximum of 43.54, Serbia, Turkey, North Korea, China, Poland, Bosnia, Montenegro, Croatia, and Macedonia. And India ranks 117 in this list with a age standardized death rate of 7.82. Now let's look at the cause. Just as how Jayaraman sir previously mentioned, we always talk about tobacco, which is probably 80 to 90% of the cause in a lot of the developing countries. But there are many other things that we have to look into. The secondhand smoke, passive smoking, radon gas, which is actually found in buildings and homes, and we are not even aware of it. The Environmental Protection Agency has set a mark for it as 4 picocurie per liter of air. And any place where the level crosses 2 picocurie per liter, an intervention has to be done. Previous lung diseases, like for example, COPD or asthma, bronchitis, emphysema, pneumonia, tuberculosis, all of these patients have a tendency for a higher chance of lung cancers. Occupational hazards like exposure to silica dust, diesel engine exhaust, arsenic in either soil pollution or water pollution or air, indoor-outdoor air pollution, and family history. When we say family history, how can lung cancer be portending any kind of risk in the family? Actually, they have alluded to in research database that the EGF pathogenic variants has been located. So those who've got that pathogenic variant have a higher penetrance towards the family and the kindred. Radiation exposure and some organic chemicals as well. Some other factors that people who consume more of red meat, processed meat, and alcoholic drinks also have a higher risk for lung cancer. In current smokers and former smokers, consuming a lot of veggies and fruits a lot of beta carotene and carotenoids based food, and those who have a lot of vitamin C, isoflavones, have decreased risk. Being physically active also counts for a risk reduction. Now, this is the picture of the pathogenesis. What happens if when a vehicle combusts, or a factory effluent, or maybe a coal burning in the house, or a volcano? The particulate matter enters directly into the alveoli, and there will be an oxidative damage, a low-grade chronic inflammation, which leads to a lot of molecular changes, either DNA adducts or gene mutation, tumor suppressor gene silencing, transcriptomic changes, changes in the non-coding RNAs, apoptosis and inhibitions. Now, all these molecular changes can occur in any cell, like, for example, the pulmonary and neuroendocrine cell, or a bronchoalveolar duct junction, or a ciliated basal progenitor cell. So based on from which cell the changes take place, accumulative mutations will eventually lead to cancer. And this is basically a sequential process, a multi-step carcinogenic process, starting from initiation, promotion to progression. It would easily take 15 to 20 years. And this is the, the illustrated version of this multi-step process. We all must be knowing about the vaping. Now, this is in vogue. A lot of young boys and girls are into it. In the schools and colleges, they use e-cigarettes, and they think it's better than cigarettes. So basically, if you look at the e-cigarettes, it has a mouthpiece, a cartridge, an active light, and a battery. So the moment the battery is on, the cartridge happens to have this nicotine derivatives, polycyclic aromatic hydrocarbons, heavy metals, and aldehydes. So on with a lot of flavorings as well. So on pyrolysis and complex organic reaction, there will be a transformative cytotoxic activity, and these chemicals can be carcinogenic. But what happens here is a lot of people think that as a stopgap, or maybe to prevent, to quit smoking, e-cigarettes will help them. But on the contrary, the MD Anderson, Dr. Karen Hugh has alluded to is that sooner or later, if somebody resorts to the e-cigarettes, they are going to go back to cigarette smoking. So it's actually of no use. And also another point to be noted is we have a given data, a given lag time with the products of tobacco, and we know that it will take 15 to 20 years. But we have no data whatsoever on e-cigarettes. And we're not sure what's going to happen eventually in the years to come. So it's better that we have a tighter control and regulation of these products. I'm sure many of us are watch movies. And I actually, for one, like this movie because Kalangat Talaivan by Udayanidhi Stalin. This movie, the two characters were casted, that is Thiru and Gandhi. Actually, they have alluded to is the Vaidya is an industry where a lot of the employees who were working in that particular place, many of them started dying of different sicknesses because of the pollutants in their factory. So this is deciphering it and exposing it, and finally he happens to win that war. I think if anyone has time, can watch this movie. Now, this is an article by the NIH, which is published in 2023, September 1. Speaks about the relationship between outdoor air pollution by fine particulate matter and breast cancer incidence, which is actually very scary to note, actually. And they also have stated that the State of the Air report says 137 million people are living in places with failing grades of unhealthy levels of air pollution. And we see that the particulate matter is nothing but these small, tiny little droplets with some small solid particles, which are released from the combustive processes, from the vehicle exhaust, from wood smokes, from vegetation smokes, and from industrial emissions. So these ones are so tiny and they are so easily, breathed into any system that it crosses the bronchi, the bronchioles, the terminal bronchioles. It goes right down into the alveolar sacs, the 23rd generation, and it can easily, in any point, in any place, it can deposit itself and start off the rigmarole of the molecular reactions. Therefore, the Environmental Protection Agency has come up with a website which is called as the air now, which is in the US, that they can actually enter in their PIN code and get the number of the particulate matter 2.5 levels, which is actually a very good initiative. But I wonder where we stand at this point and when all this will happen in our country. This is yet another article by Alexandra White. She is from the Environment and Cancer Epidemiology Group. And this article was published a few months ago, which says that there is an 8% increase in the breast cancer incidence for living in areas with high particulate matter 2.5 microns exposure. So they also have alluded to is that the higher incidence of the estrogen receptor positive breast cancers because of the fact that it has biological pathway of endocrine disruption. This is the third article, which is published in 2022 in Cancer Epidemiology Biomarkers, illustrating the fact that increased risk of breast cancer is present with air pollution, especially with traffic-derived air pollutants. And it causes gene by air pollution interactions. And something very intriguing about this is it causes not just this, EGFR mutation alone or ALK mutation alone. It causes uncommon mutations, multiple mutations, which will lead to a complex and a compound presentations. So the same person will have an EGFR mutation and a ALK mutation. So basically, we have all learned that it is mutually exclusive. But all kinds of permutations and combinations of presentations in terms of mutations happens because of this kind of pollutants. This is a fourth article which is published in China, a very recent one, to 2019. And they have done a study on Zuanwi and Fayuan. Here, the ladies always, spend their time cooking, considerable time indoors preparing food using coal emissions. They live the traditional agrarian lifestyle. And what happens here is they use this bituminous smoky coal, which is very rich in ash and sulfur content. So basically this substance is like tar and asphalt, and which is used for laying the roads and roofs. So they are so smoky, and the women who are exposed to this kind of smoke ever since their childhood, they are at a higher risk. And more than 125 cumulative tons of smoky coal, a person is exposed to is at a risk of 1.42 times. This is a fifth article published in Spain, which talks about the pavement material which we use on the roads, right? So that they have analyzed that the soil, the urban soil, consisted of high levels of potentially toxic elements like lead and arsenic. And they are so prone to oxidization. Basically, for the first time, they came up with this arsenium, plumbojarosite, and budantite, which is the one which captures these elements, retains it, and then exposes it, which means anybody who walks on the road also will be at risk. This is another article from China. It talks about soil pollution, agricultural soil by polycyclic aromatic hydrocarbons. And it also gives conclusive statements of two other important points, stating that the poor people are more at exposure in comparison to the richer ones, because these guys, they don't use any protective products. And meteorological elements such as transport, the air, wind speed, the diffusion, accumulation, and sedimentation of air pollutants also will determine the occupational hazards. Diesel exhaust and crystalline silica, these are actually banned because they are class 1 human carcinogen. The sobering reality is that it is banned by North America and Western Europe, but the sad thing to note is in developing countries, also in India, we use it extensively. Like, for example, crystalline silica is used for installing the stone countertop materials for household use and sandblasting of denim for fashion wear. All this is used extensively in our countries. So this needs to be looked at. And this is another article by Turn et al. As well as Abhishek et al., which is alluded to the different kinds of pollutants, especially the agricultural soil, because of fungicides, pesticides, insecticides, and so on. This is a Bollywood movie, Irada. I do not know how many have watched this. It was released in 2017. A very interesting movie where Nazaruddin Shah's daughter, he's an ex-army man, and he has his daughter who is trained to be a international national and international swimmer. So she's such a talented girl, but eventually what happens is just before qualifying, she develops lung cancer and he loses his daughter. Then he starts probing into the matter and sees that the thermal power stations, which is beside them, where she was swimming and learning to swim, was the main cause, which caused cancers in several families and many people died. And finally, he won that particular war. Looking at the air pollution statement by WHO and IARC, it's a very clear and a very perfect statement that they have released. Not a single one of the world's 100 biggest cities meets the WHO air pollution guidelines. 99% of the world's pollution is exposed to air pollution. So that's a very, very staggering statement that they have, they have published. And this also includes the indoor pollution in our own domestic purposes, the things that we use, the cleaning materials, the personal care products we use, the building materials, and the household customer products and tobacco smoke. The other statements that they have released is not only leads to lung cancer, it leads to many other cancers. It leads to short-term exposures where there'll be admissions for respiratory and cardiovascular events. Long-term exposures leads to cardiovascular and respiratory diseases with strokes. So about 6.7 million deaths per year is only because of air pollution. So the actions that we will have to take in order to reduce the air pollution, according to the WHO, will be very stringent pollution control policies, transition to renewable energy and public transportation through bicycling and walking, increase in green spaces, and implement waste management strategies. American Association of Cancer Research says this is something which needs to be noted, that it's not just lung cancer that we are looking at when we talk about air pollution and soil pollution. We're also talking about breast, liver, pancreas, and so on, when the particulate matter increases more than 10 microgram per cubic meter of the air. And also it says that the mortality rate increases with different kinds of cancers when the pollution increases. Like, for example, in upper digestive tract, we see that the mortality increased by 42%. Accessory digestive, like the liver, bile duct, gallbladder, pancreatic cancers, the mortality is increased by 35%. In breast cancers, the mortality risk is increased by 80% because of pollution. Lung cancer, 36%. An increased association of this particulate matter exposure leads to DNA repair function being impaired. Body's immune response is suppressed. There's more of inflammation and angiogenesis. And also it spoils the gut microbiota. This is another movie in the Hollywood, and this is one of my favorite movies by the lead actress, Julia Roberts. It's called as Erin Brockovich. She actually is the assistant to Ed, a lawyer, and she happens to find out that there is a big company called as a PG&E. And what these guys try to do is they kind of fudge the data which they got through the industry, and a lot of people die. And when they are asking explanation, these guys say, no, the chromium level is all under limits. I don't know how this happens. And they bribe and they hush up all the people. But many were dying. The hexavalent chromium levels was so skyrocketing high that, this was not even actually presented. So this Julia Roberts in this particular case, who, stars as Erin Brockovich, she happens to fight that case, find out all the evidence and expose it, and wins that war. Now, lung cancer therapeutics market size is hugely increasing. From 2022, where the US $28 billion was spent, in 2032, the number is supposed to be equal to $60 billion, which means that the lung cancer market size is actually on the rise. And the players that we see are AstraZeneca, Boehringer, Bristol Myers Squibb, Pfizer, Merck, and so on. And we have so many drugs in the armamentarium at this point. The EGFR third generation, the ALK, we have gone to the third generation, like the lorlatinib, alectinib, and so on. We have these immunotherapies like durvalumab, nivolumab, atezolizumab, pembrolizumab, and so on. And we see that the share of the market size was about 20% with North America, 15% with Asia Pacific, and Europe, another 15%. So in conclusion, I would like to say that the lung cancer survival rate has actually picked up because of the diagnostic methods that we have and the new drugs that we have got. It has increased from 21 to 25%, but it's not enough. And the low dose CT scans, which I'm sure the subsequent speakers will be alluding to, by the Nelson's trial has actually decreased the risk of mortality by at least 15%. And we also see that there is a fear that, the low dose CT is going to cause a lot of radiation exposure, but it is a wrong thought. Because if one CT chest is done, it is equivalent to 750 X-rays, that is 10 millisieverts. But if a low dose CT is used, then it is 1.5 millisievert, and the number of X-rays will be 113 X-rays. So basically, the dose of radiation is pretty low, and we are able to save a lot of people, especially those who are in the occupational hazards and those who have been taking a lot of tobacco for several years. People of color, that is the African Americans and the Africans in different parts, have more chance of mortality and poor prognosis in comparison to the white Americans. And 26% of the cases are diagnosed at an early stage when the 5-year survival rate is much higher, 61%. So this is the problem statement that we have. One is the extrapolated data shows a clear-cut increase in the incidence as well as the mortality in 2050. So we all have to be on the caution. And the most important thing that we'll have to interfere here is smoking. Prevalence definitely needs to go down in low and medium human development index countries like in India, and the pollution needs to go down. We need to have stringent monitoring mechanisms and stringent efforts to make sure that the pollution goes down. And Asia is expected to be the epicenter for lung cancer epidemic, and Africa is also on the rise because of the kind of developments that's taking place and the air pollution that is taking place. Thank you.
Thank you, Doctor. That was very interesting. The statement she brought up, and she told about the problem statement also. She had discussed about the etiopathogenesis also, and she brought up about 3 movies which I thought, okay, we have to discuss. She has brought up even the Bollywood movie from Bollywood and Hollywood. But she said this, the pictures are also showing about the lung cancer. What she was trying to say is, she has brought up and told about the lung cancer and the low dose CT screening which we have to do. And that has to invite the public, has to go there. The problem should not stay with us, only the pulmonologists or the doctors do. It has to reach the public also. So now that MGM has started a lung clinic regarding cancer clinic, the problem has to reach the public, and then we have to bring them in line, and again, smoking, pollution, all that we have to take care of. She talked about particulate matter, 2.5 microns and all that. So, and that also I'd like to thank the organizers for giving me this opportunity, especially Dr. Jayaraman, who was way behind me to see that I come here and chair this session. Thank you.
The staggering statistics told about the incidence of lung cancer. As a clinician, as any disease, we look at modifiable and non-modifiable risk factors. We all know there are definitely modifiable risk factors. We live in an era where there's air pollution, shutting down the schools, and the alternate reducing the number of vehicles that's going on in the country. We are all very aware of it. So we may progress in the field of treatment, but we should still concentrate on preventing these modifiable factors so that the lung cancer incidence come down. Instead of concentrating on the treatment part, prevention is better than cure. So emphasis on the prevention of lung cancer. We should concentrate, the government should taking enough steps. But you see, the number of vehicles released every day is increasing and increasing. there are no places to park the cars in the road. We have come to a state where the vehicles are increasing day by day. So we should concentrate on prevention too. Thank you.
Thank you, Dr. Jovita. This is an excellent talk. And I'd also like to thank the NTT for inviting me here to chair the session, especially Dr. Deeraman, who is very insistent that I come and attend. See, Dr. Jovita brought up a very important factor. All of us are aware that lung cancer, the main etiology is tobacco smoke, but something hidden and which is slowly creeping up and going beyond control is air pollution. And as Dr. Swami also mentions, coming on to very staggering levels now, and it's going uncontrolled. So I think we should also do some things, keep it under control, and we have more and more investigative modalities to diagnose lung cancer. Treatment area has also increased, targeted therapy, immunotherapy, and other therapies. And but prevention is essential now. I think we should also take equally some measures to make sure things don't go out of hand, and we shouldn't come into having malignancy as a top priority disease in the country. I think we have enough of things to deal with at the moment. I mean, I'd like to invite any questions from the audience, please.
Thank you, ma'am, for that beautiful talk. One point that I'd like to ask you is, you brought forth a point about low dose CT screening, and you gave statistics that the standard CT is equal to 730 X-rays and the low dose would be 130. What is the statistics regarding the actual appearances of malignancies due to CT scans? COVID has recently showed us that patients have had multiple CT scans, and then many of these patients are still under follow-ups. The point I'm trying to make is that over one side, the radiology associations are fighting for safety of CTs during pregnancy also. And we are talking to the patients about the number of X-rays that each CT would produce. So that sends out a very confusing message. So whether the dose actually matters, does it lead to malignancies if the patient is undergoing CT scans, or is it safe and we should not talk?
I think that's a very important question. And I would just say that we are going to offer this protocol for screening only for those guys who've been exposed to a lot of screening and probably occupational institutions. It's not be for us to predict or the board of others. Only those who have got types. So number two is it's a method to follow up to see how the nodules which are there, which we find in the screening, how it's going to evolve. That's what the Benson study has spoken about. 3D volumetric analysis. And if those patients are at high risk and need to follow them very closely, only then the treatments come. Of course, as you said, a lot of things need to be analyzed. The guidelines, the standardization in reporting, and what machines that use, and what will be the protocol we want these. So all based upon the risk that is there, what we want to see the first time. So I think that way is just about increasing the amount of those results.
Dr. Alex, I have a question. I'm about to speak. The amount of radiation with the low-dose CT scan, what is it exposed to? Whether it's millisieverts or what is the low-dose CT scan? What is the amount of radiation?
Yeah, the unit is millisieverts. Total CT usually 1.5 millisieverts. The regular CT they have 7 millisieverts of the radiation exposure. 1.5 and 7. 7 for the regular CT. Total CT millisieverts is 1.5.
Thank you for
Any questions?
Thank you for highlighting regarding most of patients, not only the cause of lung cancer, but also breast cancer. You said that breast cancer is high, mortality is less compared to lung cancer. Is it because it is really detected, whereas lung cancer is not detected? That is the reason for mortality being more because of the metastatic deposits, number one. And nowadays, people are aware because of lung cancer. But in spite of that, if you take the years by, it is being increased. It is increasing. But most of the people now, I think they have reduced smoking. But the thing is it because of the atmospheric pollution that the cancers are.
Here, civil perspectives that comes which more is that. So they do they apparently got got to exploit the manipulation that there's they have many things. So probably that's one of the reasons. The other thing is, as you say, it's easier to speak stress, but the lung goes unspeak because of all these factors that have in mind of cost and radiation. The next question that you asked is about the smoke in the red. That definitely needs to be reinstilled and the nicotine patches and other things that can help the way people get out of smoking. That should be encouraged. Probably when we speak to those people who are addicted, we may actually have some rewards. Probably they can set the reward for themselves. If they are going to save like 1,000 rupees, take a family for a movie, or go for a nice buffet and eat their family. That kind of small rewards, it will actually influence their willpower.
Yeah, thank you. I think we can give them a trip to Ayodhya and look at God now. I think that's best. But I think we've been talking about lung cancer screening for such a long time, 50 years, 60 years, 70 years. My question is, who are you going to scan? That's the question. You've talked about low-dose CT, you've talked about whatever parameters there are about low-dose CT. My question is, whom do you scan? Do you scan the entire population, or do you take a risk and talk about a high-risk population? How do you identify this high-risk population? What do you use? Do you use pyrometry to identify this high-risk population? Or you say, if you take so many number of cigarettes per day, your so-called cigarette volume, is that the criteria that you use? Or is the criteria dependent on age? Is the criteria dependent on comorbids at longer age? What is it really dependent on? Or is it blanket screening all over the board, across the board?
Just a comment that see proper air website, they can immediately track to see the details of the PM.5. We also in our country should come up with such things so that we know where exactly we need to interview.
Most of these questions that I've asked you come from patients retrospectively after being diagnosed with cancer lung. They come up with a question and say, can this have been found years ago? And I could have done something about it. And that's where the whole question of screening arises. And he picks up Google and hits Google, the first thing he will get is cancer screening. And the first person he will hit is you. And I think we need to have answers for these questions. And I think I agree that answers for these questions are not straightforward. Answers for these questions are not there, obviously, for everybody to consume. But the fact that us reviewing that I think as a cancer society, you need to come up with some sort of guidelines on the person that you're going to screen. Like what is the entity of the person that you're going to screen? Because I think this is the one that we as clinicians will be encountering over the period of time.
It's the point of this exactly this one. To screen for all the people, all the individual, all those thank you, Mr. Science. So more than exception. Before that, I request the chairpersons to be the phone to the speaker of Zomitama. Please come and accept the phone. Thank you, Dr. Subhash, for this wonderful presentation on epidemiology and common statement. So, putting all the Bollywood, and Hollywood movies around. Thank you very much. I request Dr. P.K. Tamasa to give the moment to our chairperson, Dr. Swami Kansan sir, Dr. Gayatri ma'am, and Dr. Nalini ma'am. Thank you, Dr. Swami Kansan, for the really good. 80% better than you. Yes. But Gayatri ma'am. Nalini ma'am. Thank you very much. We move to the next session. May I request chairperson for this session, Professor Dr. V. Gangadhar sir, Professor and HOD Department of Pulmonology, Savita College and Hospital. Welcome, sir. May I request the co-chair, Dr. Tilakuri ma'am, Senior Consultant Pulmonologist, Head of the Department of Respiratory Medicine, Vijay Hospital. Welcome, ma'am. May I request Dr. P. Sivaraj, sir, Senior Consultant Physician, Department of Internal Medicine and Allied Sciences, MGM Healthcare. Welcome, sir. May I request speaker for this session, Dr. Saumitra Sinharai, Senior Consultant Transplant and Introvert Pulmonologist, MGM Healthcare. Welcome, Dr. Roy. The topic of discussion today, this session is it a lung cancer or tuberculosis, a diagnostic challenge in a TB endemic country? Over to Dr. Roy. Thank you, sir. This one works? No. This does not work. This microphone does not work. Good morning. So, without wasting more time, let's talk about very mundane things, what we are going to talk clinical, whether it is cancer, TB, or something else, when you have similar looking confounding cases. So, TB is the greatest mimicker, and you must be knowing from the days when we entered the medical college, and we started from our teachers that anything can happen under the sun, like that. Anything can be mimicked by the TB. So due to unusual presentations and the lack of specific diagnostic tests other than a biopsy, patients with cancer have been misdiagnosed with TB. Though nowadays there are many other diagnostic tests, maybe liquid culture, etc., are there, but still the gold standard still remain biopsy and histopathology. Therefore, this confusing mass represents a substantial clinical problem while differentiating between cancer, TB, and the others. So the symptoms are, most of them are the same, both TB and cancer. In both these conditions, respiratory exam will be unremarkable, and the symptoms will be like productive or unproductive cough, chest pain, hemoptysis, anorexia, weight loss. The increased incidence of lung cancer with active infections and associated inflammation with PTB will be there. The other thing is also important. The active TB is seen with an underlying malignancy because of the immunodeficient status. Coexistent lymphadenopathy make the differential diagnosis even more complicated. It may be difficult to distinguish PTB and lung cancer clinically and radiologically, and especially when the MTB gene expert and repeated sputum tests for AFB are negative. So the points again are: fine needle aspiration cytology has got low sensitivity and specificity. We have presented kind of a paperwork on this on SPN, and we found out that high FDG uptake in high endemic TB endemic areas like us, the high FDG uptake on the PET CT scans can occur even in cases of TB infections, and PET negative lung cancer also exists on the other hand. Human markers such as CA19-9 and CA125 could be increased in TB patients also. ADA can be upregulated in cancer patients. Histopathological exam and TB cultures are still the gold standard for diagnosis. So I would just like to touch upon this PET CT for malignancy. PET CT is done. It's a fantastic tool. Sensitivity is around 90 or more than 90% with a specificity of around 95 to 96%. But the false positive to detect are there. So granulomatous infections such as TB, atypical mycobacterial diseases, endemic mycosis infections, which are more commoner in countries like us, will become falsely positive. Inflammatory conditions like rheumatoid arthritis and sarcoidosis also, recent surgery and hyperglycemia is important, other false positive things. False negative, if the lesions are less than 1 centimeter, minimally invasive adenocarcinoma in
situ, mucinous adenocarcinoma, and carcinoids can also be falsely negative. PET-CT is more sensitive and specific than CT, obviously in the lymph node assessment and also in the adrenal metastasis assessment. MRI brain need to be considered if brain mets is suspected. I will not go into details of this TB part. This is TB and this is lung cancers. We know all those, all our senior clinicians are here. But just wanted to touch upon this. The under National Tuberculosis Eradication Program, the acceptable methods for microbiological diagnosis of TBs are sputum microscopy. Though there is a part of a small part is there, the strong clinical history. That is also recommended for starting TB therapy, but it is better to have a microbiological diagnosis. So the culture, either LJ media or liquid culture media, rapid molecular nuclear testings like line probe assay, CBNAT or TrueNAT or UltraNAT, and then after the drug sensitivity testing as required. I would just like to talk about this GeneXpert Ultra, which is now the newest generation, which has come nested PCR cartridge used in the same equipment of the GeneXpert. Ultra has a lower detection limit of 16 bacilli per ml of sputum as compared to 131 for the GeneXperts. Especially useful for possibacillary disease like children, HIV, and TB co-infections. And Ultra may replace GeneXpert in near future. But the problem of GeneXpert or GeneXpert Ultra is these are very sensitive machines, cannot go out of AC rooms. In India, somewhere about 1,000 machines are there, perhaps some give and take. So to take the tests to the masses, to the villages, TrueNAT has been developed by Indian firm. It's battery operated, and though it is 2 steps, you need to first run the detection of MTB, and then you have to run the rifampicin sensitivity. So 2-step thing. It takes about 2 to 3 hours for the reports to come. GeneXpert or Ultra will come in maximum in 1 to 2 hours. So first step will be the DNA extraction and then the addition of the rifampicin. Lung cancers. The benign pulmonary nodules are more common in the young and in the non-smokers. Infectious granulomas make up to 90% of the benign nodules. A history of exposure is important in establishing a possible infectious origin, and different clues like the history, TB exposure history, skin test results, prior travel history, occupation, residence, and pets are invaluable in some stages. I would like to focus on that circle what we have got. Somewhere about 65% cases were detected in stage 3 and 4. And we know that though there are fantastic drugs now available, but still in advanced countries in stage 3B and stage 4, and the 5-year survival is dismal at about 10 to 12%. In India, it must be lower than that. The 5-year survival where it is maximum between stage 1 and stage 2, in those kind of scenarios, we hardly detect them. Only about 25 to 30% of the patients are being detected there. So our aim should be, again, focusing on detecting early, because if you detect before in the stage 1 and stage 2, the 5-year survival is somewhere about 70%. So that should be the idea. How does we go about the lung cancer detection? What are the different characteristics of nodules and what are the pretest probability and how to go about that? My next speaker, Apar, will be talking about that. So I will just put on this Indian consensus. What are the guideline says? The initial diagnostic recommendation for a patient with advanced metastatic non-small cell, should a PD-L1 testing be considered as part of the initial diagnostic workup? PET-CT and brain MRI at baselines are recommended. Tumor should be confirmed pathologically using a tissue biopsy. Histologic subtype should be established with molecular testing. Non-squamous histology should be tested tested for further mutations actionable. Those are EGFR, ALK, ROS, and BRAF is essential. Simultaneously, it is preferred to check for MET exon 14 skipping, MET amplification, NTRK, R2, and RET mutations. PD-L1 testing is also recommended. For the squamous cell histology, EGFR and ALK also need to be considered for never smokers and small biopsy samples. This sometimes we do not do, we only do for the adenas. So all the squamous histology, we should remember that testing of the ROS, BRAF, and MET are important. PD-L1 testing is also recommended for all these patients. So what are the diagnostic procedures to differentiate the PTB from lung cancers? Based on the clinical radiological exam, any of the following is important, either a USG guided FNAC or biopsy of the neck nodes, which is very important, clinically examination of the neck, and think of that. USG or CT guided fine needle aspiration cytology, biopsy. Nowadays, we have got larger biopsy needles, which can get a true cut biopsy of the lung masses. Flexible bronchoscopy and EBUS with endobronchial biopsy through the flexible bronchoscopy, and or TBNA, either a blind TBNA or the EBUS guided TBNA. Again, nowadays we have got bigger needles which are get the core biopsy for getting the histopathology. Not only the histopathology, the gene things also can be picked up from that. Pleural fluid cytology and cell block, and then thoracoscopic pleural biopsy. Somewhere about 5% of the cases will remain undetected of the cause even after thorough investigations. So for them, a thoracoscopic pleural biopsy perhaps is important. So I would just put up a few cases where there was a diagnostic dilemma and how we have progressed. Before that, I just want to show a case report that TB has presented as metastatic lung cancer, and this is a 35-year-old male with 18 pack years of smoking history, presented with dry cough, anorexia, weight loss, lower back and left hip pain. Chest imaging has showed that there is a right upper lobe spiculated mass with mediastinal and hilar lymphadenopathy and a lytic lesion in the left sacral area. MRI of the spine and pelvis has shown lytic lesions in the left sacrum. FDG PET has a pickup hypermetabolic lung lesions with ipsilateral, mediastinal, supraclavicular, splenic, and bone metastasis in the left aspect of the sacrum. CT-guided biopsy of the lung shows necrotizing granuloma, and it was sensitive for MTB. So TB therapy, and finally the patient has improved. So a few cases from our MGM. This is a 56-year-old male, a case of a papillary CA thyroid, status post left thyroidectomy and isthmectomy in January 21. This patient surgery was done elsewhere. So what was the issue? That patient was detected to be mostly the pre-surgical diagnosis was perhaps it was a benign nodule. So they have done only a left thyroidectomy and isthmectomy, and the immediate rose has shown them that this is a benign lesion, so they left it at that. But later on, when in the lab, histopathology has confirmed that that is a papillary CA thyroid. So since then, the patient is on follow-up. He is also a diabetes, dyslipidemia, and never smoker. Now, patient has presented to us with a non-productive cough for 2 months, vague precordial chest pain, and the CT, if you see here on the left-hand panel, it does not work. This one should work. This is side change. This. Okay. So whatever it is, we can see that there is a high positive subcutaneous nodes, particle nodes here panel. So we have gone ahead and done a EBUS biopsy. This is the EBUS picture, and we found the lymph nodes were showing fragments with fibrinous material and lymphoid stroma with focal microgranuloma. So tissue MTB gene expert was also positive for TB. So thankfully, this was not a metastasis to the mediastinum, and it was only TB. So we started TB therapy. So unless, again, you did not have taken the biopsy of that and left it there, perhaps we were not justifying to treat the patient correctly. So the second patient is a 52-year male, cough with dyspnea and tinge of hemoptysis for 2 months, loss of weight of around 4 kilo in last 2 months. He is a smoker, 20 pack years, have diabetes, but it's controlled. CT found to have a right upper lower consolidation with cavities. I will show that. Outside hospital, they have done a bronchoscopy and BAL, and the reports are all basically negative. MTB gene expert, cultures, AFB, nocardia stents, fungal stents are all negative. So this was the CT. You can see that there is a right upper lower consolidation, which is extremely PET avid with some cavities, and patient then has come to us for further management. So in that outside hospital, actually the TB therapy was started. So when he came to us, we thought we will investigate further and we will do something more. So we have done a CT guided biopsy. This is a CT guided biopsy. As it was more peripheral, we have done a CT guided biopsy, which come back as a negative for TB and negative for malignancy also. It has given us an interstitial pneumonia with patchy consolidation. So we have done an EBUS to rule out that we are not really dealing with the malignancy. So the EBUS biopsy report also has suggested that with a fibrin extrusion and lymphoid stroma, no malignancy, no TB seen. The MTB gene expert from the tissue was negative, and that's the video. Does it run? Yeah, it will run. Okay, and this was our EBUS procedure. We were having a node in the right lower paratracheal region, along with the mass was congruent along with that. So we have taken a good biopsy material from there and came back as a negative for malignancy. So this patient is, as TB was also negative and the malignancy was negative, basically we stopped TB therapy, and also we are following up every 6 months to see how things are coming up. Next case is a 56 years male from Bangladesh, which is a multifocal bilateral consolidation with few cavities, with a predilection of these consolidations more towards the upper lobes. He is a known case of a coronary artery disease with post-PTCA, diabetes, hypertension, and diabetic nephropathy. Presented about 2 months ago at Bangladesh with severe malaise, cough, worsening over last 2 months, occasional low-grade fever. Started on TB therapy, he was not improving, came to India, perhaps not happy with therapy being given some places, and came to us. And again, this patient's sputum AFB and MTB gene experts are all negative. So this was the CT when he came to us in the last of August. Multifocal bilateral consolidations more towards upper lobe and cavitary lesions and consolidations bilaterally. So we have gone ahead and done a bronchoscopy and lavage. The MTB gene expert, AFB and fungal stains are all negative. RF factor and anti-CCP were negative. ANCA was negative. ANA was positive 1 in 100, but the SSA were 2+ positive and JO1 were positive 1+. So we started the patient on steroids. Patient came back to us yesterday. The CT has improved, not fantastically yet, but it's on the mend. Patient symptoms of cough, which was his very predominant problem, is almost gone. I will finish with an interesting case of a pleural effusion. This is a 40-year-old female, hypertensive, hypothyroid, treated as seronegative rheumatoid arthritis outside for 1 year with steroids and methotrexate. low-grade fever, loss of weight, and appetite loss for 15 days. There was a gangrene in the right toe with a generalized swelling. Investigation-wise, ANA positive, dsDNA positive, urine proteinuria 3+. CT chest, there was a left-sided pleural effusion. You can see behind that. With subcarinal lymphadenopathy. Pleural fluid analysis were hemorrhagic, exudative, lymphocytic. ADA was 27. Cytology was negative for malignant cell, and there were lupus cells in the pleural fluid. So diagnosis is obviously that this is a case of a SLE with lupus cells in the pleural fluid. But the point is, had we stopped here, we would not have detected this. You can see that studded pleural with small Sagobrin kind of nodules. So results were granulomatous inflammation with AB was also positive, marked there. You can see the granulomas. So final diagnosis is SLE with coexistent lupus pruritus with TB effusion and had to be given TB therapy. So in conclusion, due to high TB prevalence in India and radiological similarities, a large number of lung cancer patients initially get wrongly treated for PTB, and there appears to be an unacceptable delay during the diagnosis and treatment of lung cancer. And not only it is cancer and TB, there are other granulomatous diseases and other infective disease, which is very common in India and our surrounding countries. Attempts are needed to minimize this lag period by maintaining a high index of suspicion, low threshold for referral and aggressive as well as appropriate investigation, workup, and prompt initiation of therapy. TB should always be considered a differential diagnosis of lung lesions, especially in this TB endemic areas of India. Thank you.
Good presentation. Thank the MCM hospital and also there his team for having brought up this CME program for the sake of the postgraduate students as well as the faculties. It is a good initiative that as the cancer incidence is increasing, there is a need to screen and serve the public. And also, as you said, TB is the medical of mimics cancer in many ways. I just want to return the second slide what you have put, just for a small note. They initiated for canopy. They initiated treatment for with anti-TB treatment. And we went all the investigations with biopsy and other things, and we proved that it was not a TB nor infection nor cancer, but the place where it's endemic. Having started properly, I think by then we'll come to a conclusion within about 1.5 months. I feel that continue the anti-TB treatment. Otherwise, you should have to keep a routine follow unless he has some.
It was not. Sorry, sir. It was not 1.5 months. He came to us in 10 days' time of TB therapy study.
The problem is in our country, see, since you have looked at all the other things, you not come to a conclusion. But what we personally feel is we could continue the anti-treatment and check up after 6 months to see whether it has really improved. But as you said, see, tuberculosis mimics everything, so you have to go biopsy. So pathological biopsy is the one which proves whether it is either a TB or a malignancy. So thank you for the wonderful presentation.
Thank you, the entire MGM team and the oncology team of MGM for having me here. It's a wonderful venture. I wish you all the best. I hope you create awareness more among public as well as among doctors in this cancer. Dr. Soumitra, very good, super presentation. But this is the dilemma which we face every day in our movie, and there is never end to this. So, in a TB endemic country, if you go through the risk factors for tuberculosis, it will look exactly same like lung cancer, upper lobe predominant, all those things. And there are so many signs and subtle clues from radiology, from clinical history, from A to Z. You have so many clues to rule out lung cancer upfront. So I think you should be very thorough as pulmonologist with your radiology part. For example, if you have a pleural effusion is inconclusive, gene expert is negative, and then before doing, whether you want to do a pleural biopsy, the patient may not be willing most of the times, they will not be fit for the procedure, like this. The problem lies when you have a clear-cut diagnosis, you're able to get a tissue from the patient, it doesn't matter. So you're going to get at the tissue. The problem is not there. The problem is most of the times when you have a right upper lobe fibrosis, and then you have epithematous lump, and then there is a nodule or a mass which is sitting right in the center of it, and when it is between, like 6 to 8 millimeter, or it is about 1.5 to 2 centimeter, that is where the problem arises, where you have to differentiate between TB and lung cancer. It's very simple if you're able to get a biopsy. It's very, very easy. But the most important thing is when you don't know, when you can't get to a tissue, that is where we face a lot of problems. And the more and more immunotherapy and the more and more of autoimmune disease which you detect and you put the patients on steroid, the more the risk for tuberculosis, the more the risk for ILDs. And in between the fibrosis, the center of the fibrosis, there will be a new malignancy because these patients are more prone for malignancy. So the problem, this problem is going to be there in front of us. That is why lung cancer screening is so important. Because if you have somebody who has a lung chisel sign or a right upper lobe golden sign, it is already too late. We need to pick up patients before that. So that is why I think the lung cancer screening is so good. The latest American guidelines have been updated. As pulmonologists, we should know what a nodule is like, put everything together to finally diagnose whether there is a risk for malignancy. For example, I had a recent patient now who had been admitted with continuous seizures and neurological issues with brain edema, and then the patient actually, she's around 56 years. So they started on steroids to reduce the edema. They started ATD because they think there are multiple mechs like this. And then they noted on the CT scan that on the X-ray that there is a small nodule on the right upper lobe, which was approximately 3.5 centimeter. And by the time it was to pick up the general condition, I opted for a biopsy. So by the time the patient general condition was improved and patient went to a biopsy, the radiologist screened and called me saying, from 3.5, the nodule has become 1.5. Do you really want to do a biopsy or not? Okay. So I said, having shifted the patient, the general condition is bad, so we might not get another chance. Just go ahead with the biopsy. And the biopsy turned out to be primary lung cancer. Okay. So the problem is these malignancies, they have inflammatory component in them. This patient, because of brain edema, they have given pulse dose of steroids and the nodule reduced. So we have so much of queries and a dilemma in our day-to-day practice. So I think you should have a good knowledge of clinical history, radiology, and never settle for anything if you don't have a molecular positivity of tuberculosis. So you will see many patients, many doctors, in fact, if the gene expert turns negative, still it's only TB. Don't look anything further. So if you have not done your proctoscope, you are not going to find out this. So always keep a high level of suspicion and get to the tissue diagnosis. I think that will take you along. Thank you.
So a very beautiful presentation. Like you gave 4 different type of cases. Actually, as I said, both TB and malignancy, the science and pathology almost the same. As clinicians, the dilemma comes mainly when we handle the efficiency, especially the lymphocytic predominant X-ray efficiency. We use the biochemical markers, the ADA and the NPH. But these two has also got overlapping values. For example, ADAs are a highly sensitive tool to detect tuberculosis. But sometimes this enzyme is released by active T lymphocytes. So sometimes in the case of lymphoma also, the ADA can be elevated. The 4th case was presented. So the ADA was negative.
27.
27.
Negative.
Okay, fine.
Normal. Negative.
So when you decide on a thoracoscopy, sir, actually?
My thinking of doing thoracoscopies, unless the patient is a young, my young condition is somewhere about 30-35. Below that, unilateral lymphocytic predominant ADA is at least 45 to 50, and a high protein. As much as high protein it goes, if it is more than 5 gram, I am very sure it is TB most of the time with this background. So with this background, if this kind of patient comes, I say, okay, start TB therapy. MTB gene expert will be negative 99% of the cases. So basically no point in doing that. But anything other than this, as this patient was 40 years, was immunosuppressed. So I thought I will go ahead and do a thoracoscopy. Nowadays, thoracoscopy in people who are really experienced, it's a very simple procedure. You do not need the anesthetist also. You will just have to make the patient sedate, do it half an hour, 20 minutes, you finish the diagnosis. So I would have more predilection to do a thoracoscopy if at all I have a slight kind of thinking that this may not be TB. And my antenna for not TB is very high in that.
Can I add some point there? Yeah. So if you see a pool deficit on the CT scan, so from the history, non-smoker, elderly male, already taking some steroids for some other thing, they are prone for malignancy. And in the effusion, there is a paper, I think if you have a parietal pleural thickening more than 1 centimeter, and if your mediastinal pleura is involved, and if you have a parietal pleura which is involved and you have a split pleura sign, that is more in favor of infection. This is more in favor of if your pleura is having a nodular thickening. These are the subtle things where you should not even wait, even if your gene expert can turn false positive. Gene expert is not 100% specific or sensitive. So these patients, you should subject them for a thoracoscopy. And for everything, there are points like if you take a cavity, size, location, the wall thickness, internal nodularity, and for pleural effusion also there is so much. If you have a lenticular effusion, if you have an extra pleural fat density, that favors an empyema, that does not favor a malignancy. So there are so many signs of pleural effusion, but the most important thing is if you have a mediastinal pleura which is involved, hands down, you have to go for a thoracoscopy, even if your gene expert is positive.
Yeah, exactly the same. And the last point in that is sometimes the CT may not pick up those nodularity. Your ultrasound is the best tool here to pick up those nodularity of the pleural surfaces.
Questions?
Now, in the second case, you will stop the treatment because there is no proof of process or pregnancy.
Yes, sir.
There should be some lesion, some infection to produce a cavity. I think what Gangaran says, either you should have continued ADT and observe, and the other is 6 months follow-up is a very long time. So you have followed it. Otherwise, you should have gone for a surgical resection and get a root cause of the disease. One more thing, and it's frequently experienced the problem is the people going for a CTD related ILD or anything, they start on steroid and methotrexate. Before that, they have to pull up lateral tuberculosis. This is most important.
Very important.
Nobody does like that. The patient will get in trouble after developing steroid and long-term methotrexate. They don't think. Thank you.
Thank you, sir. Any questions to the post-graduate? So you can actually take part in that. So the final discussion after the post-graduate session, so I request to take part actively. There are no questions. May I request that please give the moment to the speaker, Dr. Samantha Singhara. Right. Thank you, very, very wonderful. Maybe after filling the diagnostic diagram. Thank you. Professor, see this, you will want to our chairpersons. Chairperson, thank you. Dr. Gudima, Dr. Raisa. Thank you very much. Move on to the next session. May I request the chairpersons of this session, Dr. Arun Sampur, pulmonologist from MAOD Hospital, Chennai. Welcome, Arun. May I request co-chair, Dr. S. Nurmurthy, sir, Professor and Senior Consultant Pulmonologist at Hospital, and Medical Center. Sir, please come. Welcome, sir. And Dr. Sindhura Goganti, Senior Consultant Pulmonologist and Lung Transplant Physician from Kaveri Hospital, Radiotherapy. Welcome, ma'am. The today's speaker of this session is the Dr. Upper Jindal, Clinical Director and Senior Consultant, Lung Transplant, Interventional Pulmonology and Respiratory Medicine in Healthcare. The topic of our discussion today is the approach to respiratory pulmonary. Over to Dr. Upper Jindal.
Morning, everybody. It's very heartening to see such a good crowd gathered for discussing such an important topic, lung cancer. The topic which Dr. Jayaraman has assigned to me is the approach to a solitary pulmonary nodule. In itself, it is a huge topic. We can go on endlessly discussing just the differentials which can produce the solitary pulmonary nodules. So I'm going to restrict my talk onto the very practical and the clinical aspects as to when we pick up a solitary pulmonary nodule, what are the steps we need to follow to make a diagnosis. Moving on, just for introductions, the solitary pulmonary nodule is defined as a relatively well-defined rounded or an oval pulmonary parenchymal lesion equal to or smaller than less 30 mm in diameter. And it is typically surrounded by pulmonary parenchyma and or visceral pleura and is not associated with lymphadenopathy, atelectasis or pneumonia. So all these conditions need to be fulfilled before you can label a lesion as a solitary pulmonary nodule. You can see there is an example that I've put in the X-ray over there. So just to recap it, size. Now we have three types of nodules over here. We have miliary nodules, which would be typically less than 2 mm. We have pulmonary micronodules, which are 2 to 7 mm. And then we have a pulmonary nodule, which would be anything between 7 to 30 mm. Anything above 30 mm is going to be a mass. What in our talk today we are going to discuss is the micronodule or nodule, which we will term as the solitary pulmonary nodule between 2 to 30 mm. Now, depending upon the morphology, again, they can be subclassified into a solid nodule or into a part solid or a subsolid nodule. These subsolid nodules can again further be classified as to more of a ground glassy nodule or a minimally solid part solid nodule or a more part solid nodule. We'll come to that in details as we progress. It is very important to give a tribute to the Fleishner Society because this is the society from where majority of the data, majority of the guideline, and majority of the consensus on working with solitary pulmonary nodules is coming. So this is basically an international multidisciplinary medical society which was founded in 1969, and it has been named as a tribute to Dr. Felix Fleishner, who was a clinician, educator, researcher, and who was, spent most of his time in giving out a lot of these radiological clues to us. So basically, what is there in the Fleishner's guideline? Why is it important for us to know this? And why is it that this has become the gold standard for SPNs especially? Now, these are the guidelines which are meant for incidental pulmonary nodules in patients who are 35 years or above without any pre-existing lung cancer. Two important points. This is not meant for lung cancer screening. As we've discussed in the morning, lung cancer screening, there are different indications for that. And the dimensions that you pick up for the nodule on the CT, these will not be any single dimension. This is another very important point. The nodules can be of varying sizes. So we've said that typically they are rounded, but they can also be oval nodules. In that case, you have to take an average of the long axis and the short axis of the nodule dimension over here. So the guidelines came up from 2005, revised in 2013, and then the guidelines that we are going to talk about today are the guidelines which are brought out in 2017, which very clearly give out what to do for a solid nodule as well as what to do for a subsolid nodule. So we'll differentiate them, but we're not radiologists over here. We're all pulmonologists. So why is it important for us to know this more of a radiological topic is because we need to pick up malignancies early in our patient. And that is the crux of the matter. So age-old criteria, older patients, male patients, smokers. These are your high-risk patients where you would look at malignancies. Apart from this, there are multiple other areas which on radiological basis can give you a clue as to whether the nodule that you're seeing may be malignant or not. What are these clues? Location of the lesion, multiplicity of the lesion, the pleural retraction and margins of the region, age, sex, and race as we saw, underlying the disease that the patient may have. And of course, the inter-observer variability along with these general conditions can help identify whether the nodule that you're dealing with is a malignant nodule or is it just a benign nodule. So evidence has been collected in terms of age, race, sex, nodule multiplicity, the location of the nodule, whether it is an upper lobe nodule or whether it is a lower lobe nodule, whether it is near to the fissures, whether statistically it is favored depending upon the appearance of the nodule to be a malignant nodule or not, the inter-observer variability. Of course, I'm not going to go into the details of all of this, the underlying lung disease, and then very importantly, what the doubling time of these nodules are, how much time it takes for the nodule or for the disease to progress radiologically. Like it was given that the mean doubling time in the studies were around 166. And when it crosses more than 600 days, we can think about indolent carcinomas, whereas when it is short, about 100 to 200, we think about more about carcinomas. Putting all of this together, risk estimation matrix was established by ACCP, and very convenient to use. This is now available as an online calculator where you just need to click into the different history points, the different points that you see on the CT scan, and it will give you a risk estimation of what the possibility of malignancy in the lesions are. So depending upon that, three basic categories have been identified: a low risk, an intermediate risk, and a high risk for malignancy. Now, there are 4 points that you need to consider. The clinical factors, where young patients, less smoking patients, no prior history of cancer, smaller nodule size, and non-upper lobe lesion form the low risk category, whereas older patients, heavy smokers, prior history of cancer, and upper lobe location form the high risk category. Looking at the PET results, if it is a low or moderate clinical probability, that means if it is a low FDG avid nodule, obviously it goes into the low risk category. If it is an FDG avid nodule, it goes into the high risk category. Looking at the biopsy results, obviously it will tell you whether we are looking at specific adenocarcinoma diagnosis or not. And then how do we approach the CT surveillance, whether it has to be frequent surveillance at 3 months interval, 6 months interval, or it has to be a 2-year interval surveillance. That will depend upon how is the growth rate or the doubling time of the nodule that we are seeing. So how we are going to use this risk estimation, let's move on to that. Like I said, the basic crux of the matter is to pick up malignancies. So what are the radiological clues that you can have for establishing whether the SPN or whether the nodule that you're seeing is benign or whether it is malignant? 4 basic points let's look at. Number 1, calcification, absence of enhancement on a contrast CT, absence of uptake of FDG on a PET scan, and then no growth within a span of 2 years. If you have these, then most likely you're dealing with a benign lesion as compared to a malignant lesion. Looking at these individually, if you look at calcification patterns, if it is a diffuse calcification, a lamellar calcification, a centrally dense calcification, or a popcorn type calcification. Postgraduates, popcorn type calcification, spot diagnosis, hematomas, very good. So if you have any of these kind of lesions, you would think more about a benign lesion, whereas eccentric calcifications or irregular calcifications will point more towards malignancies. When you have lesions which do not show enhancement, if you look at the CT scans, the image to the extreme right is the one where you can see that the vessels are a little more highlighted. This is contrast, but the lesion, the nodule that you're seeing, is not showing any enhancement. This again points more towards benignity of the lesion. If you look at the CT scan follow-up and you see that the nodule has not increased much in size, it has not doubled in size even after a period of 2 years, then yes, this also points towards benignity of the disease. Whereas, look at this case where just in 2.5 months of time, between May to July, the nodule has become almost double the size. And when we did a CT guided biopsy, we picked up that this was an adenocarcinoma. If these lesions are not present, if these signs are not present, that means the criteria which meets benignity is not present. What are the other clues that we can have? We can look at the nodule. What is the type of nodule? What is the size of the nodule, whether it is 6 mm or less or more, whether it is a single nodule or a multiple nodule, and what is the nature of the nodule? Are we looking at a solid nodule or are we looking at a subsolid nodule?
Very complicated table, I agree. Less than 6 mm, 6 to 8 mm, more than 8 mm, and then depending upon the risk category that we saw, whether it is a high risk or a low risk, and also added to that whether it is a single lesion or a multiple lesion. So let me simplify this for you. Very simple point that we can consider. If the lesion is less than 6 mm, leave it alone. You do not need to do anything. Just do surveillance, X-ray based surveillance of these lesions every 2 years. If it is 6 to 8 mm, then yes, you will follow up these lesions at 6 to 12 months interval, and then every 18 to 24 months interval, depending upon the probability or the risk assessment. If it is more than 8 mm, a single lesion, definitely follow up at 3 months. But yes, also what has been advised is an upfront PET scan or a biopsy, so that we do not lose time and we can establish a diagnosis early. Whereas if it is a multiple lesion of more than 8 mm size, you follow up again at 3 to 6 months and then at 18 to 24 months. And this comes from the data which says that multiple nodularity is actually going against the diagnosis of malignancy and favors more of benign lesions. So let's look at what the subsolid nodules are. So these are typically focal nodular areas of increased attenuation through which the normal parenchymal structures such as airways, vessels, and septae can be identified. You have 3 different kinds that can be seen. It can be predominantly focal ground glassy nodules that you can see. Where would you see ground glassy nodules? Postgraduates, let's interact a little bit more. Anybody? Focal ground glassy nodules, where would you typically see? Okay, adenocarcinomas, yes, you can see, but any benign condition where you can see ground glassy nodules? Hypersensitivity pneumonitis. Part solid nodules, where a predominant area of ground glassing is there and a less area of solid component, or it could be a part solid nodule with a predominant solid component with a surrounding ground glassy component. All of these can be classified as a subsolid nodule. So what is the follow-up for a subsolid nodule? Again, depending upon the morphology, depending upon the size, follow-up has been given. So let's simplify this as well. So for a subsolid nodule, if it is a single nodule of less than 6 mm, just leave it alone. If it is a multiple nodule of less than 6 mm, you follow it up at 3 to 6 months and then at 2 years or 4 years. And if it is a single nodule or a multiple nodule of more than 6 mm. So basically size is one of the most important features, whether it is a solid nodule or a subsolid nodule. These nodules you need to follow up every 3 to 6 months, and then you need to repeat a CT every 5 years for a follow-up of these cases. So the crux of the matter here is biopsy wherever the risk is high, wherever the nodule appears to be favoring malignancy, a large nodule, a nodule with associated risk factors, a nodule where the morphology is more solid, you biopsy, you do PET scan, you make interventions to establish the diagnosis. And for other lesions, there are definite time points where follow-up needs to be done. What are the other clues that can help establish malignancy? You look at the margins of these lesions. So smooth margins occur in about 20 to 30% of malignancies. So what this means is that any smooth nodule, please do not rule out malignancy completely. It can still be a malignant lesion. Whereas if it is an irregular nodule, if it has spiculated margins like the corona radiata appearance we see in the picture, if it has lobulated margins, then of course the chances of it being a malignant lesion increase multiple times. 33 to 100% times it could be a malignant lesion. So what are the take-home points out of this? And after this, I have a few cases that I'd like to discuss, and I would request the postgraduates to be, a little bit more participating in that. Basically, the current guidelines have helped to overcome the problem of overdiagnosis. This is the major change. Previously, if you look at the older guidelines, there were multiple, revisions. There were multiple review points which favored multiple more CT scans, multiple more tissue diagnosis. That has been addressed in this guidelines. Lesser follow-ups are being recommended, and definitely there is an emphasis on tissue diagnosis rather than multiple times repeating the CT scan to follow up the nodules. Apart from this, we need to understand it is established that SPNs are a common entity, and we need to pick up or rule out these malignant malignancies early in all these cases. So a good history is very important to establish the risk that the patient has for malignancy. Larger or suspicious lesions, always go for tissue diagnosis. PET scan, tissue diagnosis upfront is the way to go for all the large lesions. And yes, very important point also is that always ask for older X-rays, ask for older CTs. This will help establish the comparison. This will help establish the doubling time and give you a good clue as to the lesion that you are seeing, whether it is benign or not. Moving on to the cases. This is case one, a 63-year-old man with 30-pack history of smoking. So anybody who would like to take a stab at this question. So we see a nodule over here where the dimensions are 9.10 mm and 10.26 mm on the long axis and on the short axis respectively. So what do you want to do? You want to follow this up at 3 months? You want to follow this up at 1 year? You want to do a PET scan or you want to do a biopsy? Anybody? Biopsy, yes, this is a large lesion. It is a solid nodule of more than 8 mm. Single solid more than 8 mm. Definitely you consider a CT at 3 months, but the actual way to go is PET scan and a biopsy to establish the diagnosis right away. The lesion in the case was a large cell neuroendocrine tumor. Moving on to another case, this is a 65-year-old asymptomatic non-smoker, fever of unknown origin in 2013. You can look at the nodule again. What type of nodule is this? I'm not pointing anybody. You can answer in chorus. What type of nodule is this? It's a solid nodule. You can see the dimensions. Now this is 6.13 and 6.35. So average is slightly above 6 mm. What do you want to do next? You want to follow up in 3 months? You want to follow up after 1 year? PET CT or a biopsy? Huh? Nobody wants to answer. Follow up after 3 months? No. So as we saw that this is between 6 to 8 mm. It's a single nodule. Of course, yes, the patient is 65 years. So he falls into a higher risk category. But there also the CT is at 6 to 12 months and then at 18 to 24 months. So we did follow this case up. And you can see that the follow-up here, the nodule has increased in size over 4 years from 2013 to 2018. From 6 mm, it has now gone to 8 mm. So what do you want to do now? Follow up at 3 months, follow up next year, PET CT or a biopsy? I think we are still far away from lunchtime. Biopsy, yes, you need to establish the diagnosis. Biopsy will be the way to go for this. A PET CT and a biopsy will be what you do. So we did a PET CT, we did a CT guided biopsy, and there was low-grade adenomatous proliferation in this lesion. So in spite of a slow nodule where all of the criteria for benignity are met, definitely, see, we were about to miss a malignant lesion. So it is very important to keep a constant follow-up. These SPN patients need to be in your radar. You need to follow them up on a timely manner to not miss these lesions. Another case is a 68-year-old patient with a carcinoma of breast. Okay, so here, what typically has been prescribed in the guidelines is if there are multiple lesions, and you can see there is not one, but there are 2 lesions over here, which are more of ground glassy nature. It says that you do a CT at 3 to 6 months if stable and consider CTs at 2 or 4 years. Because the reason over here is that most of these lesions may not be malignant. Multiple nodules, as I told you, favor more benign lesions as compared to malignant lesions. And you can see 5 months later, most of these lesions cleared out. Another interesting case, and I hope people participate in this one at least. What are you seeing over here? Any clues to, there is a large mass. Yes, left upper lobe mass, I've written it over there. So any clues to what this could be? Anything that you would like to assess on this X-ray before we go on to the CT? So ma'am is there to help the postgraduates. So yes, there is an extrapleural sign. This was actually a cutaneous lesion, which was appearing to be a mass. So what we need to make sure is we need to read the X-ray properly to establish that what we are seeing is actually within the parenchyma or whether it is outside the parenchyma. Any comments on this particular X-ray? Before I show the CT scan and what this is, any comments on that? So this actually is a rib lesion. It is a callosity in the rib. So we need to establish that lesion, whether it is intrapulmonary or whether it is extrapulmonary, before we can look at our follow-up and things to do. I think this is the last case that I'm showing. This is a 67-year-old man with a pericardial cyst on echo. Patient is post-CABG, but there is a left lower lobe nodule, which is quite worrisome. So we did a CT scan, we did a contrast scan, and it does appear to show some enhancement. But this is what the important point was. We asked the patient for an old X-ray. It was a large lesion, more than 8 mm. There was enhancement. So all the indications that it could be a malignant lesion. But if you look at this 3-year-old X-ray, there is the exact same lesion with the same size. It is not increasing. What that means is that old X-rays really do matter. Please do not forget to ask for old radiological pictures from the patients. Thank you.
That was a wonderful insight and talk. Very crisp and clear. And would like to just add upon 2 points. The intensity of the nodule also is especially the home school units, and the presence of any other material like fat or the central clearing or the other signs like halo, because the toxic uses flu. Rightly point out that we need to always ask for the previous X-rays and any previous, even they may not be having their films or scans, at least they may be having reports. So we need to confirm whether this nodule is actually new or and any staining, which is staining, we must not do, especially when the patient has recent chest infection. That gives a lot of false positive, that has to be taken. It's not done just after an infection, so that the most of the patients bleed nowadays with the CT scan and some centimeter nodules, and that could be just resolving the infection. So that also we have need to keep in mind. This is a wonderful talk. I would like to thank organizing team and especially Jairam sir for giving the opportunity, and my best wishes to this conference.
I think I'll pose the question to the oncology team here. So do you follow this guidelines, or is it Lung-RADS 2022 do you follow? Along with Vancouver risk index, which do you follow actually for a SP? Solitary pulmonary nodule, calculating the risk. Lung-RADS 2022, there is an update from the cancer group in US. Huh? Yeah, that's called Lung-RADS, right? 2020. Do you use the Vancouver risk model? Do you use both together? There are papers that say that you have to use both the Vancouver risk model and this, because they're complementary to each other and you can pick up lung cancers faster.
Can the lung cancer patients are probably to rule out the cancer, usually don't like those points.
Okay. So that is one recent update 2022 Lung-RADS guiding for postgraduates.
Radiologists discuss about all the Lung-RADS.
Yeah, correct. There is another Vancouver risk score, which is very good. They are complementary to each other, and they will tell you all this. You know, if you calculate the risk to all the sites, everything together, you will know which patient you should go ahead and immediately biopsy or subject to PET, even if they don't fit into this model.
So that is the online calculator which is available.
Yes,
That
correct.
is based on the Vancouver scoring system.
Brock's model.
Brock's model.
Okay, thank you. no questions, I request the chairpersons to the one to cover gender. So wonderful presentation on the SPN, solid panel, one important, we have to carefully watch the patients, monitor patients. To cover gender, I request Dr. Meenakshi Madam, please give a moment to our chairpersons, Dr. Arun Sambat and Dr. Sindhura Govind. Thank you very much. Thanks. We are 40 minutes running behind the schedule. So I request the chairperson, please check out the timings for that. Thank you. You have final discussion post landscape. We discuss the detail about the radiologist, everything we are here. So next session, may I request the chairperson for this session, Dr. Tirupati, Senior Consultant Pulmonologist, Simpson Voice of Hospital, Chennai. Welcome, Dr. Tirupati. May I request Dr. K. C. Devi, Senior Consultant Pulmonologist, Jellicat Hospital, Chennai. Welcome. So over to the chairpersons.
I think from the beginning of this CME, we've been talking about the prevention and the screening for the lung cancer. And I think now is the time for it. And we have with us Dr. S. Jayaraman. He's a senior consultant pulmonologist, chairperson MGM Academics. He's a clinical lead in thoracic oncology and sleep medicine, MGM Healthcare and MGM Cancer Institute, Chennai, to talk to us about this very important topic, lung cancer screening, time to formulate a strategy. Over to you, sir.
Thank you, Dr. Sri Devi and the chairperson of Tirupati, all the teachers and my colleagues about. I'll be talking on lung cancer screening, time to formulate a strategy. Screening scenario of lung cancer. Already Dr. Jovita Martin clearly we will discuss about the epidemiology of lung cancer. So lung cancer is the leading cause of death among cancers in the world. Lung cancer is responsible for 1.3 million deaths worldwide annually. In India, lung cancer is the second leading cause of cancer death in male and the fourth leading cause of death in the female population. The WHO report on lung cancer is the WHO estimated that by the year of 2025, worldwide lung cancer deaths will have increased several-fold, primarily in the third world, that means low-income countries, and chiefly because of the globalization of the tobacco. Global lung cancer deaths were over 1 million for the year 2000 and are projected to increase to 2 million per annum by 2020-2030. And this is the top 10 causes of predicted changes in global cause of mortality. You can see here the lung cancer presently is the 7th and 8th leading cause of mortality. In 2030, this will become a 6th leading cause of mortality and morbidity. This is a mortality short of top 10 causes. Screening and early detection of lung cancer, as per the US Task Force, I clearly mentioned that early detection alone can save up to 20,000 lives each year, according to the US Preventive Services Task Force. Without screening, many lung cancer diagnoses are unresectable, secondary to advanced stage. Approximately 80% of lung cancer could be cured if they were caught at an early stage. With the leadership of local physicians, we have started a process that is designed to diagnose patients when there is a hope of cure. This is the screening form. So, are you a lung cancer risky group? If so, you may benefit from the CT screening examination. Why consider lung cancer screening? Over 212,000 people are diagnosed with the lung cancer each year. CT lung cancer screening, the only cost-effective test proven to significantly reduce the cancer deaths. Early detection of lung cancer could save your life. So, do you qualify? There are inclusion criteria as per the American standards. No signs of lung cancer. Asymptomatic individuals, 50 to 77 years of age, smoking history of at least one pack a day for 20 years, current smoker or quit in the last 15 years. So we have a preventive oncology program in our MGM Cancer Institute, particularly thoracic oncology. We started a program. We are using the low-dose CT. So in future, a lot of program is going to come up in the MGM Cancer Institute. This is another form. This is the same. So Western world, they have an age group 50 to 80. But Indian standards, we have to modify according to our demography and all. current smoker or former smoker, mainly they are talking about the tobacco smoking, mainly the cigarette smoking. But in our country, BD smoking is higher than the tobacco, that's a cigarette. Because BD has no filter, it has a high nicotine, a high carcinogen content. The BD causes more carcinogen than the tobacco due to the cigarettes. So this is the Indian scenario. We have to formulate our own strategy. Lung cancer, there are 3 ways of clinical presentation. 1/3 asymptomatic. As a screening program, this is our main focus of area, asymptomatic individuals. 1/3 lung symptoms. So you can directly go for the CT bronchoscopy biopsy and do the thing. 1/3 is a metastatic symptoms. Patient can present with this seasick disorder, jaundice and all, so we have to formulate. But majority of the patients in our country, 40 to 60% of patients, 1/3 all we are seeing the patients with the advanced stage of lung cancer. So low-dose CT. This is the criteria of inclusion in that screening program. As per the American standard, age group is 50 to 77. But Indian standards, we have to modify 40 plus. So I'll show the literature review and all. We have to start from the screening from 40 plus. Asymptomatic, no signs or symptoms of lung cancer. Tobacco smoking history of at least 20 pack years. 1 pack year is equal to smoking 1 pack per day for 1 year. 1 pack means 20 cigarettes. Current smoker or one has quit smoking within the last 15 years. Low-dose CT lung cancer screening, proposed coverage decision. So, psychologist's role is very, very important here. Counseling on the importance of adherence to annual lung cancer, low-dose CT scan screening, impact of comorbidities and ability or willingness to undergo the diagnosis and treatment. Counseling on the importance of maintaining tobacco smoking, abstinence if former smoker, or the importance of smoking cessation if current smoker, and if appropriate, furnishing of information about the tobacco cessation interventions. So in MGM, we have a tobacco cessation program, both in MGM HC and healthcare as well as in Cancer Institute. Combined with oncology and the pathology, we are doing the program, awareness program for the general public and all. Low-dose CT scan for lung cancer screening. A low-dose CT scan has only 1/5 of the radiation of a regular CT scan, making it safer for routine testing. Technically, low-dose CT scan provides about 1.4 millisieverts. That is, MSV is a radiation, the scientific unit of the measuring of ionizing radiation, while a standard diagnostic CT is closer to 7 millisieverts. New way to detect a lung cancer. So artificial intelligence coming in a very rapid phase in all the fields, not only in oncology, all the fields. So AI that can detect early signs of the disease years before would find it on a CT scan. Now every chest radiography machine has the Cure AI, that is a computer-aided diagnosis system, reporting system and all. So we are using that. With the advancements of the computer-aided chest radiography, we can detect the nodules very early. Global can productivity data, you can see here, as per the Indian standards, that's the lung cancer is the second most common cause in the male populations. Less patients diagnosed at an earlier stage in Indian data. Majority of the patients, they presented with a stage 4. 65.9% of patients, Indian patients, they presented to the pulmonologist or oncologist with a stage 4 disease. Diagnosis of lung cancer, mainly the imaging modalities, CT scan, PET scan, MRI, and bone scan, and tissue sampling by needle biopsy. There is an image-guided needle biopsy using CT or ultrasound, bronchoscopy. EBS plays a major role. Wherever lesion, whether it's the mediastinal, central, peripheral, endoluminal, extraluminal, EBS plays a major role in diagnosing very clearly, precisely. We can take the tissue. So tissue is the issue for diagnosis. This is a very, very important tool. We have all the facilities of a linear as well as radial probe to diagnose various part of the lung, whether it's a thoracic malignancy, pleural malignancy. Through the EBS, we can approach all the areas. Laboratory tests are very, very important. We have a lot of advancements in the molecular diagnosis and cell type and all. Why is lung cancer diagnosed late? Misdiagnosis. As a symptom mimic other respiratory diseases like TB, COPD, ILD, fibrotic lung disease, COPD, TB, all the 400 high-risk group to develop the lung cancer. Lack of screening in high-risk patients, lack of awareness among the patients. Coming to the misdiagnosis part. So patients with the warning signs and symptoms of lung cancer were misdiagnosed as tuberculosis. This study conducted in already Institute of Medical Sciences in diagnosed patients of CA lung. Cancer patients misdiagnosed as tuberculosis, that is 20%. This is 14% they have follow up regularly. A lot of patients shows the increase in size of opacity in the radiography and CT, and metastasis to the contralateral lung. So these kind of thing, all the negative patients are empirical ATT based on the symptomatology. Misdiagnosis of lung cancer tuberculosis has been reported across India. Various studies in same civil data study and AIMS and various places clearly proven that. What is the solution? Misdiagnosis of symptoms mimic other respiratory diseases. AKT, anti-TB therapy should not be started without confirmed diagnosis. Careful monitoring should be done in those who are sputum negative or not responding to AKT. Consider lung cancer diagnosis as a difference diagnosis in your clinical practice. Why is cancer diagnosis late? Lack of screening in high-risk patients is one of the very important factors. So, warning signs of the lung cancer symptoms: cough, hemoptysis, fatigue, similar symptoms in TB and the lung cancer. Patients are 50 plus and smoking history. But Indian setup, we have to change according to our demographic pattern. Screening techniques in lung cancer: chest X-ray, sputum cytology, low-dose CT scan. Chest X-ray studies using X-ray screening did not show mortality benefits. Sputum cytology not recommended, not useful. Low-dose CT scan is evidence-based one. I already mentioned millisieverts and all. Reduce lung cancer mortality with a low-dose CT screening. This is a trial that is a national lung screening trial. This is another landmark trial for the lung cancer screening. The NLST found that every 320 low-dose CT scans administered, one life could be saved compared to 864 tests for colorectal cancer and between 645 to 1,724 scans for the breast cancer. Reduce lung cancer mortality with the CT, low-dose CT scan. This is the Nelson trial. This is a landmark trial for the lung cancer screening. This is an ongoing trial. More than 25 years they are doing the trial. The report clearly mentioned that if you do the low-dose CT scan in a high-risk group, the mortality rate will be very less. There are clear-cut studies are available. This is Nelson and NLST studies. National Comprehensive Cancer Screening Trial. So this is the lung cancer screening guidelines. As per the guidelines, clearly mentioned that risk assessment, high risk, moderate risk, and the low risk group. In a high risk group, individuals, smoking history, exposure to the radon, occupational exposure, certain job like radon or atomic industry, is cancer history is there in the family. So, and the family history of lung cancer in the first degree, or diagnostic history of COPD, TB, or the fibrotic ILD disease. This is not a high risk group with a smoking status and air pollution exposure. If there is a high risk status, you have to go for the screening. Candidate for screening SAT patients, physician decision making is recommended, including a discussion of benefits and the risk ratio. So, we are subject the patient for the low-dose CT scan. Other moderate and high risk group, no need to do the screening. We have to carefully wait and watch. Physicians plays an important role in early lung cancer detection. So, GPs, general practices, urged to more alert in diagnosing lung cancer in non-smokers. This is a very important thing. A physician can certainly help in improving detection rate by being more alert, especially patients with the respiratory symptoms not responding to antibiotics, chronic smokers, family history of lung cancer, cautious reading of chest radiography is very important. Screening identifies suspicious nodules. Already got Aboriginal clearly mentioned about the which nodule we have to suspicious and all. So 5 millimeter or smaller size nodule, next low-dose CT we can repeat after 12 months. Smaller nodules are not amenable to surgery. So watch and wait to monitor any increase in size. So 6 to 7, again the same category. 8 to 14 millimeter size nodule, next low-dose CT scan is the 3 months time you have to do the CT scan. And we have to do the large nodules can be surgically removed the background of malignancy, high suspicion of malignancy. 15 millimeter or larger, again is a chest CT, regular CT or PET scan, and proceed to the biopsies and the removal of nodule is these are the guidelines from the American standards. National Comprehensive Cancer Network trials. Early lung cancer detection definitely will have a better survival rate. Issues with lung cancer screening. No screening guidelines for non-smokers. Western guidelines are clearly to put the patient only the risk group is smoking individual, tobacco smoking. But in Indian continents, we have a lot of air pollution, indoor and outdoor pollutions, female population developing adenocarcinoma, this all increasing incidents. So you have to take care of the non-smoking individuals. Need to develop a screening guidelines for non-smokers. Physicians need to be more alert when encountering patients with the respiratory symptoms, mainly the non-smokers. Cost effectiveness, especially developing countries like India. Low-dose CT is more costly than chest X-ray. Chest X-ray has a very low pickup rate. Chest X-ray can be combined with the artificial intelligence for the better diagnosis. Lack of screening in high-risk patients, we have to form the robust screening guidelines in each and every center. We have to form that. Each institution can have its own screening programs till the national screening guidelines is formulated. Physicians be aware of patients they can refer for the lung cancer screening. Lack of awareness among our people. So creating awareness among general public. This is a very important. This month, November month, we call it as a lung cancer awareness month. August 1st is the World Lung Cancer Day. We do a lot of awareness activity along with the Rotary and the Indian Medical Association. We do a lot of programs like a walkathon and patients awareness programs and a lot of peace programs for everybody, all the people. And for the CME, regular CME weekly 2-3 IMA meetings we are connecting for the doctors in all the preventive programs. The way forward, institutional screening programs. Each institution can have its own screening program till a national screening guidelines is formulated. AI-based technologies on CT images to detect incidental nodules. Good artificial intelligence algorithms can detect better than human eyes. Tobacco cessation. This is a very important prevention. Prevention is better than cure already here. So a lot of chairpersons. Awareness should be made among the general public about the risk of smoking. Individual screening. Each case should be screened as per the presence of risk factors. So liquid biopsy, biomarkers, breathomics, metabolomics, all coming in a very rapid phase. Another couple of years, mostly 5 years, we will get this kind of investigation. This is from the non-invasive modalities of diagnosis of early cancer, not only lung cancer, all the things. The use of liquid biopsies could be in the form of introducing lung cancer genetic, transcriptomic, and epigenetic screening biomarkers to determine potential high-risk societies as a preliminary screening before the use of CT scan. Thus, early diagnostic using biomarkers could diagnose intermediate nodules identified by the CT, leading to selecting subjects that need a surgical biopsy and saving others who do not need it. Liquid biopsies allow for non-invasive analysis of body fluids for DNA set products and aberrant circulating cells. They have been assessed as a pillar in the precision medicine field, as genetic analysis provides quantitative feedback and monitors patient response, enabling more precise, personalized, and practical approach towards the individualized treatment. PCR techniques have been used for the possible detection of molecular biomarkers for early lung cancer. The potential use of the plasma microRNA, a novel biomarker for early detection of lung cancer, has been studied. There are a lot of biomarkers coming in the pipeline. There are a lot of research is coming in a very rapid phase. So mostly in a couple of years, we'll use all these biomarkers, metabolomics, etc. The final take-home message from my side: lung cancer is a preventable, treatable, and curable if we detect in the early stage. Lung cancer screening and early diagnosis is a very, very important primordial prevention to avoid unnecessary morbidity and mortality. Clinical suspicious to have each and every patient's meticulous history, family history, tobacco history, risky group, risky job, and the air pollution, indoor and outdoor pollutions, biogas fuel exposures, etc. We have to keep in mind that. So all important. And the TB and lung cancer differentiation. Clinical suspicious and TB and lung cancer differentiation is very, very important in our country because TB is very, very common in our country. Both the symptoms are the same way. So methodically we have to examine. Tobacco smoking or non-tobacco smoke and air pollution inhalation due to risky occupations, we have to keep in mind that annual screening with low-dose CT will help in diagnose early and cure them early. So with that, I thank you very much for this patient listening. Thank you. Any question I will take? All the chapters.
Thank you, Dr. Jayaraman, sir. It's a wonderful presentation covering all aspects of lung cancer therapy. The message is very clear. We need to sensitize our MSc people regarding these simple questions. What is the age of the patient? Are you a smoker? And what is the number of cigarettes you smoke? If we sensitize our MSc people, then the goal is achieved.
Correct. Yeah, preventive medicine is a very, very important role. Any risky group, at the recommendation, you must put the word like low-dose CT and consult pulmonologist. This way we can catch them early. Simple questions. I fully agree. Thank you.
Bronchoscopic liquid biopsy, the specificity and sensitivity, and the chance of false positive and positive.
Bronchoscopic lung biopsy. We call this a liquid lung biopsy. This is a different kind. We do the lavage sample. So bronchial lavage, we call this a liquid lung biopsy. We said for all the analysis, including the cell count, info count, and the variances and all. So liquid biopsy is different from liquid lung biopsy. Liquid lung biopsy is a bronchoscopic alveolar lavage. Liquid biopsy is a frequent sampling of the blood, urine, blood fluid. We take and see the markers. This one markers coming in a very rapid way. So we have to wait and watch them.
Is there any genetics?
Yes, sir. Genetic, yeah. There's a lot of genetic biomarkers is coming in a very rapid way. This is going on in the Western world. Bronchoalveolar lavage, we call it as the liquid lung biopsy. We take it for the evaluation, pregnancy evaluation. In case of bronchoalveolar carcinoma evaluations. So, millions of tuberculosis, we do a transplant biopsy along with the PL. This is different. Bronchial was is different. Bronchoalveolar lavage is different.
We are already having behind the schedule. I think we can have the questions later on.
Yeah.
I thank the entire MGM team for having come up with this wonderful CME. And I think we need many more such awareness programs in future as well. Thank you.
Because that person.
Thank you, sir. May I request Dr. Prasanna sir to honor Dr. Jaram sir? Dr. Chandrasekhar sir to honor our chat person.
Thank you. We move on to the next session. May I invite Dr. Arna Boganathan, Senior Consultant Professor, Department of Social Science and Udaratma, welcome to Chair Center. Thank you. And may I request Dr. Kaushik Uttaraja, Senior Consultant Pulmonologist in the National Institute of Higher Education Research, welcome, Chair. And may I request Dr. K. Sanuguppriya, Co-Chair, Assistant Professor, Department of Pulmonology, Sri Radiotherapy Medical College Hospital in Chennai. Speaker of this session is Dr. S. Priya, Senior Consultant Pathologist, Indian Cancer Institute, Chennai. The topic of discussion is the diagnostic pitfalls in the lung cancer pathologist perspective. Dr. Priya? Yeah, thank you both of you.
So, a very good morning to one and all present here. My topic for today is pitfalls in lung cancer diagnosis. So, I'll just touch upon molecular pathogenesis, move on to small diagnostic samples, list the challenges we face in diagnosis and grading, and end with few words on molecular and PD-L1 testing. As we all know, lung cancer is the most common cause of mortality worldwide, and 85% of the lung carcinoma or non-small cell lung cancers, mostly due to the effects of carcinogenic effects of smoking. And out of these 85%, the most common thing is the adenocarcinomas, followed by squamous cell carcinomas. Then we have the small cell carcinoma, which account for 15%. So this is a small depiction of molecular pathogenesis. Basically, the small cell carcinomas and the squamous cell carcinomas arise in the major bronchi, so are centrally located, and they are common in smokers, whereas these adenocarcinomas smokers, and they arise in the peripheral areas, from the alveolar epithelial cells or the terminal bronchioles. And these molecular subtypes, I mean to say that these subtypes of lung cancer have unique molecular pathogenesis and driver mutations. As told earlier, this adenocarcinomas has two major pathways. One is EGFR pathway, and other is the KRAS mutation pathway, which the KRAS is common in smokers, whereas in non-smokers it's usually due to EGFR pathway. And the adenocarcinomas usually have low tumor burden, and they are due to specific driver mutations. On the other hand, squamous cell carcinomas have high mutational burden, and they are due to accumulation of lot of mutations. In squamous cell carcinomas, even we can diagnose the presence of a malignancy on the biopsy. Even the hypertoxic bronchial epithelium, there are molecular alterations which start So that is the loss of 3P and 9P gene mutations, loss of heterozygoity. The earliest thing in the sequence of the molecular pathogenesis of squamous cell carcinoma, and this can be identified even before you have a dysplasia or a invasive squamous cell carcinoma. So with further accumulation of more and more mutations like 8P, loss of heterozygosity, loss of tumor inhibitor genes such as P53, it proceeds on to the bronchial epithelium, gets metaplasia in your squamous epithelium, which becomes dysplastic, and then there is a carcinoma in situ, and it becomes an invasive squamous cell carcinoma. So, with this background, I'll just move immediately to small diagnostic samples which are challenging. So, 70% of the lung cancer in the current scenario usually present in an unresectable stage. So, the cytology and the small biopsy specimens are the main sample for diagnosis. And not only for diagnosis, we have to preserve the specimen for molecular testing as well, because this biopsy is very precious. And so, these are the good practice guidelines for the pathologist on small biopsies. Whenever possible, we need to give a diagnosis either as an adenocarcinoma or squamous cell carcinoma and avoid giving the term NOS as much as possible. But this is not always possible with just morphology alone. So we will be running here IHC testing, which will be a limited panel of markers. As again I emphasize, we try to limit the markers so that we preserve the tissue for molecular testing at a later date. Even the tissue may be necessary after the initiation of therapy. If you come back with a resistance mutation detection, we may have to have the biopsy. So we'll try to have a very judicious selection of markers based on the morphology. And neuroendocrine markers, we don't run as a routine. Only if we have a suspicious morphology, we'll go with those markers. So I'll run through some examples. Yeah. So okay. Okay, I'm sorry for that. So if we usually get cytology and small biopsy specimens. In the cytology specimens, if you see any evidence of keratinization or formation of keratin pearls in a small biopsy, we will sign out this directly as a squamous cell carcinoma. Next, if we this is the pleural fluid where we are seeing 3D collection of atypical cells showing polarization, or a cytologist here where you can see where acinar or gland formations, and again a FMG biopsy where we are seeing gland formation. In these cases, we'll be able to give a diagnosis as a adenocarcinoma, and we'll not be running IHC on this. Just based on the morphology, we'll sign out either as an adenocarcinoma or squamous cell carcinoma. But the scenario is not always the same. We always have some diagnostic challenges. Either the sample will have a lot of obscuring elements and it will not be adequate for a diagnosis, or the morphology, I'll not be able to see any keratinization or glandular pattern or papillary pattern suggesting adenocarcinoma, or there may be a lot of spindle cells. Spindle cells will come both in squamous cell carcinoma and adenocarcinoma, especially a poorly differentiated one. And small cells with extensive crush artifact can be neuroendocrine carcinoma, but again I have to look of lymphoma in these cases. So I'm showing few examples. So the first slide, you can see that there is a lot of blood and only few tumor cells available. So in this, we'll not be able to classify this as an adeno or squamous cell carcinoma. Sometimes we may not be able to say whether it's a malignancy or not. The next picture I'm above, we can see that the cells are looking bland, but it's a case of adenocarcinoma in situ. The cells will resemble that of a macrophages, and we may not be able to give a diagnosis straightforward. And the picture below, you can see that the cells are very ugly looking, large nuclei in presence of nucleoli. But this is severe reactive atypia seen in an inflammatory condition, which may mimic the adenocarcinoma. So these are the challenges. We may not be able to, sometimes we may not be able to tell you even it is a malignancy or not. So here in this, we are seeing that there are like sheets of cells, there is no discernible morphological pattern. So here we will be able to sign out only as NSLC, NOS. So now, if we have only cytology sample, we are stuck with that. But if we have little material for cell block, or if we have a core needle biopsy, here again I'm seeing a lot of large cells which are ugly looking in a sheeted pattern. So it's a non-small cell lung cancer NOS. But if I do an immunohistochemistry, this is like staining for P40 nuclear staining. Then I'll be giving it as NSLC favor squamous cell carcinoma. And the other case where it's positive for TTF1, it will be an adenocarcinoma. So we'll usually run two markers. One squamous cell differentiation marker, either P40, P63 or SEK5/6, and one adenocarcinoma marker, usually TTF1 or NAPSIN-A. With positivity of one marker and the negativity of other marker, we'll be able to differentiate it into an adenocarcinoma or a squamous cell carcinoma. So this again, it's showing like sheet of cells with keratinization. But again, in between, I'm seeing some glandular structures with vague secretions within. So I'm confused whether it's an adenocarcinoma or a squamous cell carcinoma. Now I have to resort to IHC. So this is a TTF1. The glands are highlighted. And again, the P40 shows the solid nessa highlighted. So it's an NSLC adenosquamous carcinoma. See, as I mentioned earlier, these are highly pleomorphic spindle cells, and with an IHC, I will be able to put it under poorly differentiated adenocarcinoma. And this is what I'm talking about, small cells externally crushed artifact. Now my suspicion primarily is small cell carcinoma, but the morphology wise, we may not be able to give on such a small biopsy. We will now do a neuroendocrine marker. Now, yes, because PA is important, a high PA index and positivity of neuroendocrine markers, we will be able to diagnose this core biopsy as a small cell carcinoma. So this is the summary of what I was talking till now. So in the small biopsy, if possible by morphology, we will classify the IHC into adenocarcinoma. If not, IHC renal markers classify further. And after classification, we will preserve the tissue and send it for molecular testing. But even after like both the markers are then we will have exhaustive panel of IHC to classify as rarely melanoma, sarcomas, and even epithelioid mesothelioma can be these sectors. So we'll be running so if lot of markers are the tissue may not be sufficient for molecular testing, and in that case we'll ask for a repeat biopsy or a repeat sampling. And even if all these IHC exhaustive panels, the tissue is still negative, it still remains non-small cell lung carcinoma NOS, and we will do a molecular testing. On molecular testing, if it's positive for either as rearrangement or EGFR mutation, it's most likely or most probably an adenocarcinoma. So next is grading. Now the International Association for Study of Lung Cancer has given a new grading system, which is different from the previous grading system, where we have greater than 20% high grade patterns, either solid micropapillary or a critical pattern level. It's straightforward, it should give it as grade 3. And this classification is usually done only on resection specimens, but in the core biopsy also, if you see high grade patterns, we'll try to classify it as well differentiated, moderately differentiated, or poorly differentiated. Basically, a well differentiated has predominant negative pattern, whereas the moderately differentiated will have acinar and papillary pattern, whereas the poorly differentiated carcinoma will get greater than 20% high grade patterns. So now the grading is based on the pattern of the adenocarcinoma present. So now once we have a diagnosis, the next step is predictive biomarker testing. In adenocarcinomas, we do molecular testing for the current guidelines are for testing for EGFR, ALK, ROS1, BRAF, NTRK123, RET, KRAS, and MET gene mutations. I'm not going into the details of this testing. These are the recommended testing. The most important thing is that we should check the biopsy. We should see if the sample is adequate and two viable tumor cells are there for the molecular testing to be done. So that's the most important step. And testing in squamous cell carcinomas, they usually do not have that much of target susceptible mutations. So we do a PD-L1 testing. But the current trend is that in young non-smoking patients with squamous histology also, we can test them for EGFR MET mutations, and ALK and ROS rearrangement studies can be done. So these are under trials now, and with even with squamous cell carcinomas, in this setting, people are doing this mutational studies. And for PD-L1 assessment, we need at least 100 viable tumor cells to be present to give our report. Only exception is that if we are using Roche SP142 marker, 50 viable cells along with inflammatory stroma can be used, because we'll be scoring not only on tumor cells but also on inflammatory cells. So biomarker testings for immunotherapy, as I told, like PD-1 and PD-L1 inhibitors are approved by FDA, and for all these drugs has been approved not only in second line but pembrolizumab also in first line treatment. So these we do PD-L1 testing on these samples. So the current NCCN guidelines recommend standard PD-L1 testing in advanced lung cancers, and not only squamous and both adenocarcinomas for PD-L1 testing. So the amount of tumor expressing the PD-L1 is also important, because even if greater than 1% of the tumor cells express PD-L1, it's positive. The sample is positive. But the amount is important, because if we need to use it in a first line, you need to have more than 50% of the cells or high PD-L1 expression in the tumor cells. And the other point to note is that sometimes we need to have a knowledge of about EGFR mutation and ALK rearrangement in patients with adenocarcinomas while doing PD-L1, because these genes, if positive, predict an inferior response to immunotherapy compared to patients who do not have these mutations. So even in PD-L1, in adenocarcinomas, while doing PD-L1, we'll have a look at how the EGFR status and ALK status is. So this is the assessment of how we do the assessment of PD-L1 staining. So it's basically a tumor proportion score. That means the percentage of viable tumor cells showing even partial or complete expression of the protein on the surface of any intensity. Can be mild, moderate, or good expression of the protein. So any intensity of expression against the total number of cells counted into 100. That will be the tumor proportion score. So in the first figure, you will see that there is usually the brown color indicates the presence of positivity for immunohistochemistry. So we can see that the proportion score is less than 1%. That means that the tumor has no PD-L1 expression, and immunotherapy is not likely to work in these patients. Next, we have a low expression. That's like when the tumor cells are expressing from 1 to 49%. That's less than 50%. It's low PD-L1 expression. Here you can see that there are faint staining. We take into account both membranous and cytoplasmic staining when assessing for DACO's 22C3 marker, but when assessing for SP263, we have to see only for the presence of membranous positivity. And this is the last one is a case of high PD-L1 positivity. You can see that almost all the cells, 80 to 90% of the cells show beautiful membranous high intensity positive. So this will be given as high PD-L1 expression. And just a short, a few lines on pleural invasion. So this is important to assess, because sometimes in HN, this is special stain for elastic stain. So you can see the thicker elastic lamina in the first case, and the tumor cells are well below the pleura. So there's no invasion. When the in the resection specimen, if it's less than 3 centimeters, it comes under T1 stage. But if in this case, you can see that the pleura goes between the tumor cells, and there is a regular pleural invasion, the tumor stage gets upgraded. It becomes T2A. So we always look for pleural invasion. If we are not able to see with the HNE stain, we go for special stains. And the last thing is gaining more importance is fed through aspaces. So this is in an infection specimen, the presence of tumor cells in the advancing side beyond the margin of the original tumor. Here it can be micropapillary pattern or small nets of cells. The most important point is that we should not include these in the grading of the tumor, because I told you if more than 20% of the high grade pattern, which is micropapillary, is present, it goes under Bowling differentiated carcinoma. But if the tumor has predominant levotic carcinoma pattern, still it remains a well differentiated or a moderately differentiated tumor. The pattern of start should not be taken into account. This is just to show, this will be included in the report because this is associated with a very worse clinical outcome. So these are the current 2021 classification lays a great emphasis on diagnosis in small biopsies and cytological specimens. And as I told, we try to preserve as much as tissue possible for molecular testing. And PDL1 assessment is now done in both squamous and adenocarcinomas to guide immunotherapy. Thank you all for your patience.
That was a very neat and organized presentation, and you have very well highlighted all the mimics and the important markers that are used as per the guideline. And I also would extend my thanks to Dr. Jayram and the entire team of MGM and congratulate them for their lung cancer inauguration clinic. Just a small, I think there should be a coordination between the clinician and the surgeon. That's extremely important because in some biopsy specimens you might not need that many markers. But of course, as you, only in each individual case, you decide how many markers to go ahead. So it's important for us to even tell the patients upfront that what is the cost encountered, and for each marker that may vary. And it's always because, as Dr. Jayram pointed out, tissue is definitely an issue. And there's always a, this is not enough. So I think it's better to educate the patients and make them aware that they may have to go for more markers. Thank you so much.
I would like to thank Dr. Jayram sir and the Region Institute for a wonderful program and session. Clearly, mimics and pitfalls will help us to learn from these diagnoses.
Thank you for this wonderful talk. I just have a couple of questions. One is you might be receiving a lot of smaller samples these days because of the latest technology. What, according to you, is the best modality to do a smaller biopsies? Like, where do you get a good sample without any artifacts, so that people here would like to know which modality is better to get smaller?
So FMD specimens are usually good. Whatever we get, we are able to give a diagnosis and send for immunohistochemistry and molecular design. Fluid samples, even though we do cell block, it does not give the same result as a core biopsy. And moreover, on NGS testing also, core biopsy specimens are better.
And regarding cryobiopsies, I think your any experience on cryobiopsies, the volume of tissues which you get, whether it's adequate to go ahead.
We usually don't get cryobiopsies here on lung.
And what about the differential between a CT guided liquid biopsy and endoscopic biopsy?
In CT guided biopsies, we get more of samples sometimes. We get a lot of junk of 3-4 cores, and we try to put 1 core in one block. So for molecular testing, and one can be preserved like future after like the resistance we can send that. And as an alternative, we can also do a liquid biopsy for monitoring resistance. Thank you.
Thank you, ma'am. We request to view the molecule to Dr. Clear. May I request Pathology, ma'am, please come and give this moment to the chairpersons. Yeah. We'll move on to the next session. For the chairperson, may I request Dr. Thomas, please give the guide, sir. Senior consultant, sir, is the senior consultant or not? That's the very constant of the Association of Pathology in Tamil Nadu. And Sir is really a singer, orator, is an international faculty. Thank you, sir. May I request the proposed courtesy, General Secretary, please follow the raise. General Secretary is senior consultant, professor and head of department, Department of Pulmonology, ACS Medical College. Sir is the current president of the ABP, Association of Pulmonology of Tamil Nadu and may I request Dr. A. Suresh, senior consultant pulmonologist, since possible, Real Sciences. So please come on, guys. Suresh, welcome. So this session, may I invite the speaker, Dr. M. Rajesh, senior consultant medical oncologist, director oncology services, Indian Cancer Institute. The topic of presentation is the overview on management of lung carcinoma. Four verses.
Good afternoon, everyone. Respected Chairperson, thank you for this opportunity, Dr. Jaram. I realized you gave me about 10 talks into one, so I hope I can hurry through the slides. When you talk about lung cancer management, any oncology work obviously rests on the two pillars of pathologists and radiologists. In the lung cancer, we also necessarily involve the surgeons, radiation oncologists at the very least, and sometimes other specialties, particularly the pulmonologists. Everything that I'm going to tell you is based on evidence that's available in the literature. And I will not go through this because already been talked about. When I prepared this talk, I realized that the saga of lung cancer is also my own life. I started in oncology in 1982. And it is fair to say that 1980 to 1990, the era was palliative care. It was perfectly legitimate to offer non-small cell lung cancer on day one, only palliative care, with a median survival of about 8 to 10 months, because the role of drug therapy was clearly established at that point in time. If you look at the next decade, 1991 to 2000, it was the era of chemotherapy, which, by the way, still holds good. The majority of lung cancers, non-small cell lung cancer, and I'm going to talk only about non-small cell lung cancer because it's about 85 to 90% of all lung cancers. For lack of time, we will not talk about the others. From that decade until now, the majority of non-small cell lung cancers, chemotherapy still remains the backbone of therapy. So because before 1990, we hardly had very big understanding of the role of chemotherapy in non-small cell lung cancer. And there was an arbitrary thing that if it had a 15% response, it was considered active in non-small cell lung cancer. And it's also understood very early that single agents did not work very well. You see this publication in 2000. In 2000, it says it's appropriate to offer chemotherapy to all NSCLC patients. So before that, it was not a standard of care. And of course, all the other things, good performance status. In all medical therapies, always start only with advanced disease. And only then their safety and their efficacy is established. They move to the earlier stages of lung cancer. And that plus the fact that most of the lung cancer that we unfortunately see are advanced stage. Most of my talk will be on advanced stage. So very early, it was clear that platinum is the backbone for lung cancer. It remains the backbone for lung cancer management because it had the highest response rate among all the agents available then. And even with platinum-based chemotherapy, this was the sort of response rate you got, 15 to 25%. I told you 15 is a cutoff for considering something an active agent in non-small cell, 15 to 25%. Then came this very important landmark study, which is probably one of the most cited papers in non-small cell lung cancer, where they had a randomized study of 4 regimes, all of which had platinum, plus some other agent, gemcitabine, taxane, and so on. And the interesting thing was all of them are equal. All of them are equal in terms of the outcome. Only the toxicity and others different. It took us another 10 years to realize that adenocarcinomas were somewhat different than squamous carcinomas. And pemetrexed was added to this armamentarium in non-small cell lung cancer. And since then remains the standard of care in non-small cell lung cancer, adenocarcinoma, again in combination with platinum. Whereas with the squamous, all the earlier regimes I told you, they all can be applied with this gemcitabine or it is a taxane with a platinum. So the recommendation at that time in that decade was that in squamous cell carcinoma, it always has to be platinum based. And if the performance status was good, then you could go with a doublet combination which was superior to single. Performance status was poor, you started with platinum alone. And somewhat similar to non-squamous, except it was pemetrexed. Once the efficacy of chemotherapy was established, the role of chemotherapy was also tried in other scenarios in non-small cell lung cancer. In adjuvant chemotherapy, here's a meta-analysis which shows that there is advantage to offering adjuvant chemotherapy in all stages from 1B upwards. In all stages from 1B upwards. And here's the specific study showing the same thing, regardless of tumor size. The median overall survival is more if you offer adjuvant chemotherapy from stage 1B upwards. And this is the curves according to tumor size. Then it's also tried in the neoadjuvant setting in locally advanced disease. And again, to show that there was some improvement in survival. And this is not always the standard of care, but it is something which you can consider because there is some advantage in offering preoperative chemotherapy. Then, of course, it was tried along with radiation in several trials. And it was shown that concurrent radiation, chemoradiation was superior to sequential chemoradiation. So the message from chemotherapy as far as non-small cell lung cancer is concerned that chemotherapy is definitely better than best supportive care. That has been established. Adjuvant chemotherapy can be offered from stages 1B and up. Neoadjuvant chemotherapy is an option in initially inoperable patients. Concurrent chemoradiation is superior. Platinum remains the backbone and doublets are better than single agent. Then came the next decade, 2001 to 2010, where we moved to another set of treatments called targeted therapy, which basically all of them have the commonality of targeting the alterations caused by driver mutations. Because until then, all of our treatment was based purely on histology, adenocarcinoma, squamous carcinoma. Now we started discovering oncogenic driver mutations and trying to discover treatments for them. So in adenocarcinoma, a number of driver mutations are known. Of course, there is a chunk of tumors where we still do not know what drives them. EGFR is probably one of the earliest established EGFR mutations. And likewise, in squamous cell carcinoma also there are driver mutations. So the EGFR mutation was the first well-characterized alteration. EGFR is on the surface of the cancer cell. And when that is activated, it sends downstream signals into the cell, which causes progression of the cancer by cell division and so on. So we're blocking the EGFR with anti-EGFR antibodies. It was discovered that you could block this downstream progression of tumor. So you had agents which acted on the outside, like cetuximab and so on, agents which acted on the inside, which was geftinib and erlotinib. Those were the first initial agents, a number of trials to show this. And geftinib was the first drug approved in people with non-small cell cancer with EGFR mutation. And this is just to show you that where there's an EGFR mutation, the geftinib is better than chemotherapy. And where there's no geftinib. Then there was a second generation of targeted agents in EGFR mutation called afatinib. Now we have the third generation, osimertinib. So osimertinib has now been shown to be superior to erlotinib or geftinib in randomized trial. And therefore, a lot of clinicians would prefer to use this as a first line. So geftinib and erlotinib are getting used less nowadays because there's a definite improvement in overall survival. In fact, osimertinib also has been now approved in adjuvant setting, where not that we have that many resectable tumors, but where that applies, giving osimertinib as an adjuvant has a better overall survival in patients with EGFR mutation. Then the second best characterized thing was the ALK fusion gene. This is in about 5% of patients, where the first drug was crizotinib, where it was randomized against the standard of care, pemetrexed versus platinum, and showed to be superior in people who harbor this fusion gene. So you see the difference in the performance status, progression-free survival. Then there is a number of other drugs came. The second drug to come was ceritinib, and more recently drugs have come up, including alectinib. So alectinib now is the preferred choice because it is superior to ceritinib and crizotinib. And so now it has become the drug of choice in ALK fusion gene patients, where the progression-free survival is better. It also has a good effect on CNS metastasis. The other drug approved in this category is dacomitinib, where again the progression-free survival is superior to gefitinib or erlotinib. So your choice is between alectinib or dacomitinib. So this is just to give you a list of targeted agents now currently available in the market for different driver mutations. EGFR, I've already gone through the list. There's a new drug, avatanaba, which is for exon 20 mutation. All of these work on exon 19 and 21 mutation. For ALK again, I would say what we go to ROS1 gene mutation. Dr. Priya has already highlighted that they look for all the biopsies for gene studies. We have specific drugs here which are active against these particular mutations. All of them, with the exception of this on this list, are oral drugs. For non-oncologists, anything says it's an oral one, it's an intravenous one. So the messages from targeted therapy are that all these genes which I told you, EGFR, ALK, ROS, BRAF, MET, etc., they are well-defined targets, and several drugs are approved, and it's an ongoing work. There are more drugs being expected for these, and as well as the driver mutations for which we do not have drugs now, and they have, as I told you, moved from advanced disease setting to adjuvant settings. Targeted therapies are not, unlike what people think, totally safe. They also have their own unique toxicities, and sometimes dose adjustments, even withdrawal of drugs necessary, but they do not mimic chemotherapy toxicities. A lot of them have to do with skin toxicity, gastrointestinal toxicity. Yet another target agent which doesn't come in this category, something called bevacizumab. Tumors to grow beyond 1 millimeter cube, because until 1 millimeter cube they can get the nutrition by diffusion. But to survive beyond that, they require a blood supply. And since they do not have a natural blood supply, they secrete chemicals called molecules called VEGF, vascular endothelial growth factor, which causes new blood vessel formation. So agents which inhibit this new blood vessel formation or angiogenesis are called anti-angiogenic agents. Bevacizumab was the first of its category, which is also now used in non-small cell lung cancer, though I have to say that the benefit is very modest. It is used particularly in adenocarcinomas. In squamous carcinoma, there's a risk of bleeding, so clinicians are reluctant to use it. But as I said, the gain is somewhat modest. There is another drug in the same category called ramucirumab, which also can be used in combination with docetaxel, can improve in second-line treatment of patients, improve survival. So the targeted therapy message for bevacizumab, ramucirumab. There's also nintedanib, as I already told you, it is oral, so it's an angiogenesis inhibitor. But more drugs are being developed, which hopefully will be more efficient as well. Then comes the next decade, 2011 to 20, until now, is the decade of immunotherapy. So like I said, the 4 decades match my 4 decades in oncology. Immunotherapy are drugs which will help, to put it very crudely, improve the immunity of the patient to fight the disease. Specifically, the immunotherapy drugs which are available are targeted against T cells, which are supposed to be the key cells which monitor the emergence of cancer and try to eliminate them. So there are different ways of immunotherapy. One of the vaccines and other antibodies. We will focus on one kind of them. We will not go into all this this thing, but we'll go on to immune check inhibitors. PD1 is programmed cell death protein. This is called that because initially it was thought that this protein is to do with apoptosis or programmed cell death. But now basically we know it's an inhibitory molecule. The immune system in nature has inhibitory and stimulatory molecules because to create a system of checks and balances so that the immune system doesn't get too activated, you have the inhibitors. And for it to get activated, you have the stimulants. So PD1 is an inhibitory molecule. It has a ligand called PDL1. So just to show you this cartoon, in a healthy situation, a T cell will recognize the cancer and destroy it. But what cancers have done, they have also developed, because normally this healthy immune cells like macrophages and so on, they have a ligand for PD-1, which is recognized by the T cells which carry the PD-1. So therefore, it will be left alone. So cancer cells also are now present the PD-1 ligand, and they fool the T cells into thinking that they are part of the immune system. Therefore, they don't get destroyed. When you use an anti-PD-1 agent which will block this, the T cell will recognize the cancer cell and therefore destroy the cancer. So that's the principle of how the immune checkpoint inhibitors work. So you can either do anti-PD-1 or anti-PD-L1. There are subtle differences in the two. So there are at least 4 drugs in this category, and I'll quickly run through 3 of them. Pembrolizumab was among the earliest, where it was tried in combination with chemotherapy, and it was clear that there was a superior outcome. As you can see, the superior initial milligram, but now it's a flat dose of 200 milligram for pembrolizumab. So you see this on this graph where you can see that the pembrolizumab added advantage to adding it to docetaxel. So it improves overall survival and a favorable benefit to risk ratio. So FDA approved in 2016 in advanced disease, and in more recent years, pembrolizumab has also been approved for neoadjuvant treatment in combination with chemotherapy, as well as in adjuvant situation in the resectable lung cancers for a duration of 1 year. The next drug which was tried was nivolumab, which had somewhat similar results. These drugs have been developed by different MNCs, and that is why you have the differences. And there are subtle differences, but in terms of clinical response, there are very few head-to-head comparisons, but they are somewhat similar. So it's more a question of cost and administrative convenience. So nivolumab also in combination with chemotherapy showed that overall response rate and progression survival are significantly better than chemotherapy alone. So on the basis of this, this was also approved in 2015 in advanced disease, and now it's also approved in neoadjuvant and adjuvant. Atezolizumab is a third drug with similar kind of results, where all the parameters were better with atezolizumab plus chemotherapy. So you see there's an interesting difference in the way targeted therapy shows response and immunotherapy shows response. This is important for clinicians to know, because in targeted therapy, you have a specific driver mutation, you will see an early response. You will see an early response. And over time, it is possible that they may develop resistance. With immunotherapy, on the other hand, early on you won't see any response. The response will come later. Because sometimes you're given only 4 or 5 doses and you see no response, you might think that the patient is not responding to immunotherapy. We'll have to give it enough time. So most clinicians understand that a minimum duration of 6 months is necessary in order to decide whether the immunotherapy is helping the patient or not. Whereas the targeted therapy within a month or 2, you will know that. So there's a key difference. Most of the trials, in fact, have used immunotherapy for a duration of 1 year. And the side effects of immunotherapy are basically similar to autoimmune disease, because when the inhibitory molecule is suppressed, the T cells become more active. Just like in autoimmune disease, you end up with inflammation in various organs. So depending on which organ it is, you can have thyroiditis, hepatitis, colitis, pneumonitis, whatever. And of course, the classic anti-inflammatory steroid. So this can be reversed with steroids. Other than this, by and large, the immunotherapy can be said to be a side effect free drug, because this happens in less than 10% of patients. And even in those patients, if you can reverse it to steroid, there's no contraindication to giving the drug again to the patient. So the immunotherapy messages are that we have a lot of data only for PD-1, PD-L1. It is possible that we'll identify other immune targets in the non-small cell lung cancer. These 3 drugs are approved, as I said, in many settings, not only in advanced disease, but also in neoadjuvant and in adjuvant. The side effects already mentioned. Right now, the biggest deterrent is the cost. With all that, the last year data which I could get hold of says that in localized disease, 5-year survival is 65%, whereas in distant disease stage 4, it is 9% in 5 years. So there's obviously a lot of work to be done. But if I tell you that when I started in oncology, even this was somewhere. So we have made a lot of progress in 40 years. So what we are now coming to is the era of personalized medicine, where we have to not stop simply at histological diagnosis, but try to identify the particular genes which are driving their tumor and then try to offer therapy which will work on that. So it's no longer viewed as one generic tumor, but it's a collection of rare, a lot of diseases with different biological behaviors. So that is the future for. So 2021 to 2030, we'll have to wait and see what comes in this decade. Thank you very much.
Wonderful lecture. The targeted therapy and immunotherapy has modified the outcome of the pregnancy, and also stepped in from stage 2, they give step down to stage 2 and then go for a second. What about starting targeted therapy first and then going for immunotherapy later? So combination of the human result. You are telling targeted therapy initially will give good results, but later they have resistance.
Yes.
What about the combinations?
Well, exactly for the same reason, combination would be a good idea. In fact, starting upfront. Because the targeted therapy will do the immediate work, but immunotherapy takes time. So if you're going to offer it sequentially, it is possible that the disease will progress. So yes, it would be a good thing to offer them simultaneously. Thank you.
That case, for example, the oncologist, they start them on the targeted therapy earlier without knowing the mutations. Is that correct?
Well, I personally do not agree with that, because if you look mathematically, all these driver mutations I told you currently account only for about 15% of the non-small cell lung cancer, which means it's more logical to try empirical chemotherapy in the absence of enough evidence for a driver mutation. Immunotherapy, on the other hand, you could start, because even though Dr. Priya talked about PD-L1 expression and all that, the clinical data suggests that PD-L1 expression may not necessarily be a requisite for starting immunotherapy. But if I didn't know the driver mutation status, I would rather go for chemotherapy.
Yeah, please. So, we may identify the treatments for the clinic itself, so that we can use the alternate targeted therapy the brand. If we got acquired resistance, because we don't have that much knowledge of it.
It is acquired resistance a lot of time, because initially it does respond, and then over time, typically in about a year or so, you will see that the disease will progress while patient is compliant with the same therapy. And in fact, that is what led to the generation of the development of second generation, third generation drugs, and so on. So initially, for example, osimertinib was used when gefitinib or erlotinib failed, because then there was again a period of response, so on. But now, because of the superiority of the drug in terms of overall survival, a lot of people are using it upfront. It would be unlikely if you are very clear about the specific driver mutation. It is possible.
Thank you very much for this wonderful relation to the. And it was very much to the. The result that money gives the more to the because everyone wants to be a chairperson. And we have small announcement. We keep on glass bowl there in registration test. So I request all the faculty, it is right for me, the paper, please put it the glass bowl. This is the lucky topic. So after the registration of this program, we are going to choose the lucky topic and click from the MGS. So it is okay. We go to the next session. May I request the chairperson for this session, Professor Dr. R. Senior Sir, Vice Chancellor, Professor, from the respective medicine, hospital and institute. May I request the Senior Consultant Process Surgeon, MGM Healthcare. Welcome, Jay. May I request Dr. Rajiv Sandosh, Senior Consultant Process Surgeon, MGM Healthcare. Welcome, Rajiv. So, this session we have a speaker, Dr. Peter Dhanashekhar, Senior Consultant Surgical Oncology, President in Thoracic Oncology, Indian Cancer Institute. The topic of discussion is the role of surgery in lung cancer. Consider.
Very good afternoon to all of you. Thanks for the opportunity. So today my talk will be on surgeries for lung cancer with just a handful of surgeons in a pulmonology meet. It's a little bit difficult. Let's see what we can achieve. So November declared as Lung Cancer Awareness Month. So where do we stand here? So we'll go through about the indications for surgery, diagnosis and staging, rehabilitation, mediastinal staging, functional evaluation, lung dissections, extent of resection, mediastinal lymphadenectomy, minimal invasive surgery, and a word about oligometastasis. So surgical excision of non-small cell cancers offers the best chances for cure. But among lung cancers, we get hardly less than 20% are diagnosed in early stages. The major complications associated with surgery will be around 9 to 10%, while minor complications are around 19 to 20%. And most of these complications are related to cardiopulmonary problems. And the most common risk factor associated is chronic obstructive pulmonary disease. So surgical So where is surgery indicated? Generally, stage 1 and stage 2 are the stages which we offer surgery, with stage 2 getting post-op adjuvant treatment. And some stage 3 can be offered surgery, usually after a neoadjuvant setup. Rare stage 4 cancers can be offered surgery, which I will highlight later. So before going for any lung cancer or any cancers, it is a multidisciplinary team which comprises of the surgeon, the radiologist, or the bioimaging or the nuclear physician, pulmonologist, radiation oncologist, medical oncologist, palliative care specialist, and pathologist. And this has over time proven that MDT is mandatory for any cancer treatment and it is more specific for lung cancers. So do we need biopsy always? But do not depend on radiology alone. The clinical history is very important where we, especially in countries like India, where we have mix of both tuberculosis and nodes being picked up for malignancy on PET scans. Biopsy is always prescribed, and the most easiest strategy should be adopted, either CT guided or bronchoscopy. So rehabilitation for lung surgery is a very important topic because, as told earlier, cardiopulmonary complications are the most. So a smoking session of at least 4 weeks prior to surgery is of utmost importance. Bronchodilators, when necessary, should be started. Chest physiotherapy and spirometry should also be simultaneously started. And 2 to 6 weeks of highly intensity interval training with nutritional rehabilitation significantly improves outcome across series. So this is the outcome showing rehabilitation as well as no rehabilitation. So this can be propounded or expected in the form of early extubation, reduced ICU loss, early discharge, and improved functional status compared to patients who do not receive any form of rehabilitation. So this is the invasive staging. So the first and foremost, we do a CT or a PET CT. If it is mediastinal lymph node negative and it's a peripheral tumor, we can go directly for surgery. If it is an N1 or a central tumor with tumor more than 3 centimeters, the tissue confirmation of the with a EBUS or a video-assisted mediastinoscopy. And if the lymph nodes are negative, we can go for surgery. And if they are positive, we go for multimodality treatment, either in the form of neoadjuvant therapy or radical CTRT. In case if the nodes are positive, a tissue confirmation with a EBUS or a EUS. And if nodes are positive, they go on for multimodality treatment. And if negative on EBUS, we might require a video-assisted mediastinoscopy and again follow the same principle. So mediastinoscopy is the most valuable and the most invasive of the invasive staging. Levels 2, 4, and 7 must be included in the tumor. It is more useful for centrally located tumors. In all positive PET scan with showing lymph nodes, the mediastinoscopy might be added up. And in lymph nodes bigger than 16 millimeter on CT can be avoided in peripheral lesions with a negative PET scan. If a mediastinoscopy is not useful, a EBUS and FNAC, but it is highly operator determined, we now have a positive rate of around 50% of patients. The next comes the functional evaluation patient. The patient being worked up for surgery, we can go with the effort tolerance test with a 3 flight of stairs, a 3-minute walk test, a pulmonary function test, and a diffusion lung capacity with a preoperative, the predicted postoperative FeO2 of greater than 40%. A 2D echo is always added. So this is the short workup. So with a moderate risk, with a low or moderate risk, simple spirometry with a preoperative FeO1 and DLCO less than 60% is considered low risk, can be taken up for surgery. If it is a high risk, patient goes for cardiopulmonary exercise testing. This is the table, and accordingly we categorize and strategize the risk for surgery. So for medically unfit patients, non-surgical options like SBRT, RFA, or microwave ablation can be attempted. And SBRT can be an option for treating patients in stage 1 because of only medical unfit. Otherwise, surgery should be the option of choice. So this is the normal lung anatomy. So the right consisting of the upper, middle, and the lower lobe, and the left consisting of the upper lobe and lower lobe, and a small lingular lobe in between. So these are the lung resections, and only a small part of a lobe is removed. We call it as wedge resection. When a segment of lung is removed, depending on which number of segments, we call it a segmental resection. And lobectomy is where an entire lobe is removed, and if one lung is removed, we call it as a pneumonectomy. So this is the post-lung resection, the wedge resection, segmentectomy, lobectomy, and pneumonectomy. So that has been a significant evaluation in evolution of lung surgery. We had the first pneumonectomy somewhere in 1930, which is a double-stage procedure, and almost took 25 years to come over with the lobectomy. And now we are thinking of some cases where we can do limited resection, which took another 35 years. So extent of resection, whether we can do a sublobar resection in cases of early lung cancer. So it's a prospective RCT with limited resection of lung. So the sublobar resections are associated with 3 times local recurrence rate and a 30% increase in overall death. So till now, lobectomy is the gold standard for a lung cancer, which is early stages. But now sublobar resections are getting an renewed interest, especially where we have tumors which are being picked up on screening because of better imaging and multi-detector CT, especially for ground glass opacities. So trials for sublobar resection. So we have 2 trials here, KCOG 802 and the CalGB. So the short-term outcomes in case of sublobar resection, increased blood loss, air leak, ICD reinsertion with segmented, but other outcomes are similar, while the CalGB shows no difference in prior mortality and morbidity. So next will be our lymph nodal dissections. So this is the nodal stations, the supraclavicular zone or the station 1, which is low cervical, supraclavicular and sternal notch nodes, superior mediastinal consisting of the 2R, 2L upper paratracheal, 3A prevascular, 3P petrotracheal, 4R and L corresponding to the lower paratracheal perimetral side perspective. The aortic nodes, station 5 is subaortic, station 6 para-aortic, inferior mediastinal, station 7 subcarinal, station 8 parasitial, and station 9 pulmonary. And the N1 nodes are the hilar, interlobar, lobar segmental, and subsegmental nodes. So this is the treatment for early. So to find the level of mediastinal lymph node sampling versus mediastinal lymph node dissection. In sampling, we remove only a particular group of nodes, where the lymph node dissection will remove the entire N1 and the N2 group of nodes. So this study has found there has been a conflicting results, some saying mediastinal lymph node sampling alone is sufficient, while some go with increased expertise, lymph node dissection might be a good contribution. So this is the meta-analysis showing results for overall survival, local recurrence rate, and distant metastasis were similar between mediastinal lymph node dissection and sampling in early stage NSLC patients. But there is no evidence that nodal dissection increased complications compared with sampling alone. So what approach for surgery? Either we go about with a thoracotomy or a minimally invasive surgery. So minimally invasive surgery, we can have for any lung resection, we can have by open procedure, by a VATS procedure, which is video assisted thoracoscopic surgery, or a RATS procedure, which is robotic assisted thoracoscopic surgery. So VATS, the limitations are a steep, sharp learning curve. Should be a competent thoracic surgeon to deal with complications arising out of your VATS, and no compromise in oncological security till proved, and reduce complications after a good learning curve. So this is what the armamentarium of our open thoracic surgeons, and this is now converted to the one on the left side is your VATS procedure, where we have long instruments to go into the thoracic cavity. So trials for minimal invasive surgery, we have the Violet study, which showed a significant betterment compared with your open thoracotomies, with a post-op stay of 4.8 versus 6.7 days, reduced cost of surgery, reduced OPD visits, admissions, and better quality of life. The lymph nodal staging is also upstage, 6.2% in your minimally invasive versus 4.8 in your open studies. So this is your video assisted surgery, and this is on the right side. So on the left, that is a uniportal VAT surgery, where we use only a single port to where all the instruments go into the thoracic cavity for removal of lung problems. And the one on the up is your multiportal VATs. So surgery in oligometastatic is going to be a little bit controversial, defined as a heterogeneous disease that is isolated or restricted to limited metastatic sites. Clinical trials have included patients with 3 to 5 metastases. So these metastases can be synchronous, where the primary and the metastatic disease are identified at the same time. Metachronous, where the metastatic disease is diagnosed more than 6 months of the primary occurrence. Oligorecurrence is a recurrent metastatic disease which is limited to a few sites, 3 to 5. So this is a trial for including oligometastatic disease, low risk metachronous, NEN, which have 5-year survival of 48.8%, but an intermediate risk has a 5-year survival of 36.2%, and a high risk synchronous having a 5-year survival of 13.8%. So this is for oligometastatic disease, local consolidated therapy with or without maintenance therapy for patients with 3 or fewer metastases from NSLC that did not progress after initial systemic therapies have an improved progression-free survival with maintenance therapy alone. So the outcome of oligometastasis depends on picking the right patients. Isolated brain, lung, or adrenal metastasis, N0 disease, and lobectomy if possible in case of small T1s. They have a longer DFI. Adenocarcinomas and driver mutation positive are better outcomes, and engage are better outcomes. So thank you for your patient listening.
Thank you, Dr. Second part of the presentation. You have already indicated the various options available and basic advancements in the access to therapy. I acknowledge Dr. Raja, the Director of Oncology and thereafter for our business. wish success for the early cancer screening program at MGM. Over to Ajay.
Thank you, Dr. Dhanashekhar, for a wonderful talk. I just have one question. What do you routinely follow for staging at your institute?
So here we almost receive, as we know that very less number of cases. We generally go with the PET CT and the EBUS. We have good backup from the pulmonologist here.
And what would be your approach to your multi-station N2? Because that is right now.
Yeah, we are
changing. The multi-station N2 was earlier considered unresectable.
Now we mostly go for neoadjuvant chemotherapy. We have for such cases, we might use for a mediastinoscopic assessment of the N2 dose. If it is going to be positive, we go for neoadjuvant chemoradiations. Depending on the fitness of the patient. If patient is surgically fit, we can consider for neoadjuvant chemo, then reassess for surgery. If deemed unfit, we can consider them directly for radical CTR.
So the latest IASFC meeting held in September in Singapore, they said multi-station N2, if it's potentially resectable, we can give a perioperative immunotherapy and take them directly for surgery.
We are starting with the neoadjuvant immunotherapy.
That's why I just wanted to clear it to the postgraduate. Yes. So multi-station is no longer considered
as
inoperable. Consider surgery for
probably in our country where the patient general condition is not very good and associated TB and other diseases, we are still not going into that era of getting such into operable diseases.
Another is the nice talk. I'm happy that you're including rehabilitation and all these ELAS protocol in your work. Goes a long way in the patient outcome.
Yes,
Thank you, sir, for this wonderful presentation. Certainly, aspects of cancer management. I request the chairperson to give the motion to the speaker, Dr. Dhanashekhar. May I request the speaker, sir, to give the motion to the chairperson. Speaker, sir, to the chairperson. Thank you, Rajeev. Thank you, Jay. Thank you, Dilip. Thank you. Thank you. We move to the next session. This is the last session in this pre-lunch program. May I request the chairpersons, Dr. M. Senior Consultant Pulmonologist, Hospital, Chennai. May I request Dr. N. Meenakshi Ma'am, Senior Consultant and Professor, Respiratory Medicine, Hospital and Research Institute, Chennai. And Dr. N. Rajeshna, Senior Consultant Radiation Oncologist, Indian Cancer Institute, Chennai. Welcome. Speaker of this day is Dr. S. Alex Prasad, Senior Consultant Radiation Oncologist, Indian Cancer Institute. The topic of presentation is the modern advances in radiation oncology in lung cancer treatment. Over to Dr. Alex Prasad.
That doesn't work. This doesn't work?
Not working. Not working.
Not working. Fine. Oh. This is not working. Yeah. Captain of the law. Dear friends and colleagues, good afternoon, dear chairperson. Good afternoon. At the outset, I would like to thank Dr. Jayam and chairpersons for giving this wonderful opportunity in front of this august audience. It's a big thing to get a good audience like this. Thank you so much. So I would like to say that in the next few 20 minutes, I'm going to deliver in terms of advances in terms of radiation oncology in terms of lung cancer. I'll make sure that it's sharp and crisp and cute and customized. You did not worry like this person. I like this gentleman because he's I look at him like he's full of emotions and his body language. I just adore it. And I don't want to come to this without Jayanam and people have discussed in terms of the epidemiology, and it's a common and death rates worldwide, and survival is 5 years is 50%, and smoking is 90%. And in India, the surface of lung cancer is going to become 10 the head and cancers. The incidence increased threefold during the last decade. Radiotherapy lung cancers. Hello? Hello? Not working? The other one. Yeah, that's right. Radiotherapy plays a very important role in lung cancer. 90% of all lung cancer receive radiation therapy at some point of time. Only 10% of them go to other people. 90% have to enter into a radiation oncology department at some point of time. It can be radical, palliative, post-operative, prophylactic, whatever it is. But 90% of the cancer patients in lung cancer come into radiation oncology department. 5% of lung tumors are amenable. And there's only 5% of lung tumors are amenable cells. 95% of the other people enter into the other modalities or like medical oncology or radiation oncology, the other departments. And advances in delivering radiation therapy, look at the 1950s started like this. The gantry polymeter was at the target site, and now we have the latest one, where the gantry is away, the polymeter is away to the target site. But again, now this is the program one. This is the gantry and the polymeter the target area. So the advances in delivery area, these are the things which you can see through. So if you look at the advances in terms of radiation therapy, there are three triads which are looking through. One is dose escalation to the target, dose avoidance to the target risk, and the tumor motion. These are the triads which look in terms of precise radiation or in terms of high precise radiation. High precise radiation is otherwise known as HPI. The three triads, which is dose escalation to the target, dose avoidance to organisms, and the tumor motion. These are the triads. So RT techniques, if you look into the CT scan is the treatment position. We have GTV, CTV, and PTV. GTV is the gross tumor volume, which includes the gross tumor and gross lymph nodes. CTV is the Harvard micrometastasis, which includes the higher PSM, and the PTV is available from the planning target volume. Well, the planning target volume is the one which includes in terms of the margin for physiology, for organic motion, and this is the one which helps in terms of geographic measures for the target. So that the geography is the main thing which we look into. So PTV is the one which helps that. And this is the technique static tumor. This is how the tumor is being treated by. And this is the moving tumor with margin. If the tumor keeps moving in expression, we try to give a geographic margin that this is the moving tumor. And mover tumor gating. This is called IGRT, image, image guided radiation therapy. When the target gets moving around with the tumor. Moving tumor breath hold with inspiration and expiration. It gives the field goes exactly on the inspiration and expiration along the tumor. Moving tumor with tracking, with cybernetic. Cybernetic, you heard about it. It just keeps up, just like a artificial dog, and it keeps going with that. So the tumor, the tracking, the cyber keeps tracking the tumor behind that. And this is a cyber light. It looks like we have it's like a robotic gantry light. And you have a polymeter there. And it keeps moving. There's something called isosceles tumor, through which it keeps operating on the target area. Moving tumor tracking. This is dynamic MLC. Multiple polymer is the main thing. Because of the multiple polymer, that's why the advances in terms of radiation scaling, involved IMRT, and we my technique and we only because of this multi-link polymerase. Third is known as dynamic modified multi-link polymerase. Deforming tumor tracking. Some of the tumors keep deforming with inspiration and expiration. That also will be taken by the tracking with dynamic multi-link polymerase. So most of the times, treating mobile tumors are treated in terms of IMRT or IGRT or BMATEC. And this is a megawatt phototherapy is one you have here. Same thing, Electra over here in MGM Healthcare. Symptoms, most of the tumors we see centrally it's cough and hemorrhages, peripherally cough and pleuritic chest pain, and nerve entrapment, vascular obstruction, esophageal narrowing, symptoms due to metastasis. In the metastasis, small cell lung cancer 60% and 30-40% is about non-small cell lung cancer. The chances of incidence metastasis is high, but it's more in small cell lung cancer. Surgery, in a nutshell, we say stage 1, surgery is the mainstay, SBRT, stroke. Stage 2, surgery is the mainstay, SBRT, and stage 3, surgery plus RTR, chemotherapy and radiation, and immunotherapy. Stage 4, palliative RT. So, stage 1 and stage 2, if you look at the surgery is the mainstay, if the patient is amenable to the surgery. The patient is not amenable to the surgery, SBRT is another option to available here. Post-operative radiation therapy, margins, the indications of margins, 1 centimeter, nodal positivity, perinodal invasion, lymphovascular invasion, peritoneal invasion. These are all the indications for post-operative radiation therapy. And this is about the conventional radiation technique. Earlier surgery was the overall survival was 57 to 66% with the surgery. With the conventional radiation techniques, it was only 50%. But these advances in technology, that is overall survival has now been much higher in radiation technique. Again, the man with emotion. Radiation therapy techniques, the radiation therapy techniques better results with dose escalation. Difficult to achieve with conventional radiation with the dose escalation cannot be considered with the conventional techniques. Only with the advanced techniques we can do for dose escalation. Delivery techniques, SBR, cyberknife, real-time motion management, brachytherapy, these are all the other advances in terms of radiation therapy. IMRT. IMRT, otherwise known as the intensity modulated radiation therapy. In other words, I would say IMRT is just maybe a very small advancement in terms of 3D SCRT, otherwise known as 3-dimensional conformal radiation therapy. The idea is to make sure that the dose escalation to the target is high and the dose avoidance is being done here at tumor motion. And the thing is, in the IMRT, the GTV is larger and the amount of radiation, otherwise the integral dose of radiation or integral dose is much less than the normal tissue. So this has resulted in 10% decrease in terms of radiation pneumonitis with IMRT. Earlier, the amount of radiation pneumonitis with conventional techniques was really high. And this is this planning you see here. This is the target here. And you can see a field 1, 2, 3, the field of 4, field 1 to 4, 5, which is targeted around the area there. The dose escalation, dose avoidance is the main thing. And IMRT has been a big thing for prostate, head and neck, and other areas. The amount of thing is the 10% decrease in risk of radiation pneumonitis has come down with IMRT. With 3-field RT we see here, it's like this. You get a flat field here, and even the organ risk gets an amount of radiation along with PTV. So with the planning target volume, the organ response gets the amount of radiation, which is not acceptable. And if you see here with three field IMRT, the beam becomes shaped wise. Every beam becomes a beamlet, and every beamlet has its own sequences. And every beam has its own sequence like this because of the multi-leaf collimator. And ultimately you get a proper distribution at this area over here. If 98% yellow, here that is about 60% in the normal areas. It's about it's reduced beyond from 98% to the target area. Dose volume histogram. This is this is the target area being about the full person, 100% and 50% comes over here. The organ is like intermediate part, the amount of dose is less than 40 grains compared to 80 grains given to the target area. SBRT is otherwise known as stereotactic body radiation therapy, or in terms of SART, stereotactic ablative radiation therapy. That's actually a highly conformal dose intensive RT, non-invasive treatment, precise delivery of ablative dose radiation. Compared to fractional radiation, SBRT has been superior local control of survival, and that is known as SBRT. NCCA guidelines say stage 1 and stage 2, wherever operable, can also be taken as an alternative for stereotactic body radiation therapy. And if the patient becomes medically inoperable, we use for SBRT. The results are comparable in terms of the surgery as well as SBRT. The principles of radiation therapy commonly used doses for SBR. Single fraction, 24 to 34 gray. The tumor has to be less than 2 centimeter and less than 1 centimeter from the chest wall. Single fraction. 45 to 60 gray, 3 fractions, peripheral tumors, and has to be 1 centimeter from the chest wall. 48 50 gray, 4 fractions, which central of peripheral tumors, which is 4 to 5 centimeter and 1 centimeter away from the chest wall. 50 55 gray, 5 fractions, central peripheral tumors. 67 degree for central tumors. See the amount of hyperfraction, number of fractions decides upon the size of the tumor and its location with primary bronchus and at the chest wall. That's the one which decides on that. Patient selection for criteria for SBRT. The early stage non-small cell lung cancer don't want for surgery. Stage T1 to T3, no following. Maximum given 5 centimeter, they have to go for the adjacent to major structures like vessels, heart, esophagus, able to lie flat for at least 1 hour. And SBRT in other ways in terms of 4 or 5 fractions from 8 day or even higher per day. Number of fractions has to be 4 or 5. The types of lesions, peripheral lesions are located about 2 centimeters from the primary bronchi. Central lesions 2 centimeters from the proximal bronchi, and averting the mediastinal pleura, and alpha central lesions averting the proximal bronchi. This is the type of lesions you look for SBRT. SBRT by stereotactic by body radiation therapy, given in terms of a VMAT technique or by a IMRT. VMRT or rapid art. The VMAT is the one that is art technique where the dose of radiation goes with art therapy. And the thing is, with the VMAT technique is the integral dose which is less compared to IMRT, where the dose to integral dose is higher. So that's also VMAT technique is much better to give in terms of SBRT. Patient positioning and immunization, treatment planning. The recommended is direct IMRT VMAT reduces the integral dose to other areas as much as possible. Mandatory 3D conformal treatment technique, respiration, 4D CT imaging, IDE based motion management. Recommended is dynamic IMRT and use of fixed dose individual PDB. That's a recommended one. Fusion images, planning CT scans, and slice of thickness should be 2 to 3 millimeters. IV contrast should be used, and 4D CT is recommended if possible. And target volume definitions, passive motion and active motion. Active motion in terms of gaining, breath hold and tracking, and passive motion, abdominal compression, internal targeted volume, mid ventilation concept and jet ventilation. Deep inspiration breath hold reduces tumor motion while increases the lung volume, resulting in decreased doses to lung and often to the heart as well. Peripheral tumor, this is actually from a study by Timmerman, one of the pioneers in terms of SBRT. For peripheral tumors, is go for 60 gray in 3 fractions. And the primary failure was 7.8%. The overall survival is 84%. And grade 3 toxin is 60%, which is acceptable. Central tumors, by as to 2016, for central tumors, the amount of fraction is in terms of 50 grain in 5 fractions and 60 grain in 5 fractions. The number of fractions are slightly higher. And the local control is 88%, and the PFS is 52.5, and overall survival is 70 to 73%. Grade 3 toxin is 7%. Acceptable. Toxicity, radiation pneumonitis, about 12 to 15% is for pulmonary fibrosis, chest wall pain, 11 to 15%, and 2 to 3% will go for refractions. Skin toxicity, 4 to 6%, brachial pressure, fatal bleeding, and later radiological changes 2 to 8%. So radiation pneumonitis is about 50%, and chest wall pain is 15%, out of which 2 to 3 is rib fractures. And this is the ultracentral tumor, and there's a central tumor, and this is the central area where you have all these organs like trachea, esophagus, heart, brachial plexus, major spinal cord, all of them come to this individual area. And that's ultracentral tumor, there's a central tumor with a venous cell tumor. Difference between SBRT and the normal fractionation. You see, this is actually a normal fractionation. This is SBRT. This is transaxial, coronal, and sagittal sections. We see here there is integral close to normal area here, the normal tissue. But if you see here for SBRT, the axial, the coronal, and the sagittal sections confined exactly to the target area, and they are more close to the normal tissue, the normal area, or normal lung is as much as possible reduce that. You get confined to the target area. Workflow, simulation, tumor, plan analysis, trial setup, treatment delivery, follow-up care. There's a big workflow over there for SBRT. So patient selection for SBRT, I would say stage 1 and stage 2, T1 to T3, N0, N0, NSCLC who are medically inoperable, high risk elderly users. SBRT has no established role in terms of small cell lung cancer. SBRT was weight restriction. NSCLC, the SBRT prescribed is 48 T1, 60 grade T2, 4 to 5 fractions. And the difference in terms of disease metastasis, freedom from failure, case-specific survival, it was higher compared to the weight restriction 30 months time. SBRT was a surgery. The combined study with Roswell stars analysis, T1, T4, T2, no medically operable one, SBRT 54 fractions, 3 fractions, 50 grade 4 fractions. The survival, overall survival was SBRT of 95% compared to surgery 79%. And the toxicity was SBRT 10% and 44% was surgery. The toxicity surgery was higher. And brachytherapy, endobronchial radiation therapy, it is like the endobronchial catheter is placed inside the tumor area, and those enters into the endoluminal area and not in the parenchymal thing. So this is actually done through the bronchoscopy, through the the biopsy area, through which the catheter is passed, and then the source just goes here and goes the amount of radiation and comes out of the catheter. This is with the X-rays technique, you can find out exactly where the disease is seen. But actually, when the bronchoscopy is done, they find out the disease between the carina and the lesion. From the carina, this is the about 2 or 3 centimeters away from the lesion. That can be taken here with the placement of these catheters, where this dummies with 1 centimeter radial opaque ones, which will tell you exactly from carina what is the lesion is. Giving high dose of radiation to the target. The EBRT, the complications of radiation bronchitis, airway stenosis, massive hemorrhage, fistula formation. But basically, endobronchial radiation therapy, palliation is the main thing to be here. Interstitial radiotherapy not being advocated because it's very painful. CT guided and USC guided needles are passed through the intercostal thing. It's very painful, so it's not being advocated as a therapy now. Dose and volume for elective nodal radiation is not being recommended now. The grass disease, primary and involved modes, 65 to 70 gray is the recommended one, but elective nodal radiation is not being recommended these days at all. So this is the radiation therapy portal. This looks like. Just the next few slides to finish. So you need not worry about it. Next few slides. For protons, so without protons, we cannot complete this this lecture. So protons, the thing is proton beam. There is something called Bragg's peak. This is basically a physics thing. And if you see here, this is the Bragg's peak. This is the superficial area, and photon keeps going like this. But if you see in a proton, the Bragg's peak goes deeper area. So you can go for high dose of thing to the deeper areas. So the other thing is this is an extended modified proton beam. This is a normal daily proton beam where the Bragg's peak is here, and this is a modified proton beam which is being slightly bit broader. So the technique which is being used as a modified proton beam, which is being used for proton therapy now. You see the advantages in the photon beam, the high entrance and exit dose is high. Whereas in the proton beam, the low entrance and no exit dose at all, in the proton beam at all. So proton has advantage in terms of the photon here. Some literature review, and this is the proton unit looks like. So to conclude, I would say that advances in radiation therapy delivery, SBRT are a big boom in treating lung cancers with good results with minimal toxicity. Always, judicious choices needs to be done. Brachytherapy, a consuming expertise, and wherever feasible for endelevel treatments, brachytherapy should be considered. Proton beam therapy trials are underway, which may show soon throw light on the good tumor control in the future. So I'd like to give a few great minds before I finish. Great mind Galileo, genius mind Einstein, ordinary mind Newton, brilliant mind Gates, never mind. So, ladies and gentlemen, I appreciate your time. You had a wonderful audience. Thank you very much.
Wonderful, excellent presentation. I appreciate your time, but never mind, very nice. But only problem is what are the reference rates in DRT? What is the cost? Only problem is cost effective availability. Those two are the factors which will maybe advanced techniques you have it here. You are doing it here.
Yeah, SBR is being done. At least a couple of years we've been doing it.
What about the role in cranial radiation?
What is this?
Cranial radiation.
Cranial radiation is only for small cell lung cancers, not in terms of non-small cell lung cancer. Very few we come across the small cell lung cancers, but the patient has to be, completely under control. There should not be any evidence of elsewhere. Then we take for prophylactic cranial radiation for small cell lung cancer.
That I understand, but SBRT whether that can be tried in future or not.
For cranium? It's being done. Yes, being done. That's actually, madam, the advantage in terms of SPR is hyperfractionation, short course of duration. You can finish the whole thing in 1 week's time, which used to be about 6 weeks time earlier. 30 fractions in 6 weeks time. Now we have 5 weeks, 5 fractions in about a week's time. And much more, the patient is much more compliant with this. 1 minute, sir. Proton therapy, I'm not yet to see, but literature says proton is much more better. Yeah. Proton, they have I think in the Apollo Proton here, and now they started in Tata Memorial Center. So when we have this Tata Memorial protocol, then we will follow that. Oh, yeah. The motion management is now being done much better. Inspiration, expression, everything. Yeah. Thanks.
My target volume is not changed. My target volume is not changed. So what has changed is my treatment volume. So the imaging as well as tracking technique and base treatment control both nowadays to make sure the target treatment volume has reduced. Target is all the same. That's the main thing. And one more thing to add on proton, there is something called as the upright proton. So that is the most of the time what we treat in the patient is the supine portion of the prone portion, which comes in the 9%. But in the upright proton, they are treating the sitting portion. That's one thing that's coming out. So the trials just finished and few papers are coming out. And there is also happening with the lung issue and lung cancer. Thank you.
Thanks, Jairam, for the initiative and giving us an opportunity. Thank you for the presentation. We want to do other speaker analysis. I request Dr. to do that. I want to do the chairpersons. Thank you, Commissioner. Thank you, Madam. Thank you, Registrar. So now we have the break for the lunch. I request everyone to the and have lunch. 30 minutes. Now the time is 1:45. Again, we'll join at 2:15. So 30 minutes lunch we can join. We'll have a final discussion. There are final 1 and final 2. Followed by we have the quiz program for the prize cash award. For the delegates also, they can also the quiz program. They will speak to the cash prize for the delegates also. We are going to kindly join for last lunch. Thank you.
இல்ல சார் இது லைவ் போகுது நான் நீங்க பிபிடி மெயில் அனுப்பு
Thank you.
அக்கா கொஞ்சம் ஃபோன் பண்ணி பேசிடுங்களா? ஃபோன் பண்ணி எடுக்கவே இல்லையா நீ?
ஸ்லைட் சேஞ்ச் பண்றது கீழே வந்து இந்த ஃபார்வர்ட் பண்றது எப்படி பண்றது வீடியோ இது ஆஃப் பண்ணலாம் இங்க சொல்லுங்க இன்னொரு வீடியோ இருக்கும் ப்ரெசென்ட் பண்ணும்போது இந்த ஸ்லைட் வர மாதிரி வச்சிருங்க சரிங்க இல்லையா ஜெயராமன் சாரோட தான் ஃபர்ஸ்ட் அப்புறம் தான் என்னங்க டெஸ்க்டாப்ல இருக்கு டெஸ்க்டாப்ல இருக்குல்ல தேங்க்யூ ஸோ மச் சார் ஹலோ சொல்லுங்க ஹலோ சொல்லுங்க சார் சார் அது உங்க டீம் தான் அதான் உங்க டீம் தான் சார் பண்றாங்க லைட் ஃபுல்லாவே அவங்க டீம் தானே சிவகுமார் இல்லைன்னா அவங்கதான் இதுக்கு முன்னாடி யாருன்னா இவங்க பார்த்துட்டு இருந்தாங்க அப்போ வந்து சிவகுமார் சார் தானே வந்திருக்காரு அவர் தான் மேம் பேனல் டிஸ்கஷன் தான் சும்மா கேஸ் போட்டுட்டு அதுக்கு அது இது போட்டுருவாங்க அந்த இது போட்டுருவாங்கல்ல ஸ்கிரீனு இந்த ஸ்கிரீனு என்ஜின் ஸ்கிரீன் திருப்பி நான் ஷேர் பண்ணி அப்புறம் திருப்பி ஸ்டாப் ஷேர் போச்சு இதுலயும் 5 மணி போட்டுருக்காங்க 5 மணி போட்டுருக்காங்க அவன் எடுத்து ஒரு மெயின் போயிட்டான் இல்லையா நான்வெஜ் சாப்பிட்டோம் ஃபீவர் எதுக்கு வந்த ஏறிக்கிட்டே இருக்கு மாத்திரை போகணும் என்ன போறது போய் டாக்டர் ஏதாச்சும் ஆன்டிபயோட்டிக் ஆன்டிபயோட்டிக்ஸ் எடுத்தது அதுக்கப்புறம் ஆன்டிபயோட்டிக் வேக்சின் வந்து அப்படிதான் பொறுத்தவே போதும் எடுக்க மாட்டேன் டேப்லெட் கேட்பான் இல்ல உடம்பு நம்ம படியும் அதே ஆட்டோ ஃபீல் ஆகும் திடீர்னா மட்டும்தான் நம்ம எடுக்கணும் உடம்பு ரொம்ப நீ வேலைக்கு போறவங்க ரிஸ்க் எடுக்கணும் ஆனா இருப்பான் ஆனா வந்து 2 நாள் பார்ப்பான் முடியினா மட்டும்தான் டெவலப் இருக்கும் சாப்பாடு ஆவி பிடிக்கிறது அந்த மாதிரி இல்லவே இல்லை வேற இது மட்டும் தான் இருக்குது இது வந்து மார்னிங் வச்சுட்டு போனாங்க அதுவே காணும் ஸ்டாண்ட் மட்டும் தான் இருக்கு
It's okay.
Okay.
YouTube.
Hello. Panel discussion, NDPPT தான் சார். நீங்க ஒன்றும் ஆகுது. வேற யாராச்சும்
housekeeping. Housekeeping யாருக்கான 5 chairs போட சொன்னாங்க. யார் housekeeping?
இதை பார்த்துட்டோம். டிவி ஆஃப் பண்ணிட்டேன்னா வருது. அது வராது. இதுதான் எப்போ அதை
ஆமா ஆமா கரெக்ட். ஆமா அனுப்பிச்சாரு. ஆமா கரெக்ட் பாக்கெட் கேசஸ். டிஓபிடி கரெக்ட். ஓகே. ஆமா ஆமா காலேஜ் தான். யா ஓகே. யா எடுத்துலாம். You can do the CT chest. Yeah, HRCT எடுத்துலாம். Yeah. போடலாம். Yeah, you can start. Yes, you can start. I told her we have to look the OAC also.
ரெண்டாவது நிக்குது.
The patient is not turn up again. Anyway. Okay, please proceed.
அதெல்லாம் இதுதான் சாமி. சாமி
டிவில பேச
அதான் ஆகாது சொல்லிட்டேன்.
ஸ்டார்ட் பண்ண போறாங்க. ஆல்ரெடி நேற்று நைட்டு ஃபுல்லா யாருல இருக்காங்க, ஏன் கேட்டிட்டு இருக்காங்க, ஒரு நாள் ஃபுல்லா இருக்கும். சரி, வேற பேட்டரி எடுத்துக்கோங்க. யூரோஸ் எல்லாம் தாங்கும் அதெல்லாம் ஒரு நாள் ஃபுல்லாவே போறோம். ஒரு சில நாள் ஓடும், ஒரு சில நாள் ஓடாது. அது மைக் பிரச்சனை, பேட்டரி பிரச்சனை தெரியாதுதான் ஓடும். பின்ன மாத்ததான் இருக்கு. ஓடுனா யாரும் அதெல்லாம் ஒன்றும் பிரச்சனை இல்லை.
இந்த பைக் ஒப்பனதா
1 minute செக் பண்ணுங்க.
அங்க 2 பைக் வைங்க. அங்க 2 நான் இது வேணா இது ஆன் பண்ணி போ.
இது ஒர்க் ஆகுது சார்.
ஒர்க் ஆகாதா? அப்படியே பைக் தரணும் பைக் இருக்கு. வேற பைக் இருந்தா பாருங்க. ஸ்டார்ட் பண்ணலாமா? மூவ் ஆக மாட்டேங்குது. ஸ்லைட் மூவ் ஆக மாட்டேங்குது. ரைட் ஓகே. மைக் கொடுங்க, லைவ் ஆன் பண்ணுங்க, நான் போயிடலாம். Yeah. Very good afternoon. We'll start the panel discussion. I will be the moderator. May I request our panelists. Welcome Dr. Kaushik. Take the dais. I welcome Dr. Prabhurandan, radiologist. May I request Dr. Jovita Martin Daniel, medical oncologist. Dr. Anvarasi, radiation oncologist. And Dr. Rajesh Santosham. Please, sir, take over the dais. We'll start the panel discussion now. So we have 2 panel discussion. So first panelist I will be moderating. The second panelist will be moderated by Dr. Tyagis. So each 30 minutes. So short case presentation and followed by 11 panel to answer crystal clarity matter. So we start the case presentation first. Yeah, this is the case 1. Prabhu, welcome. Please. This is a 55 years female, asymptomatic, non-smoker, non-diabetic, underwent a routine nostril checkup. In the chest skygram, they found that lesion in the right upper zone. So the master checkup consultant recommended a CT chest and consult pulmonologist. So Kaushik, so what do you think in this case? Yeah, come on. Monitor there, monitor. This case, the female asymptomatic, non-diabetic, hospital checkup. We found that just Karakan lesion showed there is a right upper zone lesion. So hospital checkup consultant recommended CT chest and consult pulmonologist. But the Kaushik both oppose this case. What are the levels of diagnosis?
So, the 55-year-old female, non-smoker. So there is a lesion in the upper right upper. First, the lesion is a very broad term, so I would like to see the X-ray if that is available.
Yeah, well, coming to us, there is no X-ray, but basically, patient took the CT scan and went in our OPD. So this is the CT scan of the chest.
So, CT scan shows the right upper lobe nodularity with borders are not very smooth, lobulated borders, but not classical stipulations are seen. So I would go ahead to ask further history. Is there any history of airway diseases, anything?
No, sir, no other complications. It's a totally different healthy individual.
This is a plain CT.
Yeah, this is a plain CT.
Contrast, I think I would advise this patient.
Okay.
So once there is a contrast, depending upon the enhancement, if there is any malignant pattern, then probably we can either go for a PET CT or go directly with biopsy.
Okay, what kind of biopsy are you planning? This patient underwent contrast CT, which shows a mass lesion suspicious of malignancy in view of the speculated margin, irregular border, and high powerful unit and all. They suggested radial sections. They suggested for the biopsy. So, what kind of biopsy? Bronchoscopy biopsy or image guided biopsy or implant?
This part I will not be able to say whether whether it can be done with a bronchoscopy. So I have to see if there is a leading bronchus sign or there is a positive bronchus sign.
Yeah, there is no positive bronchus sign. There is no leading bronchus.
Then most probably I will go ahead with the CT.
Okay, right. Dr. Prabhuran, regarding this patient is asymptomatic, non-diabetic, non-smoker female underwent a routine hospital checkup. They picked up lesions in the chest scannogram. So this patient whether to undergo any low-dose CT or regular CT or PET CT, what's your take on this? What is low-dose CT?
This patient was, they found something in the chest X-ray, and then a routine CT chest would have been done. It's not a low-dose CT. Low-dose CTs we do for patients who undergo lung cancer screening programs. Only lung cancer screening programs is low-dose CT is required. Otherwise, otherwise the usually cases when we find a lesion, the patients undergo a normal routine chest CTs. So in this patient, when the chest X-ray, when we found a lesion, we have done a normal plain CT, and then looking at the lesion on our plain CT, lesion has a lobulated margin, stipulated margin, and it has a infiltrative coronary data. This is a classic for a lung cancer. Then probably we should have done a contrast CT. We should have done a contrast CT in this patient, and then looking at the lesion in the lung apex, and we can very well stick the needle like. So
okay, fine.
That is the.
So this patient underwent a CT guided biopsy. The diagnosis proven that a well-differentiated adenocarcinoma. So now we know the diagnosis. Now this case is we are going to present in the femur board. May I request Dr. Jovita Martin ma'am regarding this staging, TNM staging. So what are the tools you want to diagnose what kind of a staging of tumor, what kind of modality of treatment? The tumor board, what are you going to decide? You are the tumor board chairman. So how to approach these cases? What are the recommendations from you? Yes, Roy.
Was brought in, but perhaps taken up parts of the body and because I know and it would have been better as not only for diagnosing the type of lesion, but also to stage it. We not only have to diagnose it, to stage. But staging EPA should be very important for the NICU. And Madam, BSM was also,
Yeah, we just need to go. You can reach all the areas, but certain areas we require BSM also. This is also areas. Now with the EVS we can reach all the areas. We can diagnose or through where surgeon can go to whichever the areas in the medial stadium at all. So yes, Kaushik. Yes, correct. So we did a PET CT scan and a CT chest with the contrast. Everything proven that there is a localized mass lesion. There is no medial nodes. PET CT shows only the localized area of lesion. So how to approach these cases, Jovita Martin? This case is the easiest way to get this. CT biopsy of the venous lesion, lung lesion. Yeah. Correct. This case is ideal case for the CT needle biopsy. Yeah.
If there is the entire CT cuts, if there is a positive from the side, then right now we have enough tools to approach it, the peripheral lesions like radial bus or small size NT bus, all that can help us, or navigation tools reach the visualize the tumor and then take biopsy from it. One at the same sitting you can also do if there are nodes. So where in hospitals or setups where have such kind of facility, I would prefer that. Or else we'll go ahead with the CT biopsy like.
Yes, I fully agree, Dr. Kaushik. This patient underwent a CT biopsy, proven that adenocarcinoma, PET CT was done. There is no area of metastasis, only the localized lesion in the right upper. Yes, Roy.
Even if the CT guided biopsy for this patient, I would not have done if there is a mediastinal node is only there. Even if I do not have a peripheral reverse, if there is a mediastinal node as I am going up saying, it not need only diagnosis.
I think sir said there are
no. There is no nodes, right?
Sir said no nodes for CT.
Okay.
Yeah, and practically also, like without a proper lung biopsy, if we advise the EPS to the patient, I don't know how many patients will go through it. So CT biopsy is the local procedure. Again, EPS is the
We can do a CT biopsy. We have CT for the staging. Okay. We can sample all the groups.
And I would like to know the size of lesions. Size of lesion is it?
CT biopsy is less than this compared to bronchoscopic biopsy, and it's a peripheral lesion. And when we are for the staging, let's do a PET CT for the nodes. So they can't sample everything.
So one I slightly differ from what sir is saying. Like I think bronchoscopy is less invasive because you just go and you take, if you visualize and take a biopsy, there is less chance of attacks. So that is one. If there are nodes, yes, it is a single procedure by which you can get all the nodes evaluated, find if do the staging and come back. That is the most advantageous part of having a EPS and bronchoscopy. Second part is all this can be done only if there is a bronchus leading to it. So that is what I'm trying to emphasize.
This patient in a non-EPS mass lesion. This patient underwent CT biopsy. Bronchoscopy is there. We don't have EPS bronchoscopy.
Can I just say one thing, sir? Bronchoscopy may be less in respect to bronchoscopy, but it is definitely much more difficult. Patient,
this case.
Then I think, confusion. Whatever you are, whatever you don't.
This is the adenocarcinoma. Okay. So what is the staging? Clean up staging bias will be done. This is the 4 centimeter tube. No nodes. Okay. So what is the treatment program? Correct. So what kind of surgery are you planning to regime? This patient, open thoracotomy, wide thoracotomy.
First, we just make sure the patient is all right. make sure the patient is fit for surgery, general, regular evaluation for any.
What test you want, pre-operative testing?
Probably just evaluate the heart, to make sure the patient has the coding in the lower.
Also, if you want to do any specific PFT measurement here, pre-operative lobectomy or this patient, yeah, underwent lobectomy. So what kind of test you want to do for fitness for the surgery?
No, I think we will go with the regular spirometry and DLCO if possible, and assess the lung capacities before going for a lobectomy.
Yeah.
So that is very important.
The spine patient underwent the surgery.
And the baseline 6 months is all should.
Do we need a DLCO for all?
No, not all the people. Right.
The bats are bats.
Bats, we do still our robotic surgery.
Yes, it is a choice. Minimally invasive is definitely
yes
important. Whether you do bats or not doesn't. I would do bats because I do bats and it's very easy for me to do bats. It turns out also cheaper than rats, and there is no actual benefit of doing rats when you're doing when you use staples and able to just take up the nodes, unless you're doing a sleeve or something where the complex switching is required. This case, straightforward bats, uniportal bats, the 3.5 and 4 centimeter incision will do the job easily, get all the nodes, get the rope, we're done in 2 hours. Just to clarify the spirometry and DLCO, I think if the patient is not fit for surgery and on your spirometry, then you subject the patient for DLCO.
Okay. Any role of chemotherapy or radiotherapy, pre-operative, in this case?
In this case, we have to know the histopathology post-operative.
Same tumor, that is a very different diagnosis. Yes.
I would
Yeah, parametry very clean. There is a localized solution, clear cut lobectomy done. So this patient report came as the well-differentiated carcinoma. So after that, tumor goes.
there is
No invasion.
on that mandated chemo, sir. Otherwise, we can go for a targeted therapy. Now, Adora has a increased survival usage of actual osimertinib. So we may give in case in terms of prioritization possible.
So after the surgery, you want to give some immunotherapy.
Yeah.
Okay.
Yes,
Role of radiotherapy, the numbers.
Like one in case of margin positive or any sample not become accidentally positive.
No, this case, everything there. Okay, right, fine. Thank you. We move on to the, yeah.
The bar is once also. Then that's post-operative radiation.
Yes, thank you. We move on to the next case. 55 years smoker, pain, right shoulder pain, right side shoulder pain, upper chest pain and upper back pain and arm pain. Radiating pain from the neck. History of 2 months duration. Initially consulted orthopedic surgeon for the shoulder pain and all. They gave some myospas and other medications, no improvement. So they took a radiography and referred to pulmonologist. Again, Kausil. You want to see the X-ray? I'll show. This is a chest radiography. This is not a digital radiography. This is a old one, conventional chest radiography. So with this X-ray, patient referred to the Dr. Kausil.
I think it's a clear-cut homogeneous opacity right upper lobe and apical tumor probably involving the brachial plexus. So that is why there is a radiation pain. So I will again go for a direct CD thorax with contrast. So that would be my first one.
Fine. Yeah, this is the CT chest.
Yeah.
You want to the X-ray? Correct.
First is 0.
So you were clinical diagnosis, seeing the X-ray itself. What tumor are you suspecting?
Suspecting a classical apical small.
Apical tumor. Okay, apical sulcus tumor or pancreas. Okay, right. Any role of MRI, Dr. Prabhu?
Definitely, want to image the brachial plexus involvement and probably.
Yeah, this patient underwent MRI also. Yeah, Prabhu, your opinion.
This case, when we did the placing, we should have done a contrast, look for the vascular structures, and also to look for the necrosis.
say we need to target this already area for biopsies. So we need to give a contrast to the pregnancy. So after a contrast study, then definitely MRI has a role in this. And for the pregnancy, all that. Also look for the chest wall and patients. So in this case, CT itself will clear that there are restrictions. We look for the other patients. That can be without a frank restriction. This should be seen in only plain CT. MRIs will show a certain narrow involvement, particular involvement. So all these changes can be better product than MRI.
Yeah, CT MRI finding there is erosion in the rib as well as vertebral involvement with the brachial plexus involvement. So patient present the brachial neuralgia 2 months duration. So what biopsy will change the diagnosis? Kaushik? Biopsy?
I think for this, when ultrasound guided biopsy is much more simpler to go ahead and do.
Fine. This patient underwent image guided biopsy, proven that squamous cell carcinoma, pancreas tumor confirmed. So how to proceed further? Sorry.
Definitely, we have to analyze for metastasis. So we definitely need a PET CT.
Yeah. PET CT was done. There is no other lesions. Mediastinum or intra-abdominal. There is no other lesions. Only in the chest. Rib erosion with the vertebral involvement with the large size tumor.
I think the next would be for the pain, you can go with the nerve block and then radiation would be there.
Yeah, that under severe role. Yeah, this patient you want to give pre-operative radiotherapy or concurrent chemo radiation. Okay. Any role of surgery regime?
Dry modality. So to chemo radiation and then reassess. And we'll have to get an orthopedician, spine surgeon to take a look. Also, we'd like to involve a plastic surgeon and see how it is, what's going on.
Yeah.
Because the spinal canal seems to be involved.
Yeah, this patient underwent biopsy. See, the biopsy proven that squamous cell carcinoma. Yes, this patient underwent a chemoradiation. After that, patient underwent a surgery, radical surgery. We removed the portion of the rib and the vertebral involvement is there. We did a vertebrectomy, I think. Entire mass was removed. Post-operatively, patient underwent again chemoradiation. This patient followed for the 2 years period after the surgery. So after that patient, we didn't see the patient. So then we didn't see the patient because of some default and other things. So post-operatively, 2 years we follow the patients.
What I know is not a very aggressive tumor. Do well with complete system.
Any questions from the floor? Any postgraduates want to clarify any doubt? You can ask to the panelists. So we have radiologist and radiation oncologist, surgeon, and the pulmonologist are there. You can throw any questions. So this is the third case. 60 years male, non-smoker, presented with breathlessness, cough, and chest discomfort of 1 month. He's having clinical job work, no fever. On examination, respiratory system found that dull note on percussion, absent breath sounds on the right thorax. Another history, this patient underwent 2 times of pleural aspiration in the period of 10 days. So, this is the pleural fluid report. Lymphocytic, exudative, AD with the normal limit, gene expert ASB not detected, cytology negative for malignant cells. So, how to proceed further? Proceed.
So there is a dull note. So I don't know whether what you meant for this monitor or initially that I would like to know. One. Second is that can we have the X-ray against?
Yeah, this is a story dull note on this thing. Yeah.
The X-ray doesn't show any reaction. So probably there is an effusion along with an endobronchial lesion also, which I would like to rule out in this particular case. So there is a collapse within malignant or paramalignant effusion. So
what is the next investigation after the X-ray? You want a history?
No, sir. In next slides. It's the pleural fluid analysis.
Yeah.
So this is lymphocytic exudative and again can be in tuberculosis or a malignant. Both were negative. Gene export was negative and cytology was also negative. So next would be definitely CT with contrast of the chest. Would be my next line of investigation.
Yeah. Once more history. Okay. 6 years male, non-smoker. 1 month duration. Clerical job. Okay. This patient underwent a CT chest with the contrast. Yeah.
The chest X-ray, you can see large effusion.
Ah.
Before doing a CT, this anecdote that we have the effusion and
Because many times the lesions will be masked by the effusion. It will get masked by the collapse. So always we tap the effusion and do a CT test.
So I think before that, I think we have to do an ultrasound thorax to rule out whether it is an effusion or not. Because I'm still skeptical seeing that this X-ray there is no mediastinal shift. So I do an ultrasound, rule out if there is a collapse or a effusion. Then it's like Dr. Prabodhan said, we'll remove the fluid, then go ahead with the CT.
Yes, this patient before coming to us underwent 2 times pleural aspiration under image guided 1000 ml. So after that, patient came to us. After that, we did a CT scan.
Many cytoscan was missing for this patient.
Which one?
Cell block cytology.
No.
I think
we did a cytology negative for malignancy. This is the report. This is the report patient came to us.
I think a cell block would increase the yield.
I fully agree. Yeah. Right. So this patient underwent a CT scan. Dr. Prabhu or Kaushik? Yeah, you want a mediastinal window? Yes, this is the mediastinal window. There is a large effusion or massive effusion is there, and there's a collapse of the lung. The collapsed lung is seen on the medial aspect, and apart from that, we could see multiple nodules, lesions along the pleura. Yeah, right. So, okay. Yeah, there are multiple lesions. Whether all these are metastatic lesions or one is a primary, but the rest of the things are metastatic. It is difficult to say, but in the collapsed lung, I'm not seeing any necrotic tumor in the medial aspect. So everything can be. So that's why I suggested aspiration and CT scan. So that if the peripheral lesion, the large one can be a primary, but the rest of the pleural lesions can be a metastatic. This is the recurrent effusion. Within 10 days, again, patient collected patient breathlessness with the came to us. Or everything can be a metastatic. Patient is with me. Probably I will screen this patient with ultrasound, look for the abdomen and any other primaries or neck or anywhere any other primaries, and then probably aspirate this and do a PET CT. Yeah, right. Kaushik.
I have a small comment. Especially people practicing Chennai, when you have a strong suspicion of anything, such a large effusion and all that, doing a CT scan, then doing a PET scan, all these things. PET scan is so cheap now, you straight away go into a PET scan, and if there's something like this, you do a CT scan biopsy, put in a pigtail and come up. You get a diagnosis.
Right.
I just slightly differ from the opinions. One is that I will straight away go with the critical therapist.
Correct.
Go and drain all the fluid, and then visualize the tumor, and then take a biopsy, and then do a frozen, which we are doing right now in our centers. Do a frozen, wait for 15 minutes, get the diagnosis, and plan for fluoridesis in the same setting and come out.
Correct. So, we have luxury of thoracoscopy and all you can do. Without thoracoscopy, centers like only ultrasound, but image guided the pleural nodule biopsy. Is it possible, Prabhu?
Yeah, I think this nodule.
Without CT, through the ultrasound, we can take the biopsy. Okay, right, fine.
Best way to approach this what Kaushik has said. Do ultrasound, thoracoscopy, biopsy, get dose, get the diagnosis, pigtail or whatever you want in an ICT, do the fluoridesis and come out.
Thank you. So this patient underwent a thoracoscopy. I saw the image. This is a thoracoscopic image, medical thoracoscopy image. You can see the pleural effusion and multiple small nodules in the parietal pleura. So biopsy was done. Biopsy proven that metastatic carcinoma. So this patient underwent pleural disease using TALC, PET CT, and other markers were done. This patient was presented in a tumor board meeting. Dr. Jovita ma'am, Dr. Anvarasi, immunohistochemistry. Okay.
Just for quick opinion, sir. We can also use plain doxycycline tablets where patient is not affordable for a tab, which will cost somewhere around 4,000 to 6,000. Crush plain doxycycline tablets and use it is as effective as a tab.
How many gram capsules?
10 mg per kg. So it will cost you somewhere around 30 to 40 rupees.
How many capsules? 100 milligram capsule doxy.
10 mg per kg.
Okay, right. So we did that talk, sterile talk 4 gram. So
we have a large case series somewhere around 30 to 40 patients with doxy, and we had success rate of somewhere 90%.
Okay. Usually we didn't do any talk pudraj. We did a talk slurry. So while ICT removal, we put the talk slurry, injection of talk through the ICT.
Fast back to the
So thank you all the panelists. You please tell me one single take-home messages. Any questions related to these cases? Kindly throw the question to all the panelists. Radiologist, surgeon. What is the kind of treatment? Yeah, Jovita. Pardon? No mesothelium. No mesothelium. This is a metastatic carcinoma, no mesothelium. Primary was lung cancer. Yes, we will tell all the reports. Yeah, this is a. What is NGS? Next generation sequencing. Okay. Thank you. This patient underwent chemoradiation. There is not radiation, palliative chemotherapy. Somehow patient was managed 6 months, 9 months. Then after that, patient succumbed to the disease. After that, he didn't follow up. I request please give the final take-home messages each and every. Rajiv?
Yeah, like I said, tissue diagnosis in every case it is mandatory. Either you take root by CT biopsy, ultrasonographic biopsy, or by a fluoroscopy with a frozen that we have to be like I said, the ideal. Make sure you get tell the patient something, or if it's tuberculosis, you don't fluoridize. If it is TB, you fluoridize. If it's malignancy, you fluoridize. So that we.
Yes, sir.
So I take home, I think for the PGs, have less threshold for suspected lesions, like say, provide and do next line of imaging, confirm the diagnosis as early as possible. That would be more beneficial for patients.
Thank you.
Take home messages. If one thing was not discussed from the morning, lung as a brain. Previously, we used to give just palliative OT to the whole brain, but now the incident has changed. Either like for 1 to 3 lesions, either we'll do resection followed by SRS or SRT. And I think up to 5 to 10 lesions, we are doing stereotactic radiotherapy. Because nowadays with driver mutation positive, we have a lot of targeted therapy. Patients are living even with brain metastasis in terms of years. So like nowadays, stereotactic radiation is more confined in brain metastasis.
Fine, thank you. So with that, we conclude this session. Thank you very much, all the panelists. May I request Dr. Roy to give the moment to the panelists. Those who are not, yes, no, fine.
I think that's a lot of maybe that will help us. The other thing is circulating cells and cell-free DNA. So that is a very good, easy method, and you have material enough.
We are going to the DNA and all. Always do a contrasting whenever you have because when you're going to stick the needle, you have to take the sample from the represented tissue. So don't go needle in a plain CT, always do a contrast CT. And if there is a collapse, there is a central tumor collapse, and if we can always do a PET CT, differentiate the collapse from the tumor. So these are the things. So thank you very much. And always ask for the old exercise. Old exercise, yeah. The best thing is correct. So very, very useful in FP also. Very useful. Right. I request Roy to give the memento to the panelist. Name. Yeah. Go, sir. All right. Okay. Lights on, please. Final discussion. We know these slides about. This is Prabhu, please receive the phone call. Thanks for Prabhu. Stay here. Next panel discussion for one of the other panelists now. First, Dr. Tyagis, please take over the second conversation. Next, madam. Thank you. Dr. Tyagis. Tyagis is an pulmonologist, Cancer Institute, Area. Welcome to Dr. Tyagis. Please model this. I'd like to thank Dr. Jamal sir for giving me this opportunity and thanks at NGM team for this. And we'll call the next panelist. We'll call the panelist. Yes. PM Madhu sir, Prabhu sir, Alexei Prasad, Rajendra Singh, of the side is like support. We have 3 cases in our discussion, and we try to keep it short and crisp. The first case is a 54-year-old male who's a known case of diabetes hypertension with a past history of coronary artery disease, post PTCA stenting in 2010, and on evaluation for the right ureteric stone for PCNL, he found some suspicious finding in the chest X-ray. And I'd like to request our radiologist sir to comment on the X-ray finding. What is the age of this patient? Sir, it's 54 male. 54 male patient. There is a nodule in the right upper zone, zone region. Doesn't have a smooth margin. I could see some operations, kind of speculations, deletion. This is highly looking at this patient for CT scan. So next we did a contrast CT scan. I have a lung window of the CT scan which we have done. Yes, sir. We have the lung window of the CT scan. This is the CT video. Please give your comments on the CT findings. So, CT findings is a cells or body slash mass item of the size of the lesion. It's 2.9 centimeter. Yes, sir. Large body with greater margins and operations. To find this infiltration thoroughly. Yes, sir. So, there is a contrast. Yes, sir. So, on evaluation after routine investigation, CT chest showed 2.9 centimeter right upper lobe nodule and no significant mediastinal anomaly. And I'd like to ask the pulmonologist this question. What will be the preferred method of sampling in these patients? Yes, sir. Okay, sir. Yes, sir. So we can also be checked before that. Okay. So that if you can get a sample from what is better. Sure. So in our routine practice, all peripheral lesions will go for a CT guided biopsy, and all the central lesions will go for a bronchoscopic guided biopsy. And yes, sir. Biopsy also. Can sir, we can. Yes, sir. We can. So we can call it as a transthoracic needle aspiration technique like that. So any which is possible. Transthoracic biopsy. So do we recommend PET CT for this case, sir? This question is for a medical oncologist, sir. So like a lesion of 2.9 centimeter, where localized lesion, do we require a PET scan?
Yeah, we also as a state whole body CT scan in this case, but that's very good.
So we have done a PET CT scan. So opinion on the PET CT scan, sir, or radiologist.
Which is going to uptake other than that.
Yes.
I didn't see any obvious area of.
Yes, sir. Yeah. No lymph nodes in this center. Radiologically, there is no significant obstructions. So, what is the role of MRI brain in this patient? Medical oncologist or radiation oncologist?
So for this kind of stage 1 vision, for MRI brain, your whole body scan is that already screened the brain also.
Okay.
So it is a early lesion also.
So any brain mets can be picked up in
Yeah, we need some we have standard uptake very also. The screen and give that there is metastasis in the breast still.
Okay. So the next question is to the medical oncologist. What is the role of mutation testing and PDL testing in this case, pre-operative?
Actually, this is the early lesion. So our aim is where we are aiming to get a surgery is possible, radical is there. Okay. Suppose if the section is comfortable, after that we lost this post of biopsy is done.
Sure. Sir, that's the emojis for medical oncology, sir. ROGs for radiation oncology. It is just for me to remember all those things, actually, to whom to ask these things. So the next question, either pulmonologist or surgical oncologist can answer, sir. What is the role of EBUS or mediastenoscopy or USB staging in this particular case where PET scan is not showing any uptake? Do we have this practice of routinely doing EBUS screening in all the operating patients from surgical oncologist point of view?
So if we are planning surgery for this patient and according to PET it is in 0, then I don't really think EBUS is good. Because anyway, we are going to do a dissection completely. And as I was telling you in the previous talk, the recent consensus has been coming out more in favor of the multi-stage network also going towards surgery with the advent of perioperative immunotherapy. I think at such a small lesion, early lesion, with no noticeable nodes on PET, I think we can consider surgery directly.
Any other comments?
This is a controversial.
Yes, sir.
If there is no PET uptake, also I think I would go to EBUS. Make sure there is no
yes, sir.
staging is there is no upstaging of the
Okay.
Even T1, T2 is good data for phenotype body radiation also.
Yes, sir.
Comparable surgery.
So, sir, what we usually do is like any cases like Dr. Kaushik sir told, we will be taking the EBUS screening to check for any other contralateral nodes, or even if it's PET negative, sir. So then, when to consider the mediastinal node to be significant, sir? This question is for the pulmonologist. Even with or without PET uptake, sir? Okay, sir. More than 10 will be considered. Okay. So, which nodes can be approached by EBUS easily, and which will be difficult to approach by EBUS? Okay. Okay. Yes, sir. So, yes, sir. Those which are not approached by EBUS, we will be doing EBUS-B procedures, sir.
7 is EBUS.
Yes, sir.
Again, that is
EBUS. Okay. So we do hilar nodes and all through EBUS itself, sir. Like, 9. This is for a postgraduate purpose, like. So this question is for the medical oncologist. What is the most common histopathology of lung cancer we encounter in our practice? So, will the histopathology typing will have impact on planning for management in this case, sir? Like, I would like all the radiation oncology, surgical and medical oncologist opinion on this.
Which is sponsored. Okay, so they have to consider that after the surgery is possible. Okay. There is no much difference.
Okay.
So the size of the lesion is less than 3 centimeters, then up to surgery is possible. If there is no metastasis anywhere in the body, small surgery.
So, carcinoma. And any role of neoadjuvant chemotherapy in early stage lung cancer or in our particular case? Neoadjuvant.
Actually, they are resectable, non-resectable.
Okay.
Resectable disease, either it may be radical surgery or stereotactic radiotherapy.
Suppose if it is locally transferring nose in mediastinal nose is positive, then we can try with concurrent chemo-RT or assess with response with PET-CT scan, condition of radiotherapy. If any residual lesion is there, means you have to, if it is resectable lesion, we plan for radical surgery. Suppose after completion of concurrent chemo-RT is also not possible in non-small cell lung cancer, there is some immunotherapies are there, that immunotherapy do well on that. We can give us a consolidation therapy for up to 1 years.
So this any neoadjuvant PDL1 indications we have, sir? Like even at a planned case. So this patient, what would be the management plan?
Radical surgery, patient is fit for surgery, and there is patient avoided for surgery, radical surgery is the preferred choice. Patient is not really for surgery and into some comorbidness, and patient can plan for the radiation, still radical. So yes, sir. Lobectomy with the mediastinal nodules.
So like role of SBRT in this case, so like as I think you already mentioned service. Role of SBRT in this patient. When suppose the surgery is not fit for procedure.
There is this T1, T2 lesion, and the peripheral one.
Yes, that's a peripheral one.
Peripheral tumor, SBRT is even single fraction is fine. So it's a peripheral one, it is away from the chest, and it's away from the private lungs. So we can go for a single fraction, 35 grade, or go for about 40 grade 5 fractions. So it can be done. Okay. No. No electric mobilization.
Okay. So this question of pulmonologist, what is the need of PFT DLCO, and do we do cardiopulmonary exercise testing for all the patients, sir? Like what surgical oncologist, your opinion also, sir, what do you need for a lung function assessment?
For that, yes, sir. We already know this PFT1 is the 80% post scheduled testing. And if everyone pre-operative everyone is less than 80, then we go for post-operative P1 prediction. Like we take the PFP1 into the remaining number of segments after the session. In that, if you go for 40%, then you go for a straight away. It's going to be 30 to 40, then you go for the cardiac exercise testing. Then if you have to match will be more than 15, then you go for reconnecting. If it's less than 15%, then you go for it's high risk person. Then if it's going to be less than 30% of your post-operative FE1 prediction value, then you can go for consider lobectomy. If it's going to be this one is less than 40, then you go for lobectomy. If it's less than 40, then you go for high risk. So there is the indication according to the guideline.
It should never be. I think the consensus and data is very, very clear. Always do an anatomical resection if possible. Just as lobectomy or segmentomy, whatever, it's less than 2 this is different. But for this patient, I think a lobectomy, anatomic lobectomy with mediastinal dissection is better. And so the need to DLCO, I think we are thinking about pneumonectomy. So if you're thinking about lobectomy, I don't think DLCO is integrated in only in pneumonectomy we do a DLCO or VQ scan and all that to actually assess whether this patient is going to be fit for a pneumonia. It's part of the
yes, sir. How healthy is the lungs? So if the patient having a pre-existing COPD, there is a lesion in your lung. I think the lobectomy will also severely compromise the.
That's what that will be going in a PFT.
No, the PFT is not adequate to go for DLCO. Whatever condition, I think suggest both
so
gives us a good outcome. But if it is not good, then we must subject it for other. We're not going to do DLCO for most of the patients. So I have
coming back to your question, when you require a see, earlier they used to do pneumonectomies for endobronchial tumors also. But now with parenchyma preserving sleeve resections, we are avoiding pneumonectomy. As of now, the only indication where the tumor crosses the fissure and involves both lobes, then I think we have to subject it to pulmonectomy. We can't do anything. Or if it is involving only one part, then we can do an upper lobe and 6 segment alone. We can do S1, S2, S3, and S6. So we can preserve the middle lobe and remaining S7 to 10 segments. But if it is involving the fissure, it crosses the fissure and goes, there is no option but to do an. So we can do what is known as a vascular sleeve resection. You're doing vascular sleeves. No, with lobectomy. So if the main pulmonary artery is involved, we can just do a lobectomy and stitching, not a ligation, cutting and exposing the pulmonary artery alone. So that was also considered to be a So, but now the fissure, when it is involved, there's no point to preserve the lobectomy.
So what is the surgical approach you will take, sir? VATS versus thoracotomy versus robotic?
Like the size of the tumor, I definitely opt for a minimally invasive approach, either a robotic surgery or stereo.
I think, yes, sir. Sir?
Sorry? Size of the pocket. Size of the?
I think for the second question,
the purpose of the discussion is fast away from the academic discussion.
Yes, sir.
Actually, the staples for the information of the audience, the staples that we use in robotic surgery are much more cheaper than the VATS staples.
Just for discussion, what exactly is the cost of robotic surgery?
The robotic lobectomy costs 50 to 75,000 more than a VATS. Whatever your VATS was, because that is the rent for the robot. That has to be given to the. It's around almost 75,000 more.
I think for the next question, extent of surgery, whether wedge or segment or lobectomy, I think you have
this patient.
For this patient.
This patient has a lobectomy with dissection.
Dissection. So any role of sentinel lymph node biopsies in this kind of patients, sir? Like
I don't have any.
Okay.
Because we are doing
mediastinal node clearance. So what is a common complication we can expect during this lobectomies?
When you are doing any minimally invasive approach, you have to be prepared for bleeding. Always make sure you're ready for conversion. So that time you shouldn't be. And during the surgery, sometimes you have surprises, and that's pleural involvement. Multiple pleural nodules are there, and you feel some other nodules are there, and the other lobe satellite nodules are there, or some other lobe nodules are there. If you find some things like that, you better have a frozen available. And if pleura is involved, then it becomes potentially metastatic.
So you'll go ahead with lobectomy?
I don't think we should go ahead with lobectomy.
So if
it's a metastatic disease, you really think we should go ahead with the lobectomy? With the intraop, we find a pleural nodules, you really think we should go ahead or?
Intraoperatively, any pleural nodule or any end to node which is coming positive in post section?
That kind of I really do. I think we should revisit our end to everybody. We still keep talking about end to 2024. I think it is going to change. That's my not my thing. That's what was discussed in ISLC Singapore last month, September. Yeah, end to if it is potentially resectable, I think we should go ahead and resect it and then ask the medical oncologist to give immunotherapy. What would you say, sir? No longer, if it is potentially resectable, I think.
Effective results, radical surgery, but what was the primary reason and mediastinum followed by we have a regular therapies. Like global map is there, we can consider overall.
So this is the post-operative CT scan, sir. I'd like for radiologist to comment on this. So our patient developed a post-operative complication. So this is the post-right upper lobectomy. So clinically, this patient had a persistent air leak actually. So, could be some lobectomy has been done, right?
There is a large surgical
application. Yes, sir. Pneumothorax, yes, sir. Yes, sir. No, sir, I have cystic. I'll show you next. Yes, sir. This patient had a small bronchopleural fistula post-lobectomy area. So ICD insertion has been done, but we still had a persistent air leak. So for this kind of patients, how to handle this, like post-operative air leaks? How do you handle this case? I'd like my pulmonologist opinion also, the surgeon's opinion also.
What is this? Locating properly system and try to take the
Any criteria there's like this has to be managed surgically and this has to be managed bronchoscopically. Oh no, sir, he's on intubation only. He's intubated. The other image, sir. Yes, sir. The other image is extubated actually. ICD is inside actually. Stable is. No, this patient has a persistent air leak, sir. The air leak is not settling. So in that kind of scenario, like how to go? I said that's what I want to know, sir. Like. No, it was a continuous bubbling is there. Biphasic air leak. No, we waited for at least a week actually, sir, but it has not settled down. Is there any criteria for the size of the air leak, sir? Like we should be in so still on the conservative side.
If it's a large air leak and it's leaking from the upper lobe bronchus,
yes, sir.
Two things. One, the upper lobe bronchus is a fairly wide bronchus and it is taking up at a different angle. So whatever endobronchial devices might not really want that. So it's not settling down and the patient is not stable. We have to go in and intubate. But if the patient is stable, I don't think he will be worried with having an ICD for a longer time. We've had patients where their air leaks have stopped, even bronchopleural fistula, not simple parenchymal leaks, even bronchopleural fistula. See what happens when it's stable, most of the bronchus is okay. The last part of the bronchial staple has given up. So it's actually a very small air leak. With over time, the inflammation forms and it heals. And we've had patients where 1 month ICD and then it just settles and they go well. See, the urge to go in with our knife and go in with our scope should come down, especially in a post-op patient, because your arteries, your veins, everything you have stapled, that will all be inflamed and things. You don't know what is what there, and everything will be like a masala there. You really don't want to go and play around there. Maybe from the inside you can try something which might or might not succeed, but from outside I would not go in with a knife happy thing.
So
I go ahead. I accept the point. Actually, you don't do anything if you can early mobilize the patient and set up. And
with an ICD or an English
the PPF
no, generally these people will have only air. If there's no employee on, then we can put an English valve setting.
There is no fluid component, go for an English or else set up with the ICD bag. And then there are a lot of latest drain bags which are available. The patient can place. So I think you can review the patient once in 2 weeks. I think this will settle down on us rather than replaying with it.
Why I feel this will settle down is lung has expanded and filled almost more than 75% of the space. There are 70% of the space. Only a small bit of the rest there. And it's more of a surgical emphysema and you're actually not able to see the right upper lobe bronchus opening into the pleura. That's why he was asked for a coronal section, which we don't have. But from what you've shown, we don't see the right upper lobe bronchus opening. When it's a really big BPF, you can see the right upper lobe bronchus. We've had patients where right pneumonectomy, and I see through the bronchoscope, I can see the intercostal.
No, this is not a bronchial blow. This is just a small leak which are like as you told, the stapler was a little bit.
Just a partial stable.
So this patient, we did an endobronchial glue application. Like spigot cannot be placed in that angle, so we did glue application and ICD. After 48 hours, we removed ICD and the lung has expanded in this patient.
Why you want to remove ICD after 48 hours?
No, when the so we have a high chance of post-operative infection, emphysema, and all those things. We try to.
Also, for reason why I would not remove the ICD immediately after 48 hours because these patients are notorious for presenting delayed with an air leak.
Air leaks, no, sir.
So when you have once fitted question, but you have an air leak, no harm. It's not like in the West where there's a stigma for or people are okay to go around with the ICDs, and there are, as he said, a lot of devices available where you won't even know that the patient has an ICD. It will be under the shirt.
No, we try
I would not personally. I would not remove the ICD within 48 hours.
No, we will try to remove whatever tubes inside. Otherwise, that will be a focal infection. If 8 millimeters.
The question is that what maximum duration the ICD it may have some letters of the ICD and we don't know what type of care they're going to be on the in spite of the educating what type of care is going to be on the ICD. Instead of ICDs are be trained and robot yes, now there are so many very ICD trained you don't need actually any care. Just another model. Because we are from so what we want to know is how much what is the maximum duration of our parents basically like 3 months or 6 months. So what is the what you will remove the ICD or for the rest of the APL.
After the local or humanity or talking about ICD for epidemiology or other plural disease.
No, I am talking about the bronchoplural fistula. They said we have to wait for some time of months. So what is the maximum duration we can wait for?
We had a case recently like last month, we waited for 3 weeks and the bronchoplural fistula healed by itself and we removed it.
So I'm talking about a patient where they have done a case, but they have been there for a week, 4 months. But in fact, initially they were in a patient, because we had a answer back to government, then the fluid became sterile.
So all the other gram negatives are more common and keep the patient in the hospital for a longer time.
No, he was discharged and he came back with
That's why I'm saying the GMPs are more common in the hospital setting. So yeah, as soon as you mobilize the patient out, I think the risk of infection actually drops.
So I want to know what is the he became sterile after that, but I want to know since even after that the speak is coming out for almost like 1.5 months. So I want to know what the maximum duration to wait and to implement.
Are you talking about a post-surgical patient? Yeah. Okay. So there are no specific guidelines as to how long you can wait. The all the data is coming from the West, where we don't have, they can't keep the patient for a longer time in the hospital, so they have to resort to such investigations to stop the early and send the patient home without a tube as much as possible. Here in the Eastern world, at least in India and the Indian subcontinent, the scenario is different, where you can send the patient home with an ICD, and there are no prescribed guidelines, even in the Western literature, where this much number of days you have to wait. Only thing you have to is any early that for more than 5 to 7 days is a persistent early. Only that they have. But when to remove the ICD, it's a matter of case to case basis. You have to determine whether this patient is fit for surgery. Because a lot of patients with DPF, like you said, this asthmatic, they'll be very sick. You can't actually give anesthesia and go in. Because the opposite lung will also be soiled because of the big DPF. So in those cases, we either have to go in and close the fistula with a flap, or we might have to do a collapse procedure, torcoplasty or something with a large space. But for the patient that you showed, is almost expanded lung.
Yes.
I will wait.
So, like post-operative radiotherapy in N1 positive patients or the lesion of size more than 3 centimeters, any role of radiotherapy on this kind of cases, sir? Or like a role of radiotherapy in a margin positive resection? Like you don't find a tumor there, but the tumor is margin positive. So, how to any role of radiation in that kind of
cases? It depends on IMRT, SBRT can be done.
Okay.
So, but radiation has to be.
So, what is adjuvant therapy we will choose after the availability of histopathology, sir? For this patient, like post resection, medical oncologist.
So that is is not positive. When technology is positive, we'll go with concurrent chemo.
Okay.
Radiotherapy with cisplatin plus idiopathic majority of people.
If margin is negative and it's
no indication. Yes, and margin is positive, we are sent.
Okay. If margin is negative, sir, then
margin is not possible. You have to go with concurrent.
So that's our first case. And second case, it's a 66-year-old male. He's a case of CA right lung with a squamous cell carcinoma. It's a stage 3C, T4 and 3M0. He came with complaints of dyspnea and exertion, like grade 4 MMRC and orthopnea. And he's a known case of COPD. On examination, the patient had a stridor and a decreased breath sound in the right hemithorax. So so we did a chest X-ray, and this is the X-ray, sir. Or radiologist opinion on this chest X-ray.
This is a large
translation. Yes, sir.
Like a semi-property.
Any opinion on the trachea, sir? Can you? Mediastinal, superior mediastinal, paratracheal, right? Paratracheal widening is there, and there's a shift of the. There is a component of collapses. There is a pneumothorax in the right side. And any comment on the distal end of trachea, sir? There's a cutoff of the trachea. So with this we went for a CT chest. So this is the CT chest image. This there was an and fluid level. Yes, sir. And I would like you to come. Yes, I would like to comment on your tracheal also, sir. Like. Yes, sir. Yes. So this tracheal lesion as well. Yes, sir. So this patient had tracheal lesion. So how to proceed further, sir? Like this, a pulmonologist to copy and how to avoid. Sir, he's a smoker. He's a smoker, chronic smoker with extensive COPD. So, this is the standard. Emphysema, lesion, and so paralloma. Sir, what is the age of the patient? Sir, it's a 66 male. It's a squamous cell carcinoma lung. Actually, it's a diagnosed case of squamous cell carcinoma. Hydropneumothorax is there for this patient. And there is an endoluminal tumor also. We have, sir. Next to. Yes, sir. Yes, sir. Cytology. Okay, sir. Bronchoscope. Okay, sir. So, yes, sir. Yes, I would like your opinion on that also, sir. So for this patient, how to proceed further, sir? Like a pulmonologist, do you? Okay, sir. So I will share the bronchoscopy video of this patient. So this is the bronchoscopy video. So when you do a as I told in the clinical history, the patient was an orthopnea and stridor, and you see that entire tracheal lumen is closed with a tumor in this case. And with great difficulty, we push the bronchoscope past the tumor. That right lung is better, but not able to go to the left side actually in this case. So this entire distal trachea is occupied with the tumor. There's only very small patent lumen is there for this case. So how to proceed further? Yes, sir. Patient is not sedated at this time, sir. Yes, sir. So this case I took as an emergency. So when I'm doing bronchoscopy, I just did a normal bronchoscopy in this case. But this is squamous cell carcinoma. Yes, sir. Cytology. Okay,
Stage 4.
Yes, sir.
Suppose if it is stage 4 and the patient speaks with symptoms after the ICD,
yes, sir.
And it done for the pediatric chemotherapy.
Okay, so but patient is in stridor now with orthopnea. So like
and we have to take out either by the or by completely burning out whatever, and then just take some lead center taken care of. The IC also on the right side after that.
I have a what I will do is I will not right away go for the stem. So what you do is you get an array, you do the microretention, place it at the right compass, intubate to a normal bronchoscopy, and then debunk the tumors. Okay, that would actually relieve them from stridor. Then you decide whether you want to step.
I will go for a bronchoscopy.
Yeah, rigid bronchoscope, or if there is no rigid bronchoscope, you can go microretention tube and go ahead with your regular bronchoscope, snare it, and then use some hot therapies and.
So this patient, we did a rigid bronchoscopic debulking procedure. So this is the
debulking is the main point.
So you see that entire tumor has been removed, and initially we were not able to see the left main bronchus and carina. Now the airway has been
established in this case. So, do we require tracheal stenting in this patient? So, what's your opinion on it?
Yes.
Yes, sir. So this patient, yes, you see the video like post procedures. Do we require tracheal stenting? No, sir. Stenting is not. That is a mucosa. That's a mucosa. Yes, sir. Sure.
Postgraduates, can you tell us how you protected the airway when you did the debulking? Because the risk of bleeding.
Sir, in this patient, when I'm doing this rigid bronchoscopic procedure, I didn't get a space to put the MLS tube through the right lung to secure it. So what we did was, it was an emergency. Yes, sir. It is an emergency thing, sir. We did the procedure. We intubated the patient with sedation without giving any paralytics. Then we went inside and then we tried to debulk the tumor as soon as possible. We got only 3 minutes of time with us for the technique ventilation. So within the no, sir. We did a snaring at first. I tried to establish at least some of the right mid bronchus airway. Once the right lung, once we removed as like partial debulking is done, the ventilation is made easy for them. So almost 50% of the tumor is removed in this 3 minutes time. Then rest of the coring and all those things, it takes time for us to clear off the airway. So it is like an emergency procedure. Then once airway lumen is achieved, then we can give paralytic to the patient. Then we can slowly take care of this. But for this case, it was an emergency thing. And one challenge.
Keep the
No, that is not possible in this case.
Because they should not rush into the lead bronchoscopy without the possibility of a bleeding. They should always have that effect.
Definitely.
Because you're going to lose both bronchi.
Yes, sir.
Something happens.
And this patient, the other challenges we had when we are doing is he's a case of COPD. So his lung capacity is very poor for us to handle. So the next is yes, sir. That I would like to ask our radiation oncologist to answer. Sir, you are asking after debulking or before debulking, sir? After debulking, sir. The patient was in spider. Patient was in spider.
After the endobronchial radiation has to be given now.
Okay, valid. So this case, because of the luminal compression and very irregular airway, we put the YSEMS actually. So it's a stenting, airway stenting has been done for this patient. So this is a airway stent where we can see a false carina is created by the Y limb of the stent. So both the left and right main bronchus patency is achieved. So these kind of patients with post procedure, we can extubate them on table itself. So now the performance status is from PS4 to it has gone to PS2 at least now. So what are the treatment options for us available for this patient? So like for a squamous cell carcinoma stage 3 patient, stage 3B or 4 case now. Yeah. It's stage 4 because of the effusion now. It's stage 4. So any treatment options are available with us? Okay.
Okay, so consolidate the lesion. And second is very systemic immunity can affect for this patient. Okay. Platinum based. Second is a taxons. If the patient is affordable, then we plan for any
okay.
The radiation is only for palliation.
Right.
Never be a radiation talk.
What about radioactive? That is you are telling is interstitial radiotherapy.
Implants you can't do it now. Not in lung. That's inspiration and destination. The seeds can get displaced somewhere else. You can't do it. Blasted you can do.
So this is a chest X-ray post-tracheal stenting. So we'll go to the last case. This is a 55-year-old female. She presented with the complaints of grade 4 dyspnea with impending respiratory failure with a past history of pulmonary tuberculosis 20 years back. Sorry, I couldn't get the video. This is the CT image, sir. Sir, can you comment on this parenchymal pictures, sir? Like one in the left side images.
Right lung is protected at the left side.
Yes, sir.
The left lung is kind of completely collapsed. I find some calcifications of bronchioles. something in the left lung. The left bronchus.
There is a endotracheal tumor is also there in this patient.
Left bronchus seems to be embedded by a
Sir? So it's a 55-year-old female, dyspnea with impending respiratory failures. So this patient had a past history of TB also 20 years back. So she had a TB. So this patient we took for a we went for a bronchoscopy for this case. I'll show the bronchoscopy video, then we'll discuss about the treatment plans. So this patient had only right lung as a pattern lung. The left lung is already it's a destroyed one because you can see the hyperinflation of the right lung. And this is a huge tumor sitting in trachea like this. So how to go about for this case?
Ask my, I would ask my pathologist to debug the tumor just to make sure the right side is good. And if after that, if there's a role to surgery, I go ahead and do if there's no involvement of the artery or anything, it's only a localized endobronchial tumor, we can go parenchyma preserving left main bronchus resection. Because from the CT, I was not able to see any other involvement.
Yes, sir.
It looks like that. It looks like a carcinoma.
So any suggestions from this? Okay. So this patient, we have done a bronchoscopic where a tumor debulking. So I'll just for the time constraint, I'll just forward this videos. I'll just show you the important things. So this is after rigid bronchoscopic intubation. So we'll put a snare around the tumor like this, and we'll try to debulk the tumor with the electrocautery application. So we'll do a rigid intubation, and all those things, all these snaring will be done with the help of a flexible bronchoscope mainly. So once we caught the tumor with the snare, then with the help of coagulation, we will just cut the tumor, and we have to burn it slowly so that we have to give time for the tumor to get coagulated and cut at the same time. We can see the tissue is getting burned over here when it comes close to. So with the help of snare, we have removed that tumor shunt. So after removing, when we go inside, that entire right main bronchus luminal patency is achieved in this patient. Left lung is already collapsed. So it was a. So this is how the appearance is there. Like once we remove the tumor from the trachea, we are able to achieve the patency. So how to go about next in this patient? So like right main bronchus patency is achieved. We can see that carina is not mostly involved in this case. Actually. So on the involved. So on the histopathology came out as it's a typical carcinoid. It's a carcinoid. So, We have asked for a PET, sir. The patient has to come. So we'll discuss on both the aspects, sir. Whether if the PET is positive for any other, or if PET is negative. So just tell us how to go about with that test.
The PET is negative. If the PET is negative, I think, and we have to give a chance for the lung to expand because this is the result of chronic collapse. We don't know whether it is destroyed or not. It is collapsed or not. Yeah, because this carcinoma has been there for a long time. Right hand has come this way. The chronic collapse in the right hand has come that side. So if possible, we have to give an option. Do a left main process. Preserving university.
If the left hand is destroyed because of TVs, then what would be the
how are we going to do that? You have previous then you have to go back to the history and ask previous.
Yeah, we had previously destroyed the other CD that's also called calcification inside the pad, inside the
You're already sure it's a destroyed lens, then we also need to do what But pneumorectomy, we have to make sure the margins are clear because it's close to the carina.
You'll do carina resection also.
That's what. If the tumor, the margin, proximal margin is positive, then we might have to do a carina pneumorectomy, something known as a carina pneumorectomy. You do a pneumorectomy from the left side, then going to the right side, and then remove the right main process and anastomose it to the trachea again. So that you get an extra bit of margin, so that we know the carina resection. Otherwise, you can just do a left pneumorectomy.
Any role of radiation chemotherapy?
Okay. After the staging workup, only suppose it is localized, then suppose it is stage 4, then you go for the indicator.
What are the options we have for radiation?
We have a lot of chemotherapy drugs and some there medicine inhibitors also. Commonly used cyclotherapy such as systemic chemotherapy or carboplatin plus Taxols or TK plus sunitinib for long-acting photostatins also we can try. Development with capstone, these are all the drugs we have. We use only as a sequence. First line is paid, then we are going for secondary. They have multiple. So first line we go is plus 8 of them. It is typical constant. What would be the typical constant stage 4 when you're in the systemic chemotherapy. If it is a localized reason, radical surgery is the treatment of choice. We have followed. What are stage 4? Line, first line, second line. First line we go with this is patient is fit, we go with platinum with Taxol. And second line, if it is the patient progress even on with this line of chemotherapy, then we'll go with the Taxol needle, sunitinib for long-acting somatostatins, temozolomide with capstone. We have nothing to this. We have radiation therapy. So we have four typical classifier on population. The reception specimen was recorded as an atypical. So, typical and atypical cause nice. Localized lesion, radical surgery is done, you will give the patient follow. Only for an early stage 4 disease. Even for atypical, the high KI will not neuroendocrine difference. And carcinoma is different interventions. For typical atypical carcinoma, radical surgery is given, that is the method of treatment for carcinoma.
You get to see a lot of neuroendocrine tumors. Okay. They are the NCCA guidelines with neuroendocrine tumors.
For neuroendocrine, because you have divided as a 4-day, median, and a 10-day. These decade tumors are very aggressive. Whatever it may be the site, you have to look for whether it's a low-grade lesion or high-grade lesion. The low-grade lesion will be done by the pathologist, depending upon the case. 67, whether it is a low-grade lesion. For low-grade lesion, the staging of the case, Dotanax can be done. Look for that any distant metastasis with that. Here, low-grade neuroendocrine tumor, aggressive chemotherapy is not addressed. Only we have to go with the long-acting somatostatins, that is enough for it. Suppose if it is failed and progressed, then we have to add the TKs, sunitinib and long-acting active. Aggressive chemotherapy is not given. This inhibitors are there, and we have some nuclear medicine therapy is also there for low-grade tumors. But as we have a higher
No, sir, it's K67, that is 2%. Thank you, sir. Thank you for this case.
Yeah, the second case you discussed now, that the commercial transform is stage 4.
Yes, sir.
Suppose if bronchoscopy is not possible in this case, we can try with the external beam radiotherapy with the stamp in therapy. Stamp cells are only prescribed to that segment, and that if there is a hypofractionation, it will make the patient will benefit for that. Whatever it may be, it is a very Indian.
Yes,
suppose the patient is not planned for any bronchoscopy, it is really difficult. We tried with the external beam radiotherapy as hypofraction, single fraction be given as a stamp beam. Stamp size will be given there, and I address that only with the doctor, and it will give benefit to the patient.
So how long it will take to come to effect, sir? It is like
to 1 or 2 days. It will be useful. Suppose if bronchoscopy is failed and not patient is not to go for bronchoscopy, we can try with the option. Only thing in stage 4, whatever we can go, only just payment to the patient.
Okay. Thank you. Any doubts? Okay. Thank you so much. Thank you for.
For this subject to be panel discussion, I thank you all the panelists. May I request that Congress ma'am please give the author to Dr. Diagnostic. Very ma'am, please come and give more to the panelists. Say this mind use. I will request Dr. Samupriya, please come and give the moment. Samupriya, Dr. Samupriya, please move to Jay. Yeah. Anumar. Very good. Thank you very much. Thank you. We move to the exciting PG quiz program. I request Dr. Samutha Sinharai, please take over and start the quiz program. I request all the PGs, please come forward. Hold it right.
There any PGs? Just put up your hands. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 10. Okay. So can I ask 4 person make groups? 1, 2, 3, 4 groups. Quickly, come in front. Okay. Our PG officer make one group. Come. So, don't go for this question. Okay, let me this question is cancelled. One is keeping the score. Keeping the score. So, so, of the game is not exactly how many seconds. If you cannot answer, question passes to others. Right answer, madam, is +10. If the question passes to the next, +5. If the wrong answer, -30, -5. Okay. So, first question, please. So, how many of you have seen that? Okay. Go to the next question. This is to group 1. What is the primary cause of lung cancer in non-smokers? Good, +10. Next question. Which molecular alteration is most commonly associated with NSCLC? Not your question, -5. This time I am not doing it -5, but next time I will do it easier. +10. This is view 3. Now, next question. Okay, what is the primary treatment modality for limited stage SCLC? Your question. Sure, nothing else. Okay, I will take that. +10. Next is the go slowly. Okay, next question, please. For MJ, which paraneoplastic syndrome is commonly associated with small cell lung CL? Which one? -5. Who said +5? Okay, so -5. Okay, so next question, please. Group 1. What is the significance of PD-L1 expression in the context of immunotherapy for advanced non-small cell lung CL? B is lower expression associated with a better response to immunotherapy. -5. A is correct. Okay. So +5. Question 2, Group B. Which oncogene fusion is commonly found in non-small cell lung CA and is targetable with TKI inhibitors? Good. Ross. Correct answer. Next people is Group C. What is the role of liquid biopsy in the management of lung cancer and which biomarker can it detect? Sorry? A is detect circulating T cells and EGFR mutations. Correct. Our question to MGM. In the context of lung cancer, what does the term platinum doublet chemotherapy refer to? That's cisplatin etoposide minus question passes to Group 1. Here it's 1. First answer is D. Answer is wrong, -5. Okay, I will not take now because already 2 answers are gone. This is nothing, but there is a correct answer. But this time I will not give you marks. Whose question now it is? Yours. Okay. What is the significance of the term EGFR T790M? Sorry? I cannot. Pass. There is no pass in this. -5. Huh? B is resistant mutation to EGFR. Okay, fine. Correct. Very good answer. Just for nobody else is there. So what is the drug? Osimertinib. Very good. Group A is -5. Pass is -5. Group B has taken +5. Now the question is for Group B. So this is the question. Okay. Which radiographic feature is often associated with bronchoalveolar cell CA? The current name is, what is the current name of bronchoalveolar cell CA? Adenocarcinoma in situ. Okay. Within the spectrum of the adenocarcinoma. Sorry. Correct. Next question to 3. Group 3. What is the primary function of the programmed cell death protein 1, PD1, receptor in the immune system, and how does it relate to the immunotherapy in lung cancer? Inhibits T cell activation, blocking PD1 enhances anti-tumor immune responses. Correct. Next. To MGM. Okay. Which of the following is a potential side effect of immunotherapy in lung cancer treatment? Question passes -5. From -5. Complex yeah, bonus drug. I mean, they only give the first time. Okay, there is never so +5. This is the next question. Huh? So question goes to A. Okay. What is the primary mechanism of action of anaplastic ALK inhibitors in the treatment of ALK positive NSCLCs? Group A. Suppression of ALK fusion protein signaling. Okay, correct. Give me one name of the drug. Any one name which targets ALK. Huh? Sorry? Ceritinib. Okay. Alectinib, ceritinib. Okay. Fine. Give 5 to both of them. D and D. And give them 10. Okay, so next question is to Group B. Which specific genetic alteration is associated with resistance to both EGFR TKI and chemotherapy in NSCLC? Group B. T790M mutation, correct. Plus 10. Fantastic answer. Next question to C. What is the concept of tumor heterogeneity and how does it impact the treatment of lung cancer? B for Bombay. B for Bombay or D for Delhi? Bombay. Okay. So genetic and phenotypic diversity within a tumor challenges treatment effectiveness. Correct. Plus 10. Group D. In the context of immunotherapy, what is the significance of the term pseudoprogression? Correct. B for Bombay. Huh? Temporary increase in tumor size before a positive response to treatment. Correct. Plus 10. Next question to you. Okay. Which immune checkpoint molecule, when bound to its ligand PD-L1, inhibits T cell activation and is targeted by immunotherapy? PD-L1 Sorry, wrong. -5. Question does not pass. Question does not pass. Answer is, anybody can guess now. B. Okay. Next question to group B. What is the role of liquid biopsy in monitoring minimal residual disease? Circulating tumor DNA with genetic mutations. Fine, correct. Plus 10. Next question is to C. Okay. Which histologic subtype of NSCLC is characterized by a prominent desmoplastic stromal reaction? Wrong? Sorry? Wrong. Desmoplastic reaction sarcomatoid. This is a, very common MCQ. Okay. Next question goes to D. D, na? Okay. So what is the primary mechanism of action of immune checkpoint inhibitors in lung cancer and how does it differ from the traditional chemotherapy? B for Bombay. Enhancing the immune system's ability to recognize and attack cancer cells, non-specific cytotoxicity. Correct. Next, we will go to the A. Which specific chemotherapy agent is commonly used in combination of immunotherapy for first-line treatment of NSCLC, along with immunotherapy, which is the commonest chemotherapy agent? C is gemcitabine. Okay, correct. 10. You're trying. Okay. Question goes to B. Which specific chemotherapy? This is done. Oh no, sorry. The one before. Go quickly. Before. Which specific chemotherapy is it? Oh, sorry, we finished. Sorry, next one. What is the role of neoadjuvant therapy in the management of locally advanced lung cancer and which treatment modalities are typically used in this setting? Chemotherapy and radiation therapy. Fine, correct. Plus 10 next goes to C. Where is the, this is the next question? Huh? Okay, which molecular alteration is associated with the development of resistance to ALK inhibitors in ALK positive NSCLC? Which molecular alteration? D for Delhi. Sure. Okay, fantastic. D. Next question. Which radiological sign is indicative of an air fluid level within a lung cavity, often seen in certain lung cancer complications? To MGM. Which sign we usually see in a lung cavity can also be seen in lung cancer, certain lung cancers? Question passes minus meniscus sign, correct. Plus 5. On a contrast enhanced CT, what vascular pattern is suggestive of locally advanced NSCLC? Which one? Sorry. Sorry. Minus 5. D. Okay, correct. Next question. In a PET CT, what is the significance of flare phenomena following the initiation of radiation therapy for lung cancer? Question 2B. A for America, increased metabolic activity due to treatment response. No. Minus 5. B for Bombay. Sure. Treatment increase, temporary increase in SUV. Yes, fine, correct. Plus 5. Question to C. Which radiological finding is indicative of a paraneoplastic syndrome associated with small cell? Sorry, I could not hear. Brain mets, negative markings. D for enlargement of atrial valve. Okay, correct marks. Right. Next question. In the context of lung cancer screening with the low dose CT, what feature distinguishes a true positive nodule from a false positive nodule? Goes to D. We people were sleeping when we were presenting. This one has been, okay, sorry, I am not passing on because the increase in size over time was glossed over many times during we are presenting. Okay, negative marks 5. Next question. Which imaging modality is most effective for evaluating brain metastasis in lung cancer patient? Goes to team A. Okay, this question is because this is I had got on that question, but this is open to all. Whoever wants to answer the correct answer, but no points. Okay, so we have finished the round of questions in cancer. Do you want to take what is the score now? Thambi, 1 hour I have given you, na? Ade koncho just see, don't. questions. When we start from them, yeah, one would be three would be. Okay. Okay, so when the calculation is going on, the price money as for me, the first price is 10,000. That first price is either 7,000 or 10,000. Second price is either 7,000 or 5,000. Third price is either 5,000 or 6,000. Okay, I have to confirm it. There is a wide gap between these and others. So how much can try to cover something in this? Okay, can I have, so first question goes to Indian. Can I have the, sir, what is the price money? 1075 or 1075? No, we are doing a second round. Question goes to Indian. 75-year-old woman referred to the respiratory clinic by her primary care physician, non-smoker, history of GERD and type 2 diabetes, dry cough for 2 years, progressive dyspnea on exertion in the last 1 year. Concomitantly, she is also having morning stiffness and joint pain in her hands, feet, and ankles over last 2 months. Older brother had last week died from pulmonary fibrosis. On physical examination, SpO2 is 93% in room air, clubbing plus bilateral ventricles. Lab shows hemoglobin 10 grams, leukocyte count 10,000 with 62% neutrophil. ESR is 55. EFT shows FBC of 75%, FEV1 of 77, and the ratio is 86. May I request to please be silent, please, madam, if you don't mind. Thank you. TLC is 70% of the predicted, decibel volume is 70%, and TLCO is 55%. History I will keep for some more time for you people to take it into. Okay, so now I will show the next slide. So this is the CT scan picture and the X-ray picture. So the question is, what will be the appropriate next step for the management of this patient? Do a surgical lung biopsy, refer to transplant, assess for serum autoantibodies, prescribe treatment with cyclophosphamide. I will go back once to the previous slide to have this history slide again. This is the history slide. for another 30 seconds. Go down to the next slide, please. So, your question now. What will be your most appropriate next step? Cervical biopsy or other bronchoscopic lung biopsy, lung transplantation, autoantibodies, cyclophosphamide. C for serum autoantibodies. Why? What do you see in this patient? Give me a gist of this patient.
Has multiple joint pains with chronic stiffness. So it looks like a connective tissue disease.
Her brother has died from interstitial fibrosis. What do you make of that? What does the CT picture look like? What does the CT picture looks like? Anyone wants to take up the CT picture alone? Okay. If you say, I would say only very simple here. So, okay. So the answer is correct. We will take that answer plus 10. But the point here is, so this is a lady of past middle age, history suggestive of a joint affection with high ESR around 55-60 ESR with a connective tissue disease, which is probable UIP picture. Okay, so with this, I would definitely first do a connective tissue disease to rule out. So either RA factor or the other ANA, anti-dsDNA, ENA, all these things he will be ruling out. So that's the serum autoantibodies. Okay. So question goes to team B. We see the upper part, 20-year-old non-smoking individual presented with cough for, it's okay. It's okay. Cough for the past 1 year. He has no other medical problem and does not take any other medications. She reports 3 lower respiratory tract infections in the last year for which antibiotic therapy was given. No history of frequent infections during childhood. Clinical examination, SpO2 is 82 in room air. There is bilateral inspiratory crackles. Rest of the clinical exam is normal. Pulmonary function test, FVC 54, TLC 37%, chest X-ray and CT is this. What is the most appropriate next diagnostic test? What is, I cannot hear. B for Bombay. That's bronchoscopy, lavage for tests. Okay, what is your background of thinking this? What do you think is pulmonary alveolar proteinosis? Okay, and what do you say in the city? Crazy paving pattern is seen other than PV pulmonary alveolar proteinosis, which other conditions? Anything else? Anything else? Guys? No, question is, where do you see crazy paving pattern other than pulmonary alveolar? What is? Sorry? Viral pneumonia. Very good catch. Anything else? Sorry? are imposing alveoli like this. Okay, good. Anything else? Acute interstitial pneumonia, correct. HP. So it's not characteristic of pulmonary alveolar stenosis. Okay, but it looks like that. So, so what is the scenario of this path positive stent? What is the background? What is basically what we are looking for? Foamy macrophages. Foamy macrophages which will be path positive. Granules will be there inside, so that's why path positive stent. Okay, good. So plus 10. Next question goes to C. 41-year-old woman with left-sided pneumothorax, which was drained. Physical examination reveals bilateral papular lesions on the cheek. Family history is unremarkable. Chest CT is like this. Pulmonary function FEV1 is 92%, FVC is 104, ratio is 82, residual volume TLC ratio is 98%. So, what do you feel? Correct? MRI of the kidney. Okay, why do you think so? Tuberous sclerosis. Because why do you think tuberous sclerosis? Sorry? Multiple cystic lesions. Okay. Spontaneous pneumothorax. Okay. Why not the other things? Patient is 41-year-old. Okay. Answer is negative. Not things. This one does not pass on. Okay, let's discuss this. Huh? The actual answer could be FLCN gene. Okay, why? Because this is very the one what you are seeing. This elliptical shape. Okay, this elliptical shape. This is a very characteristic of sorry, grid of tube. Okay, so BHD will be exactly like this. Don't forget this elliptical shape. Okay. Parasector, mostly upper lobes, hardly lower lobe. Whereas when it is tuberous more of lower lobes, there will be multiple different atypical shapes. Okay. Also, ribs of dupe has got lesions in the cheek, papular lesions in the cheek. It happens. Okay. -5. Next, cancer. Okay. 26 years old woman with history of dyspnea on exertion while climbing the stairs. Smoker, 1 cigarette per day. 10 cigarettes per day with a history of 30 pack years. EFT FBC is 94%, FEV1 is 94%, TLC is 107, and DLCO is 57%. Chest eccentricity is like this. What do you feel? So what is your diagnosis? Cystic fibrosis. Anybody else want to put anything in this? Any others? Group A, B, C? Want to say anything else about this? Sorry. Yes. So because you think the PLCO has reduced, but the lung volumes are normal. That's why you think this is CPFE. Okay, good thinking. But what about this? These are very characteristic. Okay, so this is actually Smoking history. Okay, so what is the full name? Langerhans histiocytosis. Very typical. Again, upper lobe fibrillation. These are multiple things. That's why there will be certain pneumothorax. There will be okay, very indistinct, but there will be. So those central of the nodules will become cyst, and then finally they will become a pneumothorax. Okay, so in this kind of scenario, what will be the test? Bronchoalveolar lavage. What to see for? Sorry? LX cells. Okay, so in the bronchoalveolar lavage, we see more than 5% of CD1 and CD207. Okay, so this is very characteristic there. Okay, so that's the answer. So nobody gets point. Yeah, hello. Okay, 5 marks. Okay, so for them -5 plus 5. Question goes to group A. This is one more round, 4 questions, and then we stop. Okay, fine. Next question. 64-year-old male, again, shortness of breath, cough, recurrent chest infections, chest pain, and weight loss. Cardiorespiratory exam is unremarkable. Blood tests are within normal range. PFT shows FEV1 81%, FBC 60%, ratio 85%, TLC is 70, and DLCO is 87. HSC is this. What's the diagnosis? D for Delhi. Okay, neuroparenchymal fibroelastosis. Very good answer. That's our answer. This is again very typical. This is how it looks like. Okay, again, mainly apical upper lobe predominant. There will be more of clone thickening. There will be fibrosis. Patient will be having exertional dyspnea, cough. Occasionally, there can be low grade fever also. Treatment, nothing, only transplant. When things comes down. Okay, next question to you people. So plus 10. 55-year-old woman with progressive dyspnea and non-productive cough, no fever, smoker 10 pack years, stopped smoking 15 years ago, now only taking NSAIDs as needed for rheumatoid arthritis. Her chest CT is this, lung function is FBC 62, FEV1 70, ratio 90, TLC 70, and DLCO is 60. See pulmonary fibrosis with UIP pattern. Okay, so what do you think? What is the diagnosis? Answer is correct, but what is the diagnosis? Diagnosis? RAILD. Okay, almost 70 to 80% of RAILDs will develop in their lifetime lung affections. Mostly they will be UIP pattern, sometimes NSAIP pattern. Okay, what are the other patterns you can see? Any other pattern other than this? These two are the commonest. This makes up 90% or 95%. Rest 5%. OP, that is called. Anything else? There can be extensive NSAIP also. So what are the big 4 markers for UIP, confirmed UIP? Sorry? Honeycombing is number 1. Other than that, exuberant honeycombing. Next, straight line symptoms, sign, anterior upper lobe sign. Anything else? Sorry, 4 corner sign. Okay. Also, there will be traction bronchiectasis, mostly lower lobe prediction. Usually, it will start in one side, but slowly becoming bilateral. But at the beginning, there will be heterogeneity. Okay, and they will be going up to the full. Okay, so UIP and this is RILP. Okay, good. Give 10 marks to them, 5 marks to them. Yes. Next question goes to team C. Okay, 66 years old man with pulmonary sarcoidosis complains about worsening of his dyspnea and cough. In last year, he was treated with steroids, azathioprine and methotrexate without much response. Lung function is getting worse in the last 1 year, decreased FVC from 2.3 liter to 1.9 liter, and decrease in the DLCO from 69 to 53. CT scan reveals irregular reticulation with traction bronchiectasis in the upper lobes. What will be your next recommendation? Refer for lung transplantation. Okay, I have not told you what is the patient saturation. Currently, FVC is 1.9 liter. Patient will not be requiring oxygen for us. 1.9 liter is enough dose. Okay, it doesn't need lung transplant. Answer is wrong. Answer is needed. Okay, yes. Now, FDA has recommended for fibrosing of progressive disease for sarcoidosis, you should give internet. It's a current recommendation. Okay. -5 +10. Sorry, -5 +5. Last question to team D. This is a good question. 54-year-old female presented with this abnormal chest CT scan with a history of 15 pack years smoking. Patient had quit smoking 3 weeks ago, feels healthy and is now not coughing, regularly plays tennis and goes jogging without feeling dyspneic. 2 uncles and one of her 2 sons suffer from epilepsy. Vital signs, heart and lung auscultation is normal. PFT are normal. What is the investigation you would like to do now? Say something. ESC and PS2 mutation analysis. So your diagnosis is? Anybody thinks anything else? Anybody thinks anything else? No? Okay, this is cutaneous fibroma. Okay. Very critical. These are obviously small, almost uniform shaped, slightly deformed. There is not complete design, right? Very small cysts bearing the lower parts. Female. Lamb. Okay. So the answer will be lamb. Okay. So what will you do in abdominal breathing? Okay. So for lamb, there will be occasionally there can be what kind of pleural effusion happens with lung? Chylothorax. So occasionally there can be chylus also. So this is lamp around middle-aged female with this kind of small cysts with some facial changes, abdominal imaging to see whether there is any malignancy, renal malignancies are there or not. Okay. Treatment for lamp. First then okay, -5 plus 3. Lucky drop gift. Choose. Then that will lucky drop gift to who will come. Next, close your eyes. Okay, the first one is Dr. A. Sundarmurthy. Dr. Ajay Maximum. I take Dr. Vanchi. Okay, if I cannot read, sir. Okay, what I cannot read, answer. Dr. Gokula Kannan. Dr. Manivaran. Alex. Kumar. Dr. Kevin. Dr. Sindura. Sri Devi.
Thank you. Yeah. Please, yeah. First, second, third, okay.
Thank you. Long time.
So anyone want to talk? Is that time he makes the calculation 1 minute? What you have learned? Anybody? So, you and see all these different 60 features. What more? Which one has got what kind of features? Okay? Some more we jot up.
Our next class will be on past third. This is about sleep medicine, past sleep medicine. As a to all. So we have the same kind of we have workshop on polysomnography, workshop on fact therapy, and we have registration with the ED the pulmonologist and the psychiatrist, variant surgeons, all types of surgeons. So in the case of OSC, there is a multiple. They have very good registration. Everything is there. Past third. Sunday morning 10 o'clock, evening 4 o'clock. There will only be a sleep lab, level 1 sleep lab per center. So to commemorate the World Sleep Day, which falls on March. March month is the World Sleep Day Awareness Month. They will do the sleep lab opening and this sleep master. And this we'll put all the first announcement everything. I will shortly all the practice. Thank you.
Yeah, which 35 plus 0. Or 5,000. Yeah, hello, how can this find? So, here, points are 20 plus 45, 65. So, MMC is 65, second is come. So, first slide is they have done this today from -5, but in the first one they made 85, so it's meaning for so
Request Tila ma'am, thank you. Tila ma'am? Yes. Thank you, Roy, for this. Thank you. Thank you all, right?
Yeah.
faculty and distinguished guests and National Medical Knowledge Partner for contributing to the success of lung cancer innovation and lung cancer transplant. Thank you all for attending.